I'm Kathy Martin. I work for the Community Development and Health Network. We're a regional organisation in Northern Ireland and we support our members with their community development practice and their health inequalities work. Building the Community Pharmacy Partnership Programme is a long-established community development project with a focus on tackling health inequalities. We've been managing the programme for the last 23 years and we've developed and supported over 1,060 individual BCPP projects. Each BCPP project is a three-way partnership between a local community and voluntary organisation, community pharmacist and a small group of local people. To facilitate partnership working and encourage local activities, each project's allocated £12,000 in funding, and over the last 23 years we've invested £7.5 million directly into disadvantaged rural and urban communities across Northern Ireland. Following the BCPP model, they work together to identify local needs, and using a community development approach, they utilise local assets and co-design solutions. So it's very much a bottom-up approach.
My name is Evan Reid. I'm a pharmacist in a local community in co-ordinated. And I've been involved with BCPP for quite a number of years, and I've just sort of seen how it's good to be connected with the community in which I've been placed. The project can either be like a 6-week project or a 12-week project, and the idea of it is that we collaborate with other community groups within our area, the like of CRUN, and we engage with their attendees and just try and educate them in health. But you want to do it in a way that's fun and innovative. So for example, one of the projects we did, we wanted to teach them about 5 a day. And okay, you could have a lecture on 5 a day and the benefits of fruit and veg, but we took them to a grow project where there was polytunnels and we picked fruit and veg, and then we shelled peas together, and it's amazing what you can talk about when you're shelling peas with someone. And we just made smoothies. And so all of a sudden, an education becomes a life experience. And we found that so beneficial. You're stepping out into the community in which you're placed. You're coming out from behind the dispensary. You're engaging with people where they're at, and you're hearing actually what is going on in their day-to-day. And so the privilege that that gives of really hearing of their real health stories and how you can speak into that and how they see that perceived barrier of professional and patient broken down, and they put their trust in you. And actually individuals who maybe would otherwise have not come into the pharmacy actually come in because I've spent time with them. And it's amazing what those conversations and those interactions can lead to. So it's been a huge privilege. Pharmacy is, for so many individuals, the first stop for their care. And it allows them to come into an environment that is professional, but yet also welcoming, without any barrier of accessing that healthcare and that healthcare service. And so many more services are being offered within pharmacy, be it from minor ailments to travel vaccinations. And it's knowing and being able to put your trust in what's available within the pharmacy and how beneficial that is for the folks in the community.
Lorna O'Neill, and I am part of Causeway Rural and Durban Network, and we are traditionally a community development organisation based in Coleraine, up in the north coast, and we've been in existence for over 20 years. So just more recently we became a member of the Healthy Living Centre Alliance, so we would promote projects to do with health and wellbeing for our local communities. So about 5 years ago we engaged with CDHN and were involved in the Building Community and Pharmacy Partnership, and we think it's a great fit for our organisation. Because we are a community network, our roots are in community development, so we work with individuals kind of from the bottom up, so we're grassroots. So we have the connections within the community over the last several years. So we bring people together who we've identified that may need some support with their health and wellbeing, and we bring them through the community pharmacy programme. It builds their confidence and ability to go out then on their own and find support that they may need. And with our guidance, we can point them in the right direction. Really, it's about making sure people are aware of what's available, and having the confidence and the ability to go and access that on your own. Because we work in the community, we take referrals from healthcare professionals and from community partners, community ambassadors, so it may be people who are on the margins of society or find it difficult to engage in mainstream services. So we find people that come in at the beginning who are very shy, socially awkward, and maybe just find everyday things that we would take for granted more of a challenge. So we find that bringing them in a group with other people who may also have those difficulties and learning together and using their knowledge as well, because if somebody has already accessed something and they can share that, it gives them a strength and to be something to be proud of that they have been able to access that on their own. So what we find is that people in that group, it gives them that kind of push to go a bit further when they're doing it with somebody else who have the same barriers and same difficulties. So for us as well, it helps build a connection with the pharmacist. So we're learning all the time, improving our health literacy, and we have our fingers on the pulse and know what's happening, what new groups are about, what new services and supports are available. So we can always be up to date with our knowledge and help people on their wellbeing journey.
Impact's a really important part of the work for us. So we evaluate every single BCPP project individually, and then we aggregate that up to understand the impact at a regional level. So we're currently writing an impact report on 2 years of the data, and what we're seeing in that is really the importance of the relationship building. So seeing the model coming through and the impact that that has in local communities. So in particular, the building up of social capital in local communities, the opportunity for people to make friendships, to engage and build relationships with the pharmacist, and to really cement relationships in their local communities, seeing how that all comes together.
So, welcome everybody. I hope you're invigorated and ready for day 2 of your 3-day marathon around integrated care. And welcome to this, the second plenary session, where we're going to be exploring partnerships, collaborations, and new alliances with a really fantastic panel. Before I hand over to my co-chair, Dr. Michelle Nelson, an introduction to myself. For those of you who don't already know me, I'm Niamh Lennox-Tugani, and I'm the Chief Executive of the Foundation. So you'll see on the stage, as well as our illustrious panelists this morning, some really fantastic artwork. And I wanted to tell you a little bit about this artwork before we start. So I was having a conversation this morning with Jonathan McRae, who's from Brain Injury Matters, and he was telling me about some work that's going on around language and the language of inclusion, which I think is really important to share with you this morning and to position us really for the conversation we're going to have for the rest of this morning. So many of us are familiar with the UN Convention on the Rights of Persons with a Disability. The UN Commission on the Rights of Disabled People has given permission for a social model of language to be used. And what this means is a shift from persons with disability, as if they own the disability, they hold the responsibility, to disabled persons, recognizing actually that persons are disabled not just by their impairment, but by society, that we all have a role to play in disability. So some disability rights movements might still choose to use the person-first language. The permission has been granted for a variety of language to be used. And this is something really huge in the disability rights movement. And I have to name check here our board member, Jackie Brown. She would probably never forgive me if I didn't, because she has been really active in this space as well in her career. So coming to the beautiful artworks that we see here with us today, Article 30 of the Convention states that people should have the opportunity to develop and utilize their creative, artistic, and intellectual potential, not only for their own benefit, but also the enrichment of society. So the artworks on the stage behind us are by creatives at Brain Injury Matters and are an example of the human rights-based practice in practice. And I think that's something really important for us to bear in mind throughout the discussion that we have this morning. And without further ado, I'm going to hand over to my co-chair, Michelle.
Thanks, Nate. Good morning, old friends, new friends, soon-to-be friends. You're witnessing a never event. I've actually talked so much yesterday that I've lost my voice, which I was just saying to Anya. I haven't even, obviously I didn't go to the Blarney Stone, perhaps I should have before the conference, but I think it's an indication of the value of this meeting. And it feels like a bit like a homecoming, so for those of you that are repeating, I hope you have that feeling. For those that are new, I hope you sense that, and next year you get that feeling when you come back. And I think it's an indication of, I'm hoping that you spend the next 2 days talking so much with like-minded colleagues that you also go home having lost your voice. And you can tell people that you actually enjoyed the conference so much that you've talked your voice out. So if we could make that an aim. The session today should spark conversation. We've convened an expert, and we've asked them to be provocative panel. We're going to let them introduce themselves so they can emphasize the component of their background that they feel is most applicable to the conversation today. But really, we wanted to start with, we want people to leave this session engaging in new ways of thinking, challenging the status quo, thinking about how do we move to new alliances? What does new alliances look like? And linking to the work that you're doing and linking to the topics of today. So I encourage you to look through the program. There are at least 2 places that alliances are in the title of the sessions. And so if you're interested in thinking about new ways of being to new ways of doing, there are places in the program specifically designed to convene that. Further, Neve and I have talked a lot about creating a space, and we've decided that for the next year we want to convene as a proof of concept, a space specifically designed to engage in provocative conversations about new alliances. What does new alliances mean? What does it look like? How do we engage in it? How do we convene people who want to work this way? And so for the next year, as a testing ground, we're going to start a special interest group around new alliances. And the function is meant to serve both as a place for individuals, but also a place for SIG, other special interest group leaders. So if there's, you will see something come out related to that. But in the meantime, think about how you might want to engage in that conversation and what that group could do to help you move this through in your work. As I said, we've asked our panelists, our esteemed panelists, to be provocative, but they are not a sage on the stage. Their job is to spark conversation for all of us. There's 1,200 people at this conference, the opportunity for them to spark conversation for us and take it home. I'm going to leave it there, and I'm going to pass it over to our first speaker. Adam Lent is going to introduce himself, and then he is going to kick us off thinking provocatively about new ways of partnership and how we may need to give up, be different, to do different. Thank you.
Hi everyone, real pleasure to be here. There may be 1 or 2 very unfortunate people in the audience who've never heard of the marvellous organisation which I work for. It's New Local. It's a peer learning network of around about 70 councils and health sector bodies across the country, focused on peer learning and committed to innovation, transformation in the area of public services. We do loads of research and influencing and other things alongside that. I'm going to start with a question that might seem pretty basic, really, for the International Conference on Integrated Care, which is, why is integration so important? You all know why integration is important. That's why you're here. You all believe in integration. You know why you want to do more of it. We know that it provides better outcomes for the people we serve. It prevents duplication. It even saves money. But I actually think there's an even more and newer pressing issue as to why integration is so important. And that is because in the bigger picture, I think we're entering really a very different era in human affairs, one that is characterized by crisis. The days when we could rely on stable economic growth, an environment that wasn't increasingly hostile to normal human activity, to a general sense that most people were well rather than unwell, that time has gone, in my view. We are in an era of what some people are calling a perma-crisis. And of course, underlying all of that is the environmental challenges we face, which are not about to go away or be resolved anytime soon. And that will have massive implications for our politics, our economy, and of course, our health and well-being. If you're in an era of crisis, it has two really troubling and challenging impacts that are fundamentally linked. One is that the challenges you face as a society, as a public sector, intensify. Of course they do. Crises inevitably intensify the challenges you face. But at the same time, what crises do is they actually shrink the resources you have to meet those challenges. So the bad news, unfortunately, is that that sort of vice-like grip that so much of the public sector has been in for the last 10 to 15 years because of austerity, rising challenges and shrinking resources is probably only going to intensify over coming years. Why does that matter for integration? It matters because basically what it tells us is that no single public sector institution on its own can meet those challenges sufficiently. The challenges are too formidable and the resources are too limited for any single public sector body to meet that perma-crisis alone. So obviously, as public sector institutions in a locality, in a region, even across a whole country, we need to pool our resources. We need to work together. We need to use the shared intelligence, insight, understanding that we can all bring through integration and working together. But, and this is the big but, even if we had perfect integration, even if we had every public sector body working together in an incredibly smooth and efficient and impactful way, try and imagine that, even if we were doing that, it still wouldn't be enough. I still think the challenges we face are so great that we actually need to augment the limited resource we have with something much wider. And that is the resources that exist within the communities we work within. There is a huge untapped energy and insight and set of assets within our communities that within the public sector, even if we were fully integrated as institutions, as professions, we need to get far better at mobilising and using to meet the challenges we face and augment our limited resources. At New Local, we call that community power. And one of the great things that has come out, particularly out of the pandemic, tragic as it was, is a real openness and understanding of how powerful mobilised communities can be to meet challenges that we face. And so we see community power beginning to gather pace, particularly in local government across the UK, but also increasingly in the NHS and in other services as well. And we see in the work that we do at New Local 3 key routes or changes, if you like, that public sector organisations are making to allow them to become far better at mobilising that resource, those assets that exist in their community. And I'll just talk briefly through the 3 of those before finishing. The first is about the way decisions are taken. It's about moving away from a model that thinks that decisions within public sector organisations have to be made essentially by the most senior officers or elected officials, whoever it is, within the public sector organisation, a sort of institutional mindset that sees decisions as something taken by the institution itself. And moving to a model that is much more open, much more participatory, that really brings the community, whether that's residents, patients, whatever it is, into the decision-making process. So they can share their insight, they can share their intelligence, and also that interface, that participation, actually becomes a space and an opportunity to mobilise, to excite, to get people engaged with meeting challenges themselves. So if you go onto the New Local website, you'll find, for example, a case study of a council down in the south of England called Test Valley that has completely rethought the way they engage with their communities. They've put participation, deliberation, consensus building at the heart of everything they do. Truly transformational. The second route is actually about the way services are delivered. So moving away from a view that sees services as something that is delivered solely by the institution, towards seeing services as something that are delivered in collaboration with communities. And there's loads of really interesting examples of this taking off across the country. Again, on our website, or more generally, you can find loads of those, but I'll just give you one that has generated an enormous amount of interest in the public sector in the UK, is a physiotherapy team in Sussex, in England, have completely rethought the way that they deliver physiotherapy services, moving away as much as possible from a traditional way of sort of seeing individual patients one by one, a sort of an incredibly long list behind that. They had waiting times of 16 weeks just to see, get an initial consultation with the physiotherapist. They moved to using what they call community appointment days, where they bring everyone on the waiting list together at one point to meet with a physiotherapist, have a strengths-based conversation, not a traditional medical consultation, and then have the opportunity on the day to link up with community support, charities, all sorts of support networks and social capital that is present in that space at that time to support people. And they've had huge impact through doing that on people's health and well-being, but they've also managed to cut their waiting times down to single figures from 16 weeks just by holding these community appointment days. So again, really thinking about that service as not something that's just for the clinician, but something for the clinician working in collaboration with the wider community. And then the final route is the one that everyone tells us is the most significant, is about organisational culture. Moving away from a we know best type mindset, which has been sort of infused into the public sector over the last 7 or 8 decades, to a different mindset that says, if we face a challenge, if we face a problem, if we're trying to think about how we do things differently, let's start out there in the community. Let's assume the answer, the solution, is out there in the people we are serving, rather than thinking the answer to the problem is always in here in the institution amongst the professionals and the experts. And you can look at loads of places like Wigan Council, East Ayrshire Council in Scotland, or many of you may know about Healthier Fleetwood, amazing primary care initiative in the northwest of England there, that really has, all the changes there have come out of encouraging the workforce, the people who work in those areas, to think fundamentally differently how they go about their job. So the final thing I would just say is that obviously you know that we've been talking about integration and about moving to much more community-led services for many years now. But I think we're at the point now where we really have to just stop talking about it. The crises we face are so formidable, the resources so limited, that now we really actually have to do it, and we have to do it in a community-powered way. Thanks a lot.
Good morning, everybody. My name is Jennifer Welsh, and I'm the Chief Executive of the Northern Health and Social Care Trust here in Northern Ireland. And I'm delighted to be able to join the panel here today, and thank you very much for the invitation. I hope you're all enjoying the Belfast hospitality, and you're enjoying that as much as the sessions as we go across over the next few days. So I've been asked to talk about partnerships, collaborations and new alliances. And I'm going to do that by talking about a little bit of work that we took forward in my organisation along with all of our partners. And it began back in around 2018. So to do that, I think I need to share a little bit of the structure of health and social care as it was then back in 2018. So apologies to the locals who know all of this. Obviously we have the ministerial level, and then we have the Department of Health setting policy and strategy for Northern Ireland. At that time we had the Health and Social Care Board and the Public Health Agency, and the former board did much and most actually of the commissioning and the contracting of services. So they commissioned services directly from 6 trusts. 5 of these are health and social care trusts. One is the organisation that I run, and the 6th being the Northern Ireland Ambulance Service. And they also contracted services for general practice, for community dentistry, community pharmacy, and so on. And then in turn, the trusts, we also procured services. So I would purchase services from home care providers, from nursing homes and from residential homes, and so on. So just a little bit about the trusts. As I say, there are 5 geographical trusts, imaginatively named Northern, Western, Southern, Southeastern and Belfast, which provides most of the regional services for Northern Ireland. And really, we cover the full range of services that you would expect from health and social care. So it covers acute hospitals for adults and children, emergency, urgent and elective work. It covers our community services, so things like our district nursing and so on, our community allied health professionals. It covers social work and social care, which is something I think probably different from a lot of other jurisdictions. So our adult social work and social care and our children's services sit within our organisations as well. So things like gateway services, family support and intervention teams, and looked after children. So I and my colleagues are corporate parents to now about 600 children. We also provide mental health and learning disability services on both an inpatient and community basis. So we are already quite an integrated system compared to many other areas. But what was the space that we wanted to move into? So back to the slide on the left, just briefly. And it harks back to what Adam said earlier. We realised that actually we couldn't do this alone. No organisation could tackle the challenges that we were facing on their own. The other thing that we were realising was that at a geographical level, at a local level, I was delivering on commissioned services. Our GP colleagues were contracted to deliver the services that they were delivering. And actually, when we came together, we realised we were doing some contradictory and sometimes conflicting things because they had been commissioned and contracted through different arrangements. So we realised, actually, we're going to have to come together to do this differently and better. So it's in that space with the red oval. This wasn't mandated. This wasn't something that we were told that we had to do, but we realised we're going to have to do something differently. So it was a coalition of the willing rather than anything in legislation at that time. And what we tried to move to was the image on the right. We created, over time, a formal trust and general practice provider partnership. That's about a half-hour talk in its own right. But suffice to say, we're a very large organisation in the trust. We were trying to work across about 72 different GP practices, 320 GPs. There was naturally a little bit of tension and concern at the start that this big behemoth of an organisation, as it was described to me in terms of the trust, and were we really wanting to partner properly with general practice? Did we want to come and take over? There was a fair bit of suspicion. But over time, we grew those relationships. The GPs had also organised themselves into 4 federations. So one trust working with 4 federations makes the balance a little bit more reasonable. But we also knew that we had to be in and part of our community, and that's why you see the structure around it, which we also established, the Northern Area Network, working across all of our stakeholders. So the community and voluntary sector, the community themselves, other partners such as community pharmacy, community dentistry, our local councils, and there's 4 in my area, and I'm sure David will talk later on about the council's role in community planning. All of us coming together to look at how could we do things a little bit differently for our community and our population. So speaking about our population, what were some of the challenges that we actually faced? What were the needs of our population? And you can see some of the statistics up there. So 14% of expectant mothers smoked, and that was actually 25% in the most deprived areas, so really not giving our children the best start in life. At that stage, we had about 467 children on the Child Protection Register. That has risen quite dramatically, and we saw it particularly during the COVID pandemic. And a couple of the others that I will pick out. 68% of adults in the northern area are overweight or obese. So many of them are pre-diabetic. It's the highest level in Northern Ireland. It remains the highest level in Northern Ireland. And about 22,000 people already diabetic, and that had seen a significant rise in the previous 5 years. So that, along with cardiovascular disease and the fact that we had a significantly older population compared to a lot of our neighbouring trusts, those were the areas that we really wanted to focus on. And some of our aims there were at the bottom, work arising out of the IHI work, originally the triple aim, then the quadruple aim, and now the quintuple aim. And it would be very easy to talk about lack and what we don't have. We were all struggling financially. We were all running on deficits. We were all struggling in relation to our workforce and significant gaps. And we wanted to try and change our thinking in terms of what we didn't have to what we did have. What were the shared assets? And you could see some of them together. A population at that time of about 470,000. And in the trust itself, 12,000 staff that we could mobilise. 12,000 staff, most of whom lived in the community and were very much part of the community. As I say, the GPs had organised themselves into 4 GP federations, so a stronger voice, aligned to each locality where there was already an integrated care partnership, a locality which is how we had divided out our community services, trying to make contiguous boundaries at a very local level. So what were the shared assets whenever we came together? And how would we organise ourselves to try and work in a different way? So we put together a management structure. It didn't start like this. It started as a very loose coalition, but we tried to bring some structure around it, partly because we were trying to convince the Department of Health and the Health and Social Care Board that actually we're really serious about what we're doing here and we know we want to do this properly, and partly because we wanted to secure some money to run some pilot studies as well, which did work. So as you see there, we had 4 different work streams to actually help us to build this system, which we by this stage were calling the Northern Area Prototype. So a prototype for further integration of all of our health and social care services. We had 1 work stream to enable this system, and a big part of that was actually looking at the data analytics, Really, truly looking at your population and the needs of your population and having the data supporting that analysis is so crucial. And then a work stream to actually test this system. It's all very well having all of this in theory, but actually in terms of us coming together, the big difference was working together to make a difference. And based on what we knew about the challenges of our population, where were the areas we wanted to focus? So we focused in on diabetes, on frailty, and also on musculoskeletal conditions, because that was the main presenting thing to general practice at that time. So, a little bit of how did we start to go about this? Now, it took time for us to be able to develop a slide like this, and that was after quite a bit of work and trying to bring quality improvement methodologies to what it was that we did. But if I talk about the bottom line first of all, and where some of the real challenges were, 23% of all the bed days in our acute hospitals, so I have 2 acute hospitals in my patch, were for patients over 85 years of age. So that's over 100 acute beds at any time being occupied by a person 85 or over. And is that actually the best way to look after that section of our population? We had over 3,000 annual attendants at our emergency departments each year, just from nursing and care homes. Again, crowded emergency departments, is that the best care that we could be giving for our people? So what we wanted to do was to aim to reduce the number of bed days for the frail elderly and to try and put in place some services that would support them in a different way. And I'm just going to lift out one area that I'm going to talk about. So one of the areas that we looked at was anticipatory care. So what does that mean? We wanted to have something that was really shifting from a reactive service to something that was proactive and based on what people actually needed. So we brought a team together, which was general practice, it was community nursing, it was our social workers, it was all of our allied health professionals, and it was dentistry as well. And what we did, with agreement from all the GPs in an area, we took 3 pilot homes and we agreed that there would be 1 GP who would be the lead for each home. It had to be agreed with all GP partners, because if you have a nursing or a care home, you could have 40 or 50 residents. Each one will have their own GP. So you could have maybe 10 different GPs aligned to a particular care home. But we all agreed there would be 1 lead GP or 1 lead team. And that individual, along with one of our nurses, did a proactive ward round of that care home or nursing home to look at what was going on with an individual and to try and anticipate their needs. And that might have meant an immediate referral to social work. It might have needed support in from community occupational therapy. It might have needed dentistry support. It might have needed physiotherapy support. Or maybe the individual needed direct access into some of our hospital services. And as you see here, the results really speak for themselves. The ED attendances from those homes during the period of the pilot dropped by 24%. That was quite staggering. We didn't expect it even to be as high as that. Over the course of a year, the ambulance journeys from just those homes dropped by 144, which was incredible. The repeat ED attendances were down by 58, and the admissions to our Causeway Hospital were down 18%. Those are really staggering results. But actually, one of the things for us as we were going along was we could see this working. We could see that in working together in a different way, this was actually making a difference. But the feedback that we were getting from the residents of those homes and from their families was fantastic. And that was the thing that really spurred us on, that we were doing the right thing. So this just gives you a little bit of information of where we'd got to by early 2020. And we all know what happened in 2020, which curtailed some of our plans a little bit. But by that stage, we had built an effective partnership between the Trust and between general practice. And it really created a real momentum for positive change. By this stage, we were working well together, we knew each other well, and we trusted each other. We had proposed and we had part tested a model for further integration. And you heard Sharon talking about the new integrated care system for Northern Ireland, which is now being piloted in the southern area and which we're all going to be rolling out in shadow form quite soon. We created a methodology for co-producing a population health management plan, and that's something that can be rolled out everywhere. We developed the data analytics that again could be shared across Northern Ireland that had informed some of our work. And we provided that early testing of some of our new models, diabetes being an example. So some of that early work that we did on diabetes has become the new diabetes model for integrated care that you heard some of my colleagues presenting on yesterday in session 2B, Joanne McKissick and Hamish Courtney. So we're very proud to have been involved in that as well. And as I say, 2020 brought us all into a very difficult time. So the prototype, as it was, had to be stood down because obviously we were all responding to the COVID pandemic. But actually the work that we had done over the preceding couple of years really stood us in very good stead, and we continued to work closely together throughout that very difficult time. We shared premises to enable GPs to get early testing centres up and running. We worked together to try and support nursing and care homes in our area that were really struggling. From a hospital perspective, we shifted more of our services to direct access because people were still getting sick from many other things as well as COVID. So to enable our GPs to have direct access into some of the services that they needed. I'd mentioned the new model for diabetes and just some of the other things that we continue to do in partnership with many other people out beyond our GP colleagues as well. We have a Farm Families Health Check programme that's actually been running for about 10 years now. This is a great partnership with the Public Health Agency. And just linking through to what Adam said, this is very much about our community. We're a very large rural trust as well as having the two big hospitals. But a lot of our people, about 40% of our population, live in very rural areas, and a lot of them are from farming backgrounds. So this was about going to them, taking services to them in relation to the health checks that they would need, and this has been hugely successful. And we now provide this programme for all of Northern Ireland and not just the Northern Trust area. Causeway Healthy Kids is a wonderful partnership between ourselves and Causeway Coast and Glens Council and a number of primary schools in the area, all very much aimed at giving children the best start in life and teaching them early about being healthy, about good food and nutrition, and about exercise as well. And we're continuing to work closely with our GPs on a range of things like how could we do better on palliative and end-of-life care in the community? How do we support each other to do that better? And given that general practice is in such crisis everywhere, one of the things that we've been doing together is working on GP portfolio careers. So offering people things like sessions within our direct assessment units or indeed in our mental health services in an attempt to make general practice more attractive because you've got other outlets as well. And I'm going to leave you with some final thoughts around the keys to success for partnerships and collaborations and new alliances. This is very much a shared purpose, as Adam had said. We were not going to be able to solve the problems on our own. None of us had enough money to do this on our own. But what if we looked at our shared assets differently and it had shared purpose based around the needs of our population? There had to be parity and balance in the relationship, and that took time. And if you've got one very large organisation like a trust, it can be difficult to convince others that you're actually serious about wanting to do partnership and have an equal partnership. And it is about trust, not trust the organisation, but whether or not we trust each other. And that came through actually working together. There are no shortcuts to any of this. It takes time to get to know each other. It takes longer to trust each other. But my goodness, it's worth it. Thank you.
Thank you. Thank you so very much, Adam and Jennifer, for kicking off our conversation about the why and the how of new alliances and partnerships. And we're going to build on the shared intelligence, expertise, and shared learning opportunities with a panel discussion. I want to point out, if people aren't aware, that Neve is going to monitor the Q&A in the app. So if things have popped up for you, or there's questions arising, or if you're in our virtual virtual participation option. If you put your questions in, we are able to moderate those as well. So this is meant to be a shared and common learning experience, so please take advantage of that opportunity. We're going to turn to building on shared intelligence expertise. We're going to turn to our panel discussion. We have one prepared starting question and then some things that probably have arose from the conversation. So I'm going to pose the question and then I'm going to pass to the panelists. They'll introduce themselves and then respond to the question. So the question is, based on the perspective that you're coming to this conversation, what makes collaborating or forming new alliances either work or not? And I'm going to flag for those that were in the room yesterday, there was an interesting comment and conversation about healthcare systems are not self-organizing. And I paid particular attention to that because often when we're forming new alliances with community, we're working with community members or organizations that are in fact self-organizing. And so what makes your work, or what have you seen be successful or challenging around forming new alliances and partnerships? Ellen, I'll pass to you.
Thank you very much. Hi everyone, I'm Ellen Rule. I'm Deputy Chief Executive and Director of Strategy and Transformation for Gloucestershire Integrated Care Board. And it's really great to be here today. Thank you for having me. And really inspiring to hear those first two opening talks. And I was thinking and making some notes while our colleagues were talking. And I thought what I would like to draw out today to share with you, because there are so many examples that I could think of, but actually I wanted to lean into the example around the experiences we've had working with our voluntary and community sector partners in Gloucestershire. And one thing really struck me in the last talk where you mentioned about the different weight of kind of power in the relationship and how that can feel when you're coming together to collaborate. And I think that differential is really, really significant actually when you're working with VCSE partners. So we reflected on that in Gloucestershire, and this is something that's been quite a long time project and certainly not one that I would describe as complete. But to share some of the steps that we've taken. So we are an organisation that commissions around about £1.6 billion worth of services for our population of about 670,000. So we're pretty big when you take us in that context. So when we come to work with our VCSE partners, they're often very small organisations. Not all, some are national organisations like IJIC and so on with presence in our county, but many are small, and even within that sector you have that differential. So we invested approximately about £200,000 in VCSE infrastructure building. So we invested in some actual management time for them to work within their VCSE alliance that's based within the county. And we've supported that with our own management time as well. And that's a really practical level, supporting them to come together to network and to have one voice and to have the tools to engage with us. We've also worked on a memorandum of understanding between ourselves and our VCSE alliance about how we will work in partnership together. And we've developed a sort of short form grant agreement, because NHS contracts, if anyone's ever had the joy of working with those, are quite large and tend to be very complex for lots of good reasons about accountability for public resources and safeguarding our population. But actually even just accessing those can be a barrier to VCSE partners working with us in service delivery. So we've developed a sort of short form version of that and also put real management time and resources into helping partners to work with us to fill in the documentation, the forms, the applications and so on that we require for good stewardship, but which can make it difficult, otherwise the bar to entry can be too high. So I think you only wanted me to talk for about 3 minutes, but what I would share, because I could probably talk for quite a lot longer on this topic because I'm very passionate about it, but we have some really fantastic examples of where that has led to partnership and co-production of some really innovative service models where we've come together as the NHS and VCSE partnership and with our patients to co-design new ways of working in our county. We've also invested some other sort of chunks of money, around about 1.2 million so far, in some of our locality partnership projects. I think some of my colleagues shared some of these yesterday, if any of you attended that talk. And again, that's been tremendously enabling. And one of the really important factors in that, in terms of one of the questions about what do you need to do differently as the overarching responsible body, is that you need to cede some control and you need to trust people to come up with solutions. So you need to release resources without there perhaps, I know, gosh, there being a definite plan or definite objectives, and you need to trust them to be able to iterate and use that money and then to come back and share with what they've done. And that has been tremendously enabling. And I would say that for our Integrated Care Board, some of our colleagues are still really struggling with that concept. We've just been in the planning round and I've heard people say, well, we can't fund that because there's not a clear outcome and there's no business case. So I'm not saying we've totally cracked that, by the way, but I think that's a really important reflection. And we do have some very strong advocates of no, we need to release, we need to let go, we need to cede some control. And the very final thing I will share is that actually with some of these smaller pots where we have resourced into our VCSE sector, the NHS is a powerful advocate and sort of support when it comes to these organisations bidding themselves then for onwards funding. So for example, one organisation we work with called Active Gloucestershire, who are very much embedded in communities around health, wellbeing, getting people activated to take part in exercise. We've given them approximately £50,000, I think. But by having our presence on a bid, they successfully got £750,000 worth of national money. I have a number of other examples of this, and it isn't all about the money, but my goodness, that is a tremendous asset for Gloucestershire to have coming in to support our population. Thank you.
Thank you. You've sparked several questions in your opening comments, so we'll come back to those. Thank you. David.
Thank you very much. Good morning. I'm David Burns. I'm the Chief Executive of Lisburn and Castlereagh City Council and also the Chair of Solace in Northern Ireland. So Lisburn and Castlereagh City Council is a council with a population of roughly 150,000, and we give a big warm hug round the southern end of Belfast in terms of our location here in Northern Ireland. My role in Solace as chair is Solace basically brings together the chief executives of the 11 councils in Northern Ireland with a view to seeking opportunities for coordination and consistency in our approach to very topical issues. Councils here in Northern Ireland differ much from the councils in the mainland in that we don't have health, education, housing or roads. So as the most local form of governance, we're often seen as the glue. We're seen as the glue that connects, coordinates and facilitates all of those organisations that work within our local communities. Jennifer mentioned earlier on about community planning. Community planning was legislation introduced in 2014 to bring the statutory partners together with the voluntary sector to make a change within our communities. So it brought together housing, health, education, economy, councils, the fire service, the police service, ambulance service, all with a view to making change for communities. The part of the legislation that was missing was the involvement of communities in that community plan. So there is a challenge for us for the future. But the role of community planning was to look at health, poverty, well-being, income and employment. So each and every council area has a community plan to oversee it. In terms of the question, just relating to collaboration and does it work or not work, I was speaking at a community planning conference recently and I was saying that the silo stuff is the easy bit. It's easy for me to lift the bins, it's easy for me to maintain the parks. The challenging bit is when I have to build up those relationships with other parties. How do I do it to the maximum impact to make a change for the people that we're here to serve? Culturally, I find that the focus of many of our organisations is on what we have to do ourselves rather than our people. Our council vision is to provide and deliver better services for the people that live, work and visit our area. And I think everybody needs to be bought into that. In terms of meeting local needs, and maybe just to give an example of change, I've been in this role now for about 5 years. And when I first came over, I went out and visited most of the community groups that existed, the larger community groups that existed in our area. And every single one of them said they wanted a community centre. And I'm totting this up in my head, and I'm going, right, that's 11 I've seen. That's roughly £22 million of capital money I need, and probably about £1 million just to actually run those facilities on a revenue basis thereafter. There was never going to be the possibility of our elected members agreeing to it. So we started to explore through a community planning approach whether we could provide funding to these groups of a limited amount that actually encouraged the groups themselves to go and raise money to deliver their aspirations. And that started to sort out those that were serious about it in comparison to those that were just asking. So that's the journey that we're on within Lisburn Castlereagh. And each of the councils across the council area, across Northern Ireland are doing similar in terms of how we work and collaborate for the better. Thank you.
Good morning, everybody. My name is Hilde de Nutte. I work for an umbrella organization of hospitals in the Flemish part of Belgium. We also represent specialized mental care and nursing homes, so collaboration and partnerships are a big issue in our organization. I want to come back on the presentations of Adam and Jennifer. Jennifer, thank you very much for those nice examples. And I also want to come back on the 3 key messages of Adam. They are really a good thing to start with, because we see really a gap between the communities and the healthcare, especially the hospitals. There is a need of collaboration because of economic purposes, but also workforce. That's really very important now. We are heading an infarction, I think, and we need to collaborate to prevent double work, to work more efficient. But when I go back to the hospitals, because I want to give some reflections in the point of view of the hospitals, then I see that they want to, every time they want to take the lead in that thing. And it doesn't work, because there is a lot of resistance. You must start from equality from the partners. And I think we should work on that, and we should think about how we can change that. Another point is that we have to work with the communities, and that means that we must work population based. And also hospitals are not used to do that. They work for fees, they work on special pathologies, but they don't think about the population. So I want to give some things that doesn't work for the hospitals. And the last thing is the culture. So we see that there are another language in the communities, in the social care, and it's difficult to speak the same language and to match that culture. So I think there are 2 important things to do about collaboration. That is leadership. That's very important. Leadership that facilitates collaboration. And another thing is changing of the culture. So I think these are 2 things we have to work about the next time.
Thank you. So all 3 of you touched on culture, trust, values, relationships. I'm wondering if you can share or talk about your experiences in seeing differing values. I noted, can differing values, cultures, and ideologies be a strength, not a barrier? Can it actually help you produce better rather than being the underlying win or lose mentality? So differing values as a strength rather than a deficit. Ellen, do you want to start?
Yeah, absolutely. I really believe that. So we tried some projects around arts and health, so some cultural commissioning interventions. And one thing that was quite innovative about that, I think, is that there's quite a bit of work in that space that's about what I would call kind of general well-being. But we went for some projects where we actually targeted people who were already on a disease pathway, and we looked to enhance their care through an arts and health intervention alongside their kind of typical, if you like, traditional clinical intervention. And we also targeted areas where we could see that the standard approach was not delivering the outcomes that we needed for our population. So to just give you a very brief example of what some of those things were, it was things like we could see we had a higher than would be expected rate of children being admitted to hospital with unstable diabetes. They were not participating in diabetes education. We could see we had no offer for our population for people with chronic lung disease. Once they came to the end of the standard 6 weeks of pulmonary rehab, there was sort of nothing, and patients talked about, like, it felt like you dropped off a cliff, so etc. So we kind of looked at some of these gaps, and we offered a grant sort of program where arts and cultural organisations could come and say, I've got an idea. So we didn't say we want this particular intervention. They could come to us with an idea. And then we asked patients, the clinicians and the artists to work together to come up with a proposal. And there was huge learning in that, huge reflection. And what everybody said is they all felt out of their comfort zone. And actually the person who felt most in their comfort zone was the patient, which was a really curious experience sometimes for our patient advocates who were like, actually, I had the most knowledge in the room because I could say what I actually wanted for me. Some of our clinicians were like, wow, I wasn't the expert this time. And the artists, this was new territory for them. But we have had some really exciting and tremendous projects come out of that. And the other thing, sometimes I think we can see these things as maybe nice to haves or a bit fluffy, whatever we want to term that. But actually for our health resources that we can track alongside these projects, we can see real terms, health resource utilisation reduction. I probably should have said at the beginning, I am a health economist by background, so I'm quite interested in us calculating this health resource use and how we can evidence that. If I were critiquing my own work, I'd say the kind of it's not big enough to be statistically significant, if you see what I mean, the data set, although it's getting bigger, and I feel there's enough in there that we can be pretty confident. But yeah, in terms of, for example, so for our lung health project, Singing for Breathing, we can see less exacerbations of the lung condition, we can see less call-outs of ambulances, less attendance to hospital. How much is that the maintenance of some lung strength through the breathing exercises? It's singing supported by a physiotherapist and a community choir, but also the bit that's very hard to measure, the well-being. You're with a group of people like me, people who have the same condition, that shared experience. I think it's very powerful.
Thank you. I suppose it shouldn't necessarily be a win or lose situation when it comes to culture and trust and value and relationships. I suppose for any professional organisation, they're always considering their organisational structures, the values of the organisation, the priorities, the funding challenges within the business, safeguarding of their clients, health and safety issues. But I don't think it's wrong to be challenged in some of that. So that joint working and being in a safe environment where you trust the people that are in the room with you, that you can take their challenge proactively rather than critically, and then building on it from there. If I think of one of the social enterprises that operates in Lisbon, the name of that organisation is Resurgam. They started out as a very small group who wanted to work with young people to make a difference, to take them out of that deprivation and poverty that exists within the old Warren area of Lisbon. Eventually they managed to build their own facility, They now have early intervention programs with the Health Trust locally. They do a number of projects around about safety and trying to stimulate new ideas and taking people out of paramilitary issues. But from that, they've now developed a social enterprise pub, and it's the only social enterprise public house in the whole of Northern Ireland. They also run a Help Kids Talk programme, which is taking those children that are most furthest from the literacy levels expected in primary one, and working with them really closely to try and close that gap that exists at key stages 1 and 2. But they've also developed a number of community programmes, including a community fridge, where they're taking food products that are due to go out a day and then circulating them in the community. So all of that work is helping other organisations, either statutory partners or the private sector locally, go over and above what could be achieved had they done it on their own. So just not working in isolation, and realising that the community will have a strong voice and be able to make change that perhaps no one individual could.
No? Yeah, okay. When I think about different values, then I think about nursing homes who have attention to well-being of the older people, about keeping them out of the hospitals. And when I think about the hospitals, for them it's to keep the length of stay as small as possible. When the medical problem is solved, then they must go out. Sometimes rehabilitation is not started with all the consequences. So I think when we can work together and giving some outreach to that nursing homes from the hospitals, that can help to build a better collaboration and also benefits for both parties. An example was also the example of Jennifer, where the GP was in the lead in the nursing home. So I think there are possibilities, and what's important is that we look for sharing problems that are the same, and then we can get on. And it must not always be you can think big, but I think it's important to start small. And then you have a base to work to bigger projects.
Thanks, Hildy. We had a conversation, not actually at ICIC, but in another place, about getting to the heart of what matters. And that for many people, not wanting to be in hospital is what matters. And for hospitals, not wanting people who don't need to be in hospital is what matters. And so being able to have that conversation about what really matters often serves as that foundation for problem solving. Thank you for that. I'm just going to flag, is there something in the room?
There is so much. Good. So it's my job to try and trawl through. Thank you, everybody. Really, really fantastic. I think there's one that is particularly about the role of families and unpaid carers in communities and in systems. And I think, there's a specific question related to your model, Jennifer, but I think I'd be interested in all of the panel's thoughts about how we meaningfully and materially support families and caregivers in our system. So maybe if we can pass over to you first, Jennifer.
Is this on? Yes. I think that's an excellent question, and I think that it's one of the most important things that we can do. We've tried to invest quite heavily in terms of how we support our family carers. And it's a bit like Ellen said earlier on about helping the community and voluntary sector to be part of the legislation or the paperwork that is required. I suppose what we've tried to do is to wrap around the carers, talking to them about what it is that they need. So we have a carer support hub that people can access. So there's lots of information in there about services that are available, practical tools as well. But there's also things in terms of offering respite for the carers themselves, because we recognise, I suppose, the what some have described as the heavy burden, but yes, it's a responsibility, but it's also something they very much want to do as well for their loved one. None of us could function if we didn't have the support of family carers. That's the reality of it. And I think as a society, we have to do more to actually support them. And we would like to go further than what we already have in place, but certainly our carers hub has been a good place to start.
Yeah, no, I think it's a really great question and such an important issue. I was struck by something that Hilden just said about you start small and you build. I think, I'm realistic about where we are in our system. I think we're at the starting small and we're starting to build, but I certainly wouldn't say we're all the way there on a number of these things. And I think that I would reflect similar with our carers approach. So we have a carers partnership board in our system, and that partnership board is a place where carers can come, and we work very closely with the overarching VCSE organisation who supports carers in our county to ensure that carers have a voice and advocate for the number of services that we run. Do I think, sitting here on reflection, that maybe the influence is significant enough? We have a number of services similar to the services that have been described, but I think in terms of that true at the heart co-production reflexivity of services, I still hear too many case studies of where carers have not been listened to, perhaps when their loved one is in hospital. It's quite difficult to advocate, I think. Sometimes when you want to make care choices, particularly around some of the things we've talked about, where maybe people have made choices about not wanting to come to hospital, and yet they have been brought anyway, even when we have personalised care plans in place and carers are not supportive. So but we're balancing this against really challenging issues. I'm not being critical here of our clinical colleagues, because I think we're balancing against issues of risk, feeling responsible, feeling that you have, potentially risk to your own professional registration if you don't take certain decisions. But there's something about how can we open up that culture, have that conversation, that actually it is okay to listen and to take these views into account, and that should be part of our practice and would actually enhance our practice as clinicians and experts.
I'm probably going to take a non-health approach at this because my experiences are less in the health field than certainly the people here today. I suppose for me, when I look at it, if we look at unemployment in Northern Ireland, there's only somewhere in the region of 30 to 40,000 people across the whole of Northern Ireland that are unemployed, whereas there's about 130 or 140,000 who are economically inactive, and that category includes a significant number of unpaid carers. So I look at it as a position of we have a skill shortage here in Northern Ireland. There are so many jobs that we can't fill, whether that's social workers, whether it's planners, finance staff, HR staff, community development staff. There's just so many vacancies that we can't fill now. So I very much see it as an untapped area of employment opportunity. And for me, I think it's about how do we provide the capacity and support to those individuals to provide care to their loved ones, to allow them to participate fully in the economic society of the country. So I think that's probably the challenge for us, is how do we support those people to be in the workplace.
Healthcare workers and social services are used to arrange everything for the patients. And I think we should change that. We should place the patient and ask him what he wants, what are his goals. And important also is that we also take the family and the caregivers with them. So it's really a big concern. We have to make really a change in how we organize those things.
I'm sure you have, yeah.
Just, it's maybe slightly provocative, and it sounds like a small thing, but I think it's a really big thing, which is I think when you're having conversations with people like unpaid carers, I think it's really important not to approach them as unpaid carers, not to say, we want to bring you all together to talk about the challenges you face as an unpaid carer. I think one of the really inspiring trends that I see happening across the public sector at the moment is having open conversations with people. People are people. They're not just the thing that you within the public sector have decided is what they are and what matters to you. And I think if you approach people as unpaid carers or as homeless people or recovering drug users, whatever it is, you immediately narrow down the conversation. You don't really get to the things that really matter to them and that might actually really help address the issues they face. But we've had the mention of power relations here. It immediately creates a different type of power relation. You're the one in charge. You're the one setting the agenda. You're the one saying, these are the things that matter to me, that I want to talk to you about, rather than what matters to you and what you want to talk about. So I think it's completely right that we do think about unpaid carers, but if we're going to have that conversation with them, let's have that conversation with them as human beings, not just as unpaid carers.
So I'm going to keep you on the mic for a moment, Adam, because we have several questions in relation to just that topic of power relations and how, in reality, where we're dealing with systems that equate resources and the availability of resources with power. And I think you used the word behemoth in relation to perceptions of the trust. And Hilda, you've talked about hospitals, being large institutions that have lots of resources. How do we ensure, and this has come from a number of people, how do we ensure that communities have a voice and have a share in the power?
That's an easy question. How long have you got? I think it slightly goes back to what I was just saying before. I know it sounds ridiculous and it sounds incredibly small and banal, but what I see happening is it does start with listening. It starts with moving away from a mindset which is we're here to tell you what it is you need to do, what you need to know, what you need to focus on, to actually saying, okay, what matters to you? Let's listen to what you think matters and what can genuinely change your life. And I love this phrase that people are experts in their own lives. So listen to them as the experts. And then take that as your starting point for when you are developing your sort of grand strategies for change, or even when it comes down to actually how you deliver things on a day-to-day sort of operational basis. So it is about shifting that mindset. And I don't think actually the starting point is saying we're going to hand over loads of money to communities. I think that actually can be quite a negative starting point and can be problematic. But if you're building a dialogue with a community based upon listening, putting them in the driving seat, as their confidence grows, as trust builds, then over time you can actually start talking about how you can actually transfer sometimes quite significant resource, and I do see that happening. But I'll just give you one really little example before I pass on, because I just love this as a really small example of how power relations can be changed just by thinking about just your sort of daily interactions. That example of that physiotherapy team in Sussex rethinking the way they worked around these community appointment days. One thing they really wanted to do was allow the physiotherapists, the clinicians, to really listen to what the patients, although they call them people, not patients, were that came along to these community appointment days, to really have those strengths-based conversations. And of course, one of the things about being a clinician is you have to take notes. And of course, if you're taking notes, you're not really listening to what the person is saying, you're tip-tapping away on your computer. It also says something about power relations. It's like, I'm the one in charge, I'm the one feeding the data into the system. So they decided they weren't going to let the physiotherapist take notes, which didn't go down very well with the clinicians, partly because it's a legal requirement that any consultation notes are kept. So what they did was they got the patients to take the notes, and then they used those notes to feed those into the system to reach their legal obligations. Fundamentally shifted the power relation, but also allowed the clinician to really listen and pay attention. Tiny little things like that can actually make a huge difference.
think that's a really powerful story, Adam. I just wanted to reflect, am I glad we had a listening event a few weeks ago? It did happen to be for carers, but actually where we quickly got into the space was about them as individuals. And it was really powerful. It was myself and the chair of the trust. It was, honestly, it's one of the most powerful things that I have ever done. It was 2 hours very well spent in terms of genuinely listening. We did very little talking until the end, which was about what we were going to do, about what we had heard. And I think as well, there's a range of other ways that you can organise things in terms of engaging with the community. There's lots of different tools. Appreciative inquiry is a good tool to use in terms of, it could be on a particular topic, it could be about a geographical area, but it's something that we've used in the past to really try and get close to the community and what is important to them, and then how we change things to respond based on what we've heard.
Thank you. So we've sparked quite a conversation. And I'm realizing that we are getting close to coffee time. So what I'd like to do is take the opportunity to thank our panelists for their thought-provoking, provocative, insightful comments. Please join me in thanking the panelists. That's the prompt that you should take advantage of the coffee time to snag individuals that you would like to have a further conversation with. But a couple of notes that I wanted to flag. You know, we've talked a lot about, and actually our panelists flagged, language matters. How the words that we use, where we started this morning, language matters. And being able to grow from a place of shared and common understanding, but putting people at the center of that. And working with alliance frameworks that allow you to grow from commonality and differences, I think is really important. And not underselling our work. What we're talking about is the hard work of integrated care and collaboration. And I think sometimes we talk about it like it's the easy work. We talk about it as soft skills. We talk about it as fundamental skills. You learned how to do it in kindergarten. And I think we need to think about how we frame the work and really honor and acknowledge the tough business of trust and relationship and collaboration and working outside your comfort zone. I loved that framing. I'm going to put a plug in. Robin Miller, I don't know if you're in the room. I haven't seen you. But there will be a special issue in the IJIC on third sector. And I'm going to flag that I recognize that the third sector is one component of community, and it doesn't get at, nor does it reach, the many health promoting capacities in one's community. And those are organizations that we don't often see or interact with because they are doing the work within their own communities. And I think there's an important point there around where the line between formal services and the community, so that we're not encroaching in places that don't need to be supported. I'm going to put that in quotes. I'm going to pass the mic to Niamh for some thoughts because I see she's been writing comments.
So much. I mean, it's been such a fantastic session, but I think there were a couple of things that jumped out for me. Similar to you, Michelle, I think as I was listening, I was writing down listening. To your point, Adam, we talk a lot about voice and community voice. Well, you give a community voice mostly by listening. The voice is there. It's not never there. It's just we don't listen to it most of the time because we're caught up in the work of doing what statutory services are there to do. So I think it's that mind shift, and we talked a number of times about mind shift, away from thinking about empowerment, because that implies there is power to give away, when actually that's not really what it's about. It's about recognizing that power is everywhere in all the relations, and we need to stop being the ones setting the rules for how it works and listening to other people and letting them tell us what the rules should be. And I was struck as well, a bit like Michelle, by that idea of getting out of our comfort zone. And Ellen, when you talked about everybody was out of their comfort zone apart from the people at the centre of care. That's where we should be all the time until we get used to it, and it's all our comfort zones. And that's really what New Alliance is all about, is everybody being in their comfort zone, everybody being in their space all the time, and a space where they feel comfortable and they feel heard and listened to all the time. So those would be my key reflections from today. I think it's been a phenomenal session. I've really enjoyed it. I hope you have really enjoyed it. And I think it's set us up for our thinking for the rest of the day. So please enjoy the rest of the day.
Schöner Götter, Funken, Tochter aus Elie. Yeah, thank you. Oh, good morning. I can see so many people here. It's so exciting to have all of you here. This is a very special session because this is also being live streamed, and we have the audience all over the world following this very interesting one. It is the digital area, the digital tools, the digital systems, being able to support the integration of care, or being able to do the opposite, to increase the fragmentation of care, has been the focus of several of these sessions of the conference. Today, this one I think is just spectacular. We have incredible people in this panel with very large experience from both theory and practice, and we'll have the chance to discuss with them, to pose them questions, and to learn from them. My name is Pilar Gangas. I'm a senior researcher for the International Foundation for Integrated Care. I'm also the head of the EU Portfolio Coordination. We have two different interventions focused on European projects. As you know, there's a lot of money that have been invested in co-designing digital tools to improve the care management of the population. We have quite a few European projects ongoing in the foundation. We have, I think now, around 11. One of them is the one coordinated by Magnus, one of the people in our panel today. Please feel free to use hashtag ICIC24 to disseminate on this session. Also, again, remind you, you can fill in the survey, this year's survey, and welcome, and thank you for being here. Okay, let me give you the order of the day. The order of the presentations should be starting with one of our guests, but he hasn't still arrived, so we'll start with Professor Corley, who is supported by Gary Boyle. Is that correct? So the floor is yours. You have your 10 minutes, and please introduce yourself longer, because we know, I mean, I guess many of the people in the audience know you already, but it would be great that they know, those who doesn't know you can know you a little bit.
Great, good morning, thank you. Can we just get the presentation up, please? Thank you. Good morning, everybody. How's everybody doing? Good, all right. What a privilege to be here, and congratulations to Anya Carroll being the chair, and Niamh, the CEO, and the team on what a spectacular, really great conference. So I'm going to talk to you for 10 minutes about a concept called Stay Left, Shift Left 10X, and somebody called the Digital Health and Wellness Capability Maturity Framework. And I talk a lot about 10X, and my talking time has gone from 2 hours to 10 minutes, and that's a 10X reduction, and that's good, and we're up to the challenge. So Stay Left, Shift Left 10X. So just let's focus for a second. So what am I going to talk about? First, I'm going to talk about a design principle, a single unifying design principle, which I believe, and others believe, if it can be adopted, this is the quickest way to integrated care. And the quickest way is because we have a couple of what we call design patterns that I want to share with you. One of them already exists for 15 years, is about how you build world-class IT and being used by organizations all over the world. And the second is one that we've just started to develop. And a design pattern is a generally reusable solution to a commonly recurring problem. There was a Stoic Roman philosopher. He said, the way is long if you follow rules or precepts, the way is short if you follow patterns. So what I'm sort of suggesting is that we can all work together to develop a design pattern that any country, any hospital system can follow to rapidly climb the integrated care maturity curve using digital tech tools. So I'm based at the Innovation Value Institute in Maynooth. Our sister university was founded in 1795, and we launched the Innovation Value Institute in 2007. It was modeled on the Software Engineering Institute at Carnegie Mellon, and our goal is to drive structural change in the way organizations and governance and companies use digital to get value. And now we're really focusing on digital, or on healthcare, because I think you would all acknowledge healthcare is absolutely the laggard in terms of adopting digital. And our vision is about shaping the digital future that works for all. And one of the biggest challenges in healthcare is health equity. 50% of the world's population don't have access to affordable health, and the 50% that do, it's rapidly becoming unaffordable. So how are we going to address that? I want to acknowledge our president, Eva Leonen, a Finn, who's a huge supporter of what we're doing. And last year we had the 20th US Surgeon General, Dr. Jerome Adams, with us at our summer school. So what's happened? We're all very lucky that we're living now. In 200 years, life expectancy has gone from about 30 to 75, 80. So that's remarkable. But the systems that have got us there are actually starting to fall apart. And I love this article, The Coming Collapse of the US Healthcare System. Doctors and clinicians aren't burnt out from overwork. We're demoralized by our health system. The trends are all going in the wrong direction. Demographics, hospital turnover, It's now impacting in the UK. A third in the UK miss work due to delays in accessing NHS care. And around the world, the NHS is so respected. It's the #1 thing that British people are most proud of, but it's really challenged. And here's some data from Professor Dan Lasserson. You know, acute admissions are going up, hospital beds are going down, and occupancy is going up. But we have a great opportunity. All of these disruptive technologies are coming, and we can really leverage them. I had the privilege of working at Intel, and this is a picture of a young-looking Gordon Moore. I once had lunch with him, amazing man. But the consequence of Moore's law, that it means, you know, transistor density or computing power is doubling every 18 months or less or equal cost, is that the unit of competition and the unit of performance has moved from the organization to the ecosystem. It's moved from the product to the platform, but probably most importantly from linear to non-linear. I get great hope from this quote from Peter Diamandis. When something is digitized, it starts to perform like an exponential technology. And that's what we've been observing in the Irish healthcare system. When we apply digital technology to healthcare, we're seeing 10x better, 10x faster, 10x cheaper. So what is stay left, shift left, 10x? Stay left is keeping you well, and if you need care, we can treat you best of all from home. Shift left is getting you home from the hospital as quick as possible. And then 10x is the notion that we can do 10x faster, 10x cheaper, 10x better. So we're trying to drive a global movement, and some of you might be familiar with the Solvay conference that was originally run in 1911, and Einstein and Marie Curie and Heisenberg came together to work on the big scientific problems of the day. So for the last 3 years, we've been convening as part of the UN General Assembly a digital health symposium with the top digital health leaders in the world, and we've published a paper, you know, authored by about 15 thought leaders and clinicians around the world. And last year we published the Manhattan Manifesto. So this is our vision of a completely transformed healthcare system that puts people at the center. It's about a shift from illness to wellness. It's about a shift from hospital to home. It's about a shift from activities to outcome. It's about a shift from reactive to preventive. Very importantly, it's about a shift from passive patients to active participants. And we believe that this can be really made happen in Europe and in the Republic of Ireland. We spend 97% of our health budget on illness, restoring illness, and just 3% on wellness. If you were a financial services portfolio manager, can you imagine if you put 97% of your funding into the worst performing portfolio? Well, that's what we're doing all around the world. So we're advocating a leapfrog system, and particularly in the Republic of Ireland, we're really far behind. We have the lowest digital health maturity across the OECD countries. But we're suggesting that around the world, we leapfrog to solutions that are based around patients, around personal care records. And I want to run a video from Gary Boyle. He's a friend, he's a patient, we're all patients. He's VP of Parkinson's Europe, talking about his simple request.
Hello, my name is Gary Boyle, and I'm living with Parkinson's disease. Every year I have an annual consultation with a consultant, and every year it seems there's a different consultant that I need to deal with. The problem with that is I spend most of my precious time in my annual review going over old notes and going over old paper-written documents that are in my file. So do you know what would really be good for me and for my relationship with my caregiver? It would be great to have an electronic record, something that we could set out and share and start using the technology that's available to the best possible use. So if I had one wish, I would like that it would be patient records would be all digitized, and we'd all stop wasting time going over old ground every time we meet. Thank you.
Yeah, thank you, Gary. So I think we need to listen to Gary, and we're advocating, we give everybody in Ireland a personal electronic health record on their phone, and the system revolves around this. I want to talk about hospital at home, and this is a very interesting example. In Ireland, we have the highest acute occupancy across Europe. I'm wearing technology from a Scottish company called Wear, and this gives better vital signs than you get in any Irish hospital today. There's a sad end to this story, because in the picture here, Dave Hurhangi is the guy on the my left here. And this picture was taken just after he'd raised £2 million sterling to productize and deploy this into Scottish hospitals. Sadly, a month after this, Dave had a heart attack. He was admitted to a Scottish hospital, was recovering well, fortunately acquired a hospital-acquired infection and died. It's really sad. So I feel a personal commitment to Dave to make this kind of technology. So hospitals are full, but there's also a big issue around hospital-acquired infection. So where this has moved on, I just want to give you a really quick example. This is the 12th of March in St. James's Hospital, and we had already turned on a technology before anybody had heard of Zoom or Teams for electronic telehealth. And I'm glad to say this technology has evolved here. So I'm wearing a small patch on my breast here. And this is my hospital at home solution. It's saying, Martin, everything is okay. And I'm having real-time vital signs here. And you can see my heart rate is 85 because I'm a little bit stressed being up here presenting in front of you. But it gives my respiration rate, my temperature, etc. But this is the future. So this solution can be deployed in 3.5 minutes in somebody's home, so we can avoid a hospital admission, and so we need to rapidly adopt these kinds of solutions. The second day COVID was in Ireland, we had developed, perhaps the first solution in the world for remote monitoring of COVID. It was hugely successful. We had it deployed in less than a week. We had it in 30 hospitals in less than 4 weeks. But the interesting thing as well, sometimes healthcare is run by accountants, but the return on investment validated by the university about over 10,000%. There's scarcely an area in the world where you can deploy solutions to this kind of return. Similarly, the first weekend that we had COVID in Ireland, we deployed respiratory technology in Beaumont Hospital, and we found we could get up to 12 hours notice of a patient desaturating. We rapidly deployed this solution to 23 hospitals. We've now deployed it in Donegal, which is a very remote area, and we used it. We would ask the patients to wear this at night, and we gave it to 10 very sick patients with severe COPD. They were routinely hospitalized once a month, every month. We would have expected 60 hospitalizations over a 6-month period. When we used this approach, proactive hospital at home, we had 0 hospitalizations. The total cost was about €950 for the drugs, as compared to an estimated cost of $250,000 if we hadn't done it. So we built a network across Ireland of living labs where we were deploying these digital technologies. Tomorrow I have the real honor of talking with Roisin Malloy about a 10x thermometer that was introduced, an absolutely fabulous product. We worked with leading companies like Roche and Centric Health. We saw results, 10x reduction in admissions from heart failure. So I talk about stay left, shift left, 10x. This example where we're keeping heart failure patients at home and we're reducing admissions by 10x. We've also introduced a proactive health check where you could go to your pharmacy and in 15 minutes we could identify all the risk factors. We can give you a device like a Fitbit or whatever, and we give you a risk assessment. And what we're finding working with an Irish company called Full Health Medical, 1 in 5 people actually have a risk factor that needs to be addressed. Now, sorry, I'm really sad to say there actually isn't a happy ending to this because all of this activity was stopped by the HSE strategy division. I believe there will be in Ireland an investigation into the conduct of this organization, but that's for another day. I just want to finish by talking about the IT capability maturity framework. This is about, and it's great to come to a conference where it's mostly clinicians. Mostly I'm going to conferences where it's technicians or technical people pretending they know about healthcare, and it's great to be amongst clinicians. But I want to share with you, here's a model we developed at the Innovation Value Institute. Some of the top companies in the world developed it. We've built a periodic table for everything a hospital or health system needs to do, and we can actually assess your maturity. We ran a substantial program with HIMSS where we looked at EMR maturity and we looked at IT CMF maturity. And what we have found is a really strong correlation between hospital systems and health systems that have mature IT capability and electronic medical record adoption, so an R squared of 0.71. So this is my, I think, last slide. This is an invitation to you. We are building a digital health and wellness capability maturity framework. So this is a tool that a national health system or a hospital system or a hospital at home organization could use to assess where is their current maturity and what are the next things they should do to get to integrated care using digital technology. And we want to help document what is the journey from going from old practice to current practice to best practice to next practice, and then inventing future practice. And right now in Ireland, we're trying to lift the Irish Health Service from the outside in, from level 1 to level 2. We signed an MOU to collaborate recently, and I'm really looking forward to partnering with Niamh and Anya and the entire team, and I think the future is really exciting, but we can't wait until tomorrow. These digital interventions need to be deployed now. They're better for the patients, they save lives, and they're better for physicians. So thank you very much, and this is my email if you'd like to work with us on the Digital Health and Wellness CMF. Thank you.
Yes. I have to say double thank you because you were able to merge two presentations in a really speed time. It was amazingly clear and really interesting, the approach that you have followed. I think this has given a lot of thought for the audience to be presenting and sharing the questions that we are receiving through the app. I will be responding to them at the end of the presentations. Now we can receive Magnus Wallengren. He's the coordinator of the project Care Matrix, and he will be sharing with you some reflections from this project on the lessons learned on implementing co-design technologies in real environments of public procurement healthcare provision. So thank you, Magnus, for being here. The floor is yours.
Thank you, Pilar, and thank you everyone in the audience. It's great to be here as part of taking part in your conference that you're arranging these days. My name is Magnus Wallengren. As mentioned, I work at an organization called Innovation Skåne, which is the innovation company of the public healthcare provider in Region Skåne at the very south, in the very south of Sweden. I'm here to present this project that I'm coordinating currently called the Care Matrix. We are a number of partners in this project, IFIC being one of us, but we will get to that later. There are several things, I think, being mentioned throughout these days about how integrated care is about community, it's about relationships, it's about trust systems and governance, but leaving that aside, it's also about digital innovations and being able to adapt tailored solutions for end users, being care professionals, carers, patients, any type of individuals or organizational managers involved in the care provisioning. And this is what we're dealing with in the project that we're coordinating. It is a project funded by the European Commission's Horizon 2020 program. There are still a few of us around. And in this particular project, we emphasize integrated care for people living with multimorbidity, meaning obviously being involved with several different care pathways along their journey. And what is being mentioned here is that it is a pre-commercial procurement project, as Pilar suggested. We strongly believe that any time that we invite participation and collaboration with the industry technology developers to solve the problems that we have in our healthcare and the patients that we serve, sooner or later we will run into the problem of procuring the solutions that we have developed collaboratively. It is important for us to understand and recognize that sooner or later this will happen, and with these pre-commercial procurement procedures, we can take that hurdle on early on in the process and have a transparent, fair, and equal procedure with any type of industry collaborator that is ready and prepared to serve our purposes. Some of the objectives that we have set forth for us in this project, they are quite ambitious, I would say, but I think all of us understand that this is how these types of solutions need to recognize the challenges that we have and the expected impact that it can have for the individuals themselves that are parts of the system and for the care organizations that are serving these individuals. In our project, we are 7 different partners coming from, and as it is a public procurement, they are coming from 3 different buyers in 3 different European member states, being from Sweden, from Norway, and from the Basque Country in Spain. Obviously, it would be easier to perform this procurement procedure in just one of these countries, but I think all of us recognize as the European Commission has done, that these solutions that we are looking for to address these needs need to be scalable and they need to be flexible to be tailored to each of these systems, no matter where they are at, what is the organization and governance of healthcare in that particular context, what is the culture around care provisioning in that particular context, and how do we serve these individuals most efficiently. These procedures, I'm not going to bore you too much with the details, but they go all the way from identifying the actual unmet need or the societal challenge that we mean to address in the project, and then publish that challenge to the market, to industry actors that are willing to engage with the process, for them to be funded in 3 different steps in a competitive manner. They start with the solution design, development of a conceptual design basically. For our project, we are beginning to, we're at the end of the prototype development phase, where we really get to have a very intimate interaction with the suppliers for them to have a full understanding of the challenges and the context in which we operate, and for us to understand their design process as well. Our next and upcoming phase will be to select a few of these solutions to validate their functionality and how they operate in these 3 different geographical contexts. You could say that pre-commercial procurement in itself is part of what is called, in a more larger sense, innovation procurement. Something that is very similar to an innovation funnel, starting from an unmet need, a challenge that we can't address entirely on our own. Then we select a few providers that can elaborate on a design or a concept that can address that challenge. They develop prototypes for demonstrating that concept, and then it goes on for feasibility testing. And this is exactly what we're doing in our project. In a more long-term sense, obviously, we want these solutions to be successful, and we want them to be adaptable and scalable in our context. And for that to happen, they need to be flexible towards any number of different contexts or any number of different buyers, as we all are on the public healthcare side, for them to be ultimately in the long term successful. For us, the challenge that we are working with continuously in our project, we've been working with this for 3 years now. It's going to be another 1 or 2 years before we conclude these efforts. Obviously, you all know these challenges by now, the matter of integrating care between different care levels, between different care providers, and how we can allow data and data streams to be accessible across these levels. On top of that, obviously, the multimorbid patient adds another level of complexity, being that they are part of different multiple care pathways with different care providers and different individuals really involved in the provisioning of their care. So it's really a matter of being able to access the appropriate relevant information at the right time for both the individual receiving the care and for the care organizations provisioning that care. obviously, this is about care pathways, and it's not only about the data, but having these technology developers understand that there are care pathways that have been established in some contexts, while others may not have been. And it's a matter of coordinating these care pathways for the purposes of making really life easier for the individuals receiving the care and for the care professionals involved in their care. We're building this around 5 different use cases for us to be able to early on identify who are these patients, to be able to prevent any further progression in their care journey. It's about being able to facilitate the collaboration of interdisciplinary collaboration between teams and individuals at the different care facilities, individualized care, person-centered care, patient empowerment, and the coordinated continuous care efforts that these individuals receive. At this stage, we are working with 5 different technology developers from different countries. I'm not going to go into each and every one of them particularly, but we can, even though they have decided to use different types of solutions for addressing these challenges, we can say that there are similarities between them. Most of them have chosen a model where we hear a lot about dashboards these days, and I would say that's quite typical of what we see as well, about the care professional having access to a dashboard with the most relevant information at hand for that individual patient, and on the other hand, for the patient to have access to the information that is most relevant for them short-term and long-term. Yes, and a lot of we can see, and we're happy that a lot of the tech providers that we're being involved with is not only the large corporations that we are all familiar with when it comes to these digital innovations, but also different types of SMEs, even micro SMEs, that have chosen to be involved and commit to the process to get to know the sector better, get to know ourselves as buyers better, and bring their solutions to the hands of our care professionals. Obviously, there are so many challenges with these types of projects. They go on for a long time, and it's important for us to sustain the level of interaction and co-creation with these counterparts throughout the project. It's very important for us to have these solutions be tailored and adapted to the different types of geographical and regional contexts in which our buyers group operates. And any type of IT or digital related challenge, obviously, when it comes to flexibility, interoperability, modularity, not least because all of these buyers obviously have digital EHRs in place already, which these solutions need to work efficiently with and add value rather than replace or just create another task for the care professionals that they need to be involved with. And that was it. Thank you.
Thank you so much, Magnus. Advancing some challenges that we will be further sharing in the discussion. Thank you, all the people that are already sharing your questions. Please, you will also have the chance to raise your hand and stand by or get a microphone, but you can also use the Q&A. Our next guest is also working on multimorbidity. Professor, I want to read it properly. I was checking on your questions. Okay. Professor Lars Meyer will be is working on the multimorbid population, on design principles for e-health for older adults. Thank you so much for being here. Now you can do your intervention.
Thank you very much. Thank you for your attention and being here and for inviting me for this subplenary session. I'm from University of Copenhagen. I have worked in healthcare innovation, informatics for 15 years and original medical doctor. I'm presenting on behalf of the Canadian European Consortium, SMILE, Smart Living Inclusive Environment. And the idea with my presentation today is to give some ideas about our ideas of new kinds of innovation to be more inclusive as our objective for the whole consortium, which is between Norway, Denmark, the Netherlands, and Canada, is to find ways to offer these services to more people. And what we have heard from the two first presenters is very much in alignment with our thoughts. Just to be aligned, I have brought a slide here, which shows that the way we consider the way healthcare is provided or should be provided is, despite that we talk about integrated care and that we have different organizations, institutions, then we really need to acknowledge that we have in principle 4 service models that we should be specialized in. In the middle of the slide, you see the typical diagnostic treatment paradigm, which we have known for 1,000 years or more, and the modern area for more than a few hundred years. I do not know to say more about that, but it's when you have this diagnosis, you are treated, and then you come back to your community and your daily life. At the left side, you see the acute response with life-saving measures, in response to trauma, etc. And it's also very specialized. It has existed for approximately 8 years. And then we have at the right side, what is important, what we're talking about today, is the integrated care of chronic conditions. And it's very important to recognize when people are diagnosed, when they're suffering from conditions, whether it's COPD, it's ischemic heart failure, or it's cancer survivors, or it's post-intensive care syndromes, you need to be in another order where it's not event-driven, but where you are offered services regularly and proactively monitored. So that's our thinking in our project. And the next slide here shows the idea in the SMILE project. We built on the ECM model, or epithelial care model, which was published originally in 2017. And when you describe it, it sounds very much like how the first presenter presented his work, as it's a proactive, value-based, it's across sectors, it's cross-disciplinary, it's driven by proactive data, patient-reported outcome data, and which is used to filter the services which is provided as close to you in relation to how you need it. And what I'm showing in this slide here is what is very important when we are at a session where we are talking about digitalization. It is, we really need to talk about social technical thinking, as we very often forget this social technical thinking that we as humans, whether we are health professionals, or we are caregivers, or we are the patients, and we have technology assisting us, we are in a dynamic relationship where we interact with each other. And the principle we work from is not person-centered or patient-centered. That's old-fashioned, actually. We work personalized, health-centered. We work with the patients in teams together with their caregivers, formal and informal caregivers, and their services around their condition, around their health. So instead of putting the patient in center and putting them in to be a kind of something we are doing something for, even though that we ask them what matters to them or help them to articulate it, then we really look into how the health condition can be mitigated through what we can see here on the slide, a community of clinical practices, a community of community practices, and then technical support. And the whole idea with this is it's a mesh, you see, not a mess, but it's a mesh. And the mesh is like the internet, or when you have home devices at home, you communicate with each other when it's necessary, and you communicate only with those that are required in the situation. And it means that when you are suffering deteriorations, then you get more context to those at the left side in the hospitals, the specialized sector. When you're more in the proactive part, the independent living part, supported by technology, then you have more interactions with the community part. And all these different actors, they will also interact through the mesh. And if you would like to know more about it, you can just approach me after this session here, then I can explain much more about the ECM principle. To create an inclusive environment, to be inclusive, we really need to know the persons we are addressing. And the way to ask is not to say what matters to you necessarily. Not all people knows what matters to them. And even though something matters to them, when they suffer from a deterioration and they recognize it, some will be able to respond and co-manage, and others are not. And it means that some needs to be served by us. And we need to add a little paternalistic sometimes. Others we do not. So we need to recognize people. And we also need to recognize to involve different kinds of people in our design processes. And that's where we use the READY framework, which is based on our model for digital health literacy. We have a scale, the EHLQ questionnaire. And then we have added elements of social support, which means your peers, and also your professionals, whether you feel supported by them. And then it also matters how you experience your condition. Are you distressed by it? Are you positive or negative around it? And are you actually able to understand your body? Do you have these skills to recognize symptoms from your body? And we have shown in different studies, it's important that you recognize people's distress before you try to give them technology. Also, a lot of studies shows the very huge importance of having a social network, both from professional caregivers. And what we are doing and what's innovative is that we have used this framework here. We have a questionnaire, it's 13 scales, and we're actually able to assess a population, cluster them, and then use the data from the clustering to create personas. And we then map, and what we have done when we went into our design process, when we were going to design one of our techniques, I'll demonstrate a little, we really needed to get the voice of all. And prior to starting our design process, I come to the next slide here, we actually looked into literature and identified very often you recruit patients or participants from organizations, by other ways, by peer network, etc. You do not always include those that is most in need or most far away. And we also identified that you do not involve them in all steps of the design process, and sometimes you also forget those with cognitive impairment. So what we did was we used the READY instrument. We clustered a group of patients, 45 patients, and then we identified 4 different personas, and then we invited these 4 different persona representatives. So we were sure that we interviewed people to identify needs with different levels of feeling supported, different levels of digital health literacy, different levels of emotional distress and insight into own body. And then we had first interviews, and based on the interviews, we found 9 areas of interest. We made co-creative workshops iteratively, and then we came up with 3 solutions, and then we presented them to our informants, and in that way we came up with a solution which was a way to support people living at home with a chronic condition, which means how can we support you when you are supported by the ECM model, when you have access to the different formal caregivers, when you have home monitoring systems, what do you need in additionally? And we came up with a conversational agent, or what we call a smile bot. And what we identified is essential for this population here, which is mainly COPD patients, is that it's important to have an area where you can look up around your health. And we have created in a way that if you have a low level of health literacy, then you'll get only short information. And if you have a higher level of health literacy, then you will also get access to links so you can get more knowledge. And then it's important to have an area stimulating you, informing you, motivating you for social and physical activities. And then the third area that is important for the informants or people with long-term conditions is insight into circadian rhythm, some questions around how did you sleep, or some advices, and also if you have some sleep monitoring equipment, then you can, based on these data, also be informed about good advices in relation to preparing for sleep or when you wake up early. So that was the final part of my presentation. But the main message here is that we need to design for a particular service, and for our situation, chronic conditions, we need to be aware of this social technical perspective. we really need to find and identify people with different levels of digital health literacy, social awareness, and self-management capabilities. And when we do the design process, we really need to focus to involve people in all phases, from problem finding to evaluation. And in our context, and I've seen it reported by others as well, it's important for people with chronic conditions to be supported around knowledge around their health in a more easy way, around social physical activity, and also how you sleep. Thank you very much.
Thank you so much. The socio-technical approach. I think all of you have been highlighting how important it is to take into account that these technologies are intended to be used in a social context by real people. We'll discuss more on this. Now I have the pleasure to have Matthew. The name? Sorry about this. Matthew Mayer. Thank you so much for being here. Could you introduce yourself briefly and please go ahead?
Yeah, I'd be happy to. Thanks for having me. It's the second time that I've had the pleasure of coming to ICIC, and I absolutely love this conference and the people here. So I feel like I'm presenting to experts, but I'll give you just a brief introduction to myself. So I'm an epidemiologist by background. That's my training, with an area of specialization in health economics. But one of my favorite moments is when someone at a party asks my wife, what does your husband do? And she always goes, oh, just go talk to him, because it's easier for him to explain. So I'll give you a sense of the roles that I have. So my day job is at London Health Sciences Centre. I'm a senior director in the Office of Health System Transformation, which is a really innovative office. LHSC is a tertiary, quaternary academic health sciences center, one of the largest in Canada, actually, but certainly in our region. But the reason why we have our office is there's an acknowledgement that we need to show up differently in the way that we interact with our community and with various providers across the community. So we've been empowered in our office to make change. One of the largest ways that we're doing that is through work with what we're calling the Ontario Health Teams. I've got a slide that I'll show you on that, so that'll mean more in a minute or so. But we do a lot of work with other partners, both in the local level, but also regionally and provincially, to try to think about how can we do something fundamentally different. I'm also an assistant professor in epidemiology and biostatistics at Western. I'm adjunct at the business school. I'm adjunct in the School of Public Health. I am not an expert in any of those spaces, but I mention that because I also kind of joke in those parties that I argue that sometimes I feel like I'm multilingual. I do have a background as a personal support worker. I have worked frontline. I've worked with individuals in the communities. I've had an opportunity to work with researchers. I have the wonderful opportunity to work with providers across the system, and I love talking to all of them. So I think that's the key to the work that I do, and what hopefully you'll see in some of the work that we're trying to move forward with this concept of human-centered design. So just a bit of a grounding to make sure that everyone knows what I'm talking about when I start. So I am from Canada, the province of Ontario, which is the most heavily populated province in Canada, right there in the middle. And what's happening in Ontario, and there are many of us here, so if you see someone from Ontario, ask them about the OHT transformation, but Ontario is undertaking a significant transformation towards what we're calling Ontario Health Teams. They're being structured in many ways on the integrated clinical systems that we're seeing out of the UK, but also on the accountable care organizations of the United States. We have this dichotomy in Canada where we have influence from Europe and from the South, so we're trying to bring that to the Ontario context. But where we're at in this process is basically it started with an open call from the government to say we want to form these Ontario Health Teams. We want organizations on the ground to come together and tell us how you want to do this. So how are you going to provide integrated care? Basically form a coalition of the willing, find some friends, tell us you want to work together. That's led to, at present, 58 Ontario Health Teams that have been approved. What we've heard from the beginning, though, and this is where I mentioned some of the reference to ICSs or some of the accountable care organizations, the concept in Ontario Health Teams is that at maturity, Ontario Health Teams will be clinically and fiscally accountable for the total costs and health outcomes of their attributed population. What we've done in some of the work I'm going to share with you, we've pulled together a number of these OHTs to come together into what we've called the Ontario Health Team Coalition for Population Health Management. We've rephrased this a little bit because we think it's important. At maturity, every Ontarian should be attributed to an OHT, and every OHT should know who they're accountable for. And that's a really important distinction. The OHTs are about the population. They're not about the partners at the table. So we're trying to shift the thinking towards let's focus on our population. What's interesting about this whole process is that in the beginning, when we were approved, our Middlesex London Ontario Health Team, which is one of the 58, was told that our attributed population was 525,829 people. And we say that over and over and over again, because that is not a round number. Those are humans. However, we weren't told who they are. So we weren't given the list, we weren't given names, we were just told 525,829. Okay? It gets updated, so we know it's changing, but we don't know who they are. So that's a huge crux in the work that we're doing and what I want to present today. How are we thinking about how we would shift that paradigm so that we can actually get to know our population and get to know what they need so that we can design the services around them. So I just wanted to share a couple of slides that, as I said, I get the good fortune of working with lots of good, brilliant people across the system. This is a slide that was created by Dr. Dan Pepe, who's a colleague of ours. He's a primary care physician. And this is working with his colleagues, how he described being a primary care physician in the Ontario system today. There is an incomplete picture of the patients that they need to support. They spend more time doing administrative activities than they do actually providing medicine. And they constantly feel like they're pushing the proverbial rock up the mountain, right? Just constantly having to fight for everything they get. This is an image that was created by Anne Wojtek, who is one of my co-chairs on the coalition that I mentioned earlier out of the University of Toronto. She works with one of the OHTs as well, and I absolutely love this. This is how she's described the system from work that she's done with patients and population members. There's this perception amongst Canadians that we have a healthcare system, but the experience that people have is completely disconnected, disjointed silos, and it's on the patient to try to figure out how to piece all of these things together. And that's the experience we hear over and over again as we do co-design sessions. So the tool that we've been trying to use within Ontario Health Teams, which I think, again, everyone here hopefully is familiar with, is this concept of population health management. It's been in the wording, in what we've been hearing in Ontario Health Teams from the beginning. You're a mechanism to deliver on population health management. And again, our question is, help us define that, help us understand what that means. This is the diagram that was created by the RISE team at the McMaster University. It is the tool that's being used to really drive the education with OHTs to say, this is what we expect of you when you reach maturity. And one of the things that's really, really important here, and I think people from other systems often take this for granted, but we can't in Ontario, is it starts with knowing your population. Population identification and capturing some basic information on everyone you're accountable for is where this starts. And it goes back to my comment earlier when they said, you've got 525,829. Awesome, who are they? Well, we can't tell you that, right? That's a problem, right? So we're working really hard to shift that thinking and help people understand that's the level of detail we need to get to. Once you have that, though, once you know your population, then you can start to segment that population into meaningful subgroups, go out, work with those subgroups, co-design solutions with them, implement, evaluate, and the cycle kicks off, right? But a couple of things I wanted to point out. One is, we don't know our populations, at least not in detail. So we often end up in Ontario context, and I hear from other partners around the world that this happens as well, diving into predefined segments. If you work backwards from those segments, it's a great way to figure out where your gaps are. So initially, when we were formed as an Ontario Health Team, we were also asked to identify a priority population. We worked with our partners. What's the priority population we should be focusing on? I'll just give you this as an example. We could apply this to any population, but they said COPD, congestive obstructive pulmonary disease, is a massive issue in our population. Let's start there. So we went to the data, as any good data scientist would do. Data tells me that we have about 6,000 to 6,500 people with COPD that we can focus our energy on. The challenge, of course, is that population-based prevalence estimates would tell you that we would have 30 to 35,000. That was huge for us. It was a really important step in sitting down with clinicians and patients and helping them to understand that we are missing out on supporting 24 to 29,000 people because we don't have integrated data. So as we're trying to sort of move forward in this journey, and again, I think this is sort of speaking to a room of experts, design thinking is something that we're really trying to adopt in multiple ways. But one of the ways that I find really, really helpful, again, health systems researcher, is this concept of not just thinking about design thinking, but thinking about systems thinking and bringing those two concepts together. Often in my journeys, I find that we have lots of people who are really good at thinking about designing things for individuals. Those people tend not to be the same as the people who like to think big picture, systems thinking, right? And we need both. So this concept of human-centered design thinking is really something that I think is helpful for us because it allows us to bridge the gap, bring people together so we can have meaningful conversations about how do we affect system change that's going to actually mean something to somebody on the ground. So this is an example of how we're doing it. So we've through the Ontario Health Team Coalition and through engagement with our Patient Client Care Partner Council, lots of people that are involved in our process, we've created some vignettes so we can start to explore these stories of what this kind of thinking means to somebody on the ground. So George is our first individual based on, you know, a story that many of us have sort of acknowledged. George is new to Ontario, 67 years old, fairly healthy, just arrived. And interestingly, we landed on this vignette because we kept talking about how to share multiple complex pieces of information across the system. And through that, we kind of backed up into the fact that we don't even know how we would support someone who's brand new to Ontario. Zero information in any database. How do we support George? Right? So we started there, but then we've added Sam. Right? So the idea here is that Sam is a 35-year-old individual. No housing, no access to primary care supports, really struggling. This is the piece that doesn't often get done, though, I think, when we talk about systems and we think about design thinking. We also have to think about the people who work in the system. So from a data perspective, when I had this chance to give a presentation, we've created a few of these vignettes around providers and others that would function in the system. We wanted to use this to have conversations about Darnell. Darnell would be a health system analyst, a population health analyst, right? So Darnell is someone who would not work alone, would work with a team, but has the skills in maintaining a registry, getting to know people, running some analytics, and ensuring that the output of those analytics get into the hands of the people that need it, right? I'll come back to Darnell in a second. So we're trying to be very direct in how we're having these conversations and how we're bringing those human-centered design principles into our thinking. And I did say I was an epidemiologist, and there's an old saying in epidemiology, give us access to all the information in the world and we'll solve all the world's problems. I don't know if anyone's heard that before. This is sacrilege if you're working in the epi. We don't need everything. We can do really, really powerful things with very little information. So one of the things that's come out of this process as we've worked through this is that if we can start small, if we can start simple, if we were to get Darnell empowered with only the information that we need on our attributed population so we know who we're caring for, that's powerful. So imagine Darnell had access to a database where he had access to 525,829 names. He knew their name, health card number, date of birth. You need those for probabilistic matching, address and contact information. And then this is where the really interesting piece comes in, consent to contact. Can we reach out to each person and say, do we have your consent to collect more? This is a great opportunity for us to identify the people that do not want to be interacted with, the ones that are going to have huge privacy concerns, and stop. But we can start here and make sure that somebody is connected, right? So just imagine that Darnell had access to that system. Then we can get into step 2 of population health management and start doing something really powerful. So imagine that Darnell had access to this information. Imagine that Darnell could do outreach to George and Sam. With that basic information, Darnell might be able to identify key milestones. George is a senior, right? There may be senior care services that we should make him aware of. Sam at some point is going to age. How would we reach out to Sam? But then we start talking and thinking about, well, what if we were able to, with their consent, get other pieces of information? This helps us to identify risk. And this is how we can start to, with very simple information, start to proactively identify people that we need to connect with. We don't need everything. But imagine if we had something like attachment to primary care. And I know that's not a concept that exists in some systems. It's a big problem in Ontario. We have in our population an estimate of about 65,000 to 85,000 people that don't have primary care. So that's an issue. That might identify the fact that Sam might be rising risk, but George is new too. Neither of them have access to primary care. So both have some level of risk. This piece of information is the one I want to highlight: encounters, appointments, and referrals. Basic information, but it gives so much in terms of how regularly are they accessing the services, who's in their care team, what's the upcoming appointments, what's outstanding. Right, so this is the kind of thing at a system level would be really helpful. But the reason why I pointed out is we've heard from clinicians, we've heard from providers in the community, we've heard from patients themselves. If only I had access to this, so I don't have to write down and remember who I saw last week, who I saw last year. If I had this information, it would be hugely valuable for me. There's a lot that we could do here. But then imagine if we could start adding information with people's consent about what diagnoses have they had, what medications do they have. That starts to increase the risk. And this is the kind of important one, we've heard this a lot this week: social information. If we knew that Sam was accessing services like shelter services because he's homeless, all of a sudden Sam's level of risk skyrockets. But in this system, Darnell can reach out to the right people and make sure that Sam's connected. Right? So we can be proactively trying to reach out to support people instead of waiting for Sam to show up in the emergency department, as an example. So I think I'm probably over time, and I'm almost done, I promise. What we're trying to do with this, and the reason why I wanted to bring this to this conference, because I'm really interested in other people's experiences across the system. What we're using this for is to work with our OHTs and start to get people thinking about, do you have a Darnell? And no one does, but everyone thinks they do. So we have about 1,000, probably about 1,000 people out there who think they're Darnell because they have access to a limited data set, but they don't have access to everything, okay? So do you have a Darnell? No. As we establish Darnells, where would he work? What information would he have access to? What privacy do we have to put in place? So really using this human type of approach with the people that would access this information to think about and envision the future. And so the way I wanted to kind of wrap up my portion of the conversation today is, if you have a Darnell, we absolutely want to know what your Darnell does, what your Darnell has access to, how have you gotten to that point in your system so that we can learn from you. So that's my time. Thanks.
It's been such a pleasure to listen to you. We can see the real-life system transformations. You get down to very detailed how you approach this data analysis, which is the way you use for connecting with people, while you were thinking about how these people could be using these devices. These two projects were also approaching this people-centered connection to development of technology through involvement of people and through really adjusting these co-design processes. But you all were facing some challenges, common challenges. We've been hearing for at least a decade how these technologies will be a game changer for the way the care is provided and the way people are treated in the system, how this is going to advance the integration of care, how this is going to reduce fragmentation, how this is going to increase the personalization. One of our audience participants is asking, why are we so slow to adopt digital solutions at scale in health? Why technology is being implemented so slowly? Yes, please, Martin.
Too many people have the ability to say no. It's down to leadership. It's seeing is believing. You know, I had to leave the Irish Health Service. I was the CIO, was the Director of Digital Transformation, and we did amazing work with clinicians, with consultants, GPs, nurses, and yet there was a small group of administrators blocking progress for whatever reasons. And what we have to do is just do it. And we have a methodology called Open Innovation 2.0. It was developed by the European Commission and Intel, and Maynooth University, and he uses living labs. And it's a way of introducing radical change in a very non-threatening way. So, the average success rate of innovation is very low. It's 6 to 7%. With digital transformation, it's actually higher. It's about 30%. But in the Irish Health Service, despite extreme resistance, we saw a success rate of over 80%. And it's, start with 10 patients, 1 doctor, 1 nurse, try something. Evaluate it, iterate it really quickly, and then move to 100 patients. And if you can do that, and you have to do it under the radar, so why? It's a culture of no, and we need to move to a culture of why not. Let's take a risk. The ex-UK health secretary, he said, we're now at the point where the risk of doing nothing far outseeds the risk of doing something. The technologies that are available, we can do everything on our phone. We can bank, we can listen to music. Why not our health? And so please, Gary Boyle, who's a fantastic patient, real advocate for stay left, shift left. The number one thing he wants is a personal electronic health record. We talk about 10 Copernican shifts, and the shift that we have to make is as seismic as what Copernicus said, that actually the Earth revolves around the sun. It took 150 years for that paradigm to, be accepted, but that's the kind of shift we need to make. So I think it's about why there's too many people that say no. There's a culture about, risk, I'm afraid to do that. Just do small experiments, improve them really quickly, and just push them through, and don't take no for an answer.
Thank you. Any other response to this question? Yes, Lars, please.
Yeah. I come from a country I maybe could call milk and honey, as we have a very strong infrastructure. We have digitalization, we have e-health records or electronic medical records for all patients, all GPs are digitalized. And what we can see is right now we are rolling out a national infrastructure for telehealth, primary offer to COPD patients. And one of the big issues is actually incentives. It means that if the GPs are going to refer, do they have the time to assess their patients, whether they are eligible for it? Do they have the motivation for doing it? We can see it's very difficult to having them to do it. We can also see that the benefits when we get the patients into the telehealth services, where we more than half the hospitalizations, then they will be more in their home. They will take more of resources from the municipalities, which means that the municipalities should have more money, but the economic model does not flow the money around with the patients. So it actually means it's organizational issues, it's incentives, it's the monetary ways to do it. So right now we are waiting on National Structure Commission to try to make something new, like maybe in Finland. But the short answer is that in a small country like Denmark with a little like less than 6 million people, it's not the technology, and it's neither the older people's digital health literacy. Actually, we can onboard most when we offer it, but it's about to motivate health professionals in municipalities, hospitals, to inform the patients and to help the patients to onboard.
Yeah, thank you, Lars. That was amazing how you have mapped all the key stakeholders to be taken into account when this is developing. And also it was very interesting from Martin, the pace of change and the route to change. Thank you so much. Matthew, I think you had some answer for this.
Yeah, and you guys have kind of stolen some of what I wanted to say, but I think, one of the themes that I've enjoyed hearing here is that health systems don't self-organize. And I would say the same is true for digital health systems. They don't self-organize. There needs to be some centralized organization, some structure, a roadmap that people can stick to, that they can say, this is how we're gonna go. I know that's what's really lacking in Ontario right now. But we had a really interesting conversation this morning as well in one of the digital sessions, where we talked about the fact that a central coordinated interoperability strategy, some kind of governance structure, and a patient-held, person-held health record are not mutually exclusive. We can be fostering both, I think, at the same time. I think that how we let those on-the-ground innovations that we're going to push through, how we do that needs to be left to local context. It needs to be left to opportunities for, like you've heard from some of these folks, really brilliant innovations that we can then scale. But the scaling, I think part of why it's taking so long is that we don't always have that centralized infrastructure to tap into. So if we can let people scale or develop something and then have the infrastructure to support them with the scaling, I think it needs to be both.
Maybe just one quick comment on that, because in the past we thought we needed this, huge infrastructure to do this. But if we build a health system around the mobile phone and a personal electronic health record on the phone, we don't need to invest, billions and billions. We do our banking. Can you imagine outsourcing your bank account to your accountant or somebody? You're not going to do it. And why do we outsource our personal health? We need this new era, I think, of self-care and shared care. But this 10x factor, because of Moore's Law, stuff we couldn't dream of 10 years ago, we can now do. So, but I totally agree, we need a top-down master plan. So this is the vision, and we're kind of proposing stay left, shift left, 10x. Let's just all innovate in the same direction. It needs to be interoperable, of course, but I think we're at a tipping point where everybody in the world should have a personal electronic health record. There's a fun video I like to show when I'm teaching. It says, what if air travel looks like, ran like the health system? And it just would be impossible. So why can't we do that? And I think we can do it for a lot less now. If we tried to do this a decade ago, it was really difficult. But now, everybody in the world should have a personal electronic health record. It should be standard. Cars, any mechanic can go up and, look at what's going on. We know a lot more about our cars than we do about our own health. So we're at a tipping point, and let's decide to do it.
A lot has been said about the organizational perspective, and if we just add something from the industry perspective as well, we just need to understand and recognize that these are strictly regulated industries, both when it comes to these digital innovations, which very often will be medical devices. Just as in drugs development, these things take years to be developed, to get qualified, to get validated, and then to be put on the market. I think the typical time period for any medical device to go from, let's say, a concept stage to something that's been classified, that's been validated, is about 8 years. In our project, Care Matrix, I think we're entering year 4 now, which might seem a bit frustrating at times, but it's still, we are accelerating a process which usually takes twice that time. So let's also consider the industry perspective, I think.
Well, thank you so much. These are amazing responses. Several of you were mentioning, connects with other of the questions from the audience. They were asking about the consent and privacy. This was for you, the question, but I think this affects for the whole panel. How much have we advanced, and how much we need to advance yet on the standardization of the devices, and on how to address the ethical, legal harmonization across not only Europe but the rest of the world? It seems that when we are developing technologies, we find so many different legal and ethical requirements that it's discouraging sometimes, and it's really a huge barrier, as we have seen in Care Matrix and other projects. I guess in Smile they also found it. It would be great to know your opinion on this, how we could advance on this standardization and this harmonization of these legal and ethical barriers across the world. You asked me for a difficult question, Martin. Here you have one, but I have another one for later on. This comes from the audience. Who would like to respond to this?
Should I try?
Yeah, I only
they're rarely there. The problem is right now things are changing, even in Denmark. But in general, it is so that when we live in Denmark as part of the being a citizen in Denmark, then all our data in relation to our health and our life when we are born, our marital status, etc., but also contacts, they can be used by the regions or municipalities that have this data without consent. And we are even, if it's not for research, which is internal for the organizations, they're able to do it. So to look into how we could do most beneficial things for people with COPD, then one region together with a few municipalities looked into all data and were able to identify what I think you in England call Core 20, something like that. But we are actually able to look into what you talked about earlier from the VISH in Ontario without any consent. It is, if you're going to have all these data then put into a national register, and if we're going to get those data, right now we have to apply for them as researchers, we have to argument according to GDPR, etc., and we can only get them on aggregated form with these 3 individuals gathered together. So we could not do it at the individual level, but at a higher level than 3, we can also get all these data as researchers. Right now, and that's where I'm a little in doubt, and if anyone from Denmark could comment maybe, we are in a process where people will be offered to ask for not being included in these public databases for research purposes. And we are also having a discussion right now around blood samples, biobanks in Denmark, which has been stored for a long period without people knowing it. And right now we have a political discussion about whether people should consent to having these data in the biobanks. So we have this as having a very strong public sector for many years. We have this conflict between that all consider these data to be public when they're used by the organizations for the purpose of the public. So it's mainly for the researchers. There may be some ethical reasons, but it is quite open. So we are quite different from many other countries. And I was a little puzzled to learn that you in Ontario should have consent to sample these data if you are an organization actually providing the services.
I think for us, the matter of data management and privacy is always going to be obviously critical in these types of projects and efforts. For us, that means that even though we have a shared personal data GDPR regulation across the different countries that are involved in our project, the difficulty comes from that it's being implemented differently within these 3 member states that we will be validating these solutions in. And just speaking from as a Swede, we always like to think of ourselves that we were talking about risk before, and rather than doing the right things, we like doing things right. That means really going by the book and being very risk averse when it comes to the matter of have a more balance and consideration of privacy and risk for those individuals. So those are the challenges that it creates for us in the project.
Thank you, Magnus. Please, Matthew.
I think in some ways this question is actually the answer to the previous question, right? It is so complicated and so complex and so multifaceted that it leads to just paralysis in many cases, and it's part of why we're so slow to implement. But context is everything, so I want to make sure that if their question was directed at me based on the comments that I made, we have very well developed privacy legislation in Ontario. Within a circle of care, information can absolutely freely be shared, and it is. And the challenge is that, of course, that's only a segment of the population and segment of the providers, and then the challenge becomes how do we leverage that information to drive change? We also have brilliant administrative databases that we use where we pool and aggregate information and keep it very safe and secure, and we run a lot of research on that. And we've been very fortunate to have that output. The disconnect that we're trying to kind of bridge in the conversations in my presentation was that when we run an analysis on a population level database on aggregate administrative data and we identify that there are 300 people who are very high risk in this population, we have no mechanism to get that back down to the individuals who are providing care. And that's the problem that we're trying to refer to here. But it's part of why we're proposing what we've proposed in this Start Simple model, is if we if we start simple with information that's relatively accessible or low risk, we can start to build trust. We can start to get people to understand what we actually want to do with this information, how it benefits them, and then slowly over time start to build that. And that's why I made the comment that I did. We have not necessarily landed on the fact that we have to ask consent or how that's going to work out. It's all up in the air, but we want to make sure it's part of the conversation early on because it's such an important piece of what we have to do. So.
Thank you for all the questions. These are really fantastic. I'm going to merge several of your questions that have to do with the people who are going to use the technology. Of course, this is an integrated care conference, and we are concerned and we are interested in how people are involved during the processes of both developing the technologies, implementing them, testing them. Some of the people in the audience were asking about the difficult, you could say more challenging profiles when you're involving older people with cognitive disabilities, for instance. How do we manage to be able to really involve these people in the process of development and implementation of technologies and also the assessment of them? And how do we make sure that we are really addressing the real needs? Yeah, please. Martin, thank you.
Yeah, just I think, at the Innovation Value Institute, we push a method called Open Innovation 2.0, and this is something we, developed with the European Commission, Intel, Maynooth University, and at the core of it is the idea that the customer or the user are just embedded in the innovation process. And that I mentioned the living lab concept. And actually, very often, the breakthroughs now are coming from individual patients or users, and that's one of the Copernican shifts. There's a real shift, and Eric Van Hippel of MIT talks about this, moving on from a producer innovation model to an individual user or consumer. So some of you might know the Medtronic 780G, that's a digital pancreas. The original prototype was developed by an engineer whose wife had a serious diabetes problem. I talk a lot about Angus Short. His wife had irritable bowel syndrome, and he himself developed a product that would allow closed loops or a digital medicine, looking at what's going on at the level of nitrogen in his wife's stomach after she's eaten. So the point is, digital is democratizing innovation, so it no longer needs a Siemens or a GE or Philips to do it. Tomorrow, Dr. Roisin Malloy, I'm presenting a case with her, and she saw her sister, unfortunately, who had terminal cancer, being woken up at night to have her temperature taken. She said, I think I can do this. So one engineer came up with a non-contact thermometer that actually has so many, but it's one person. So the idea of a user or a patient innovating and creating an innovation that could travel, it's no longer ridiculous, it's the reality. So I think that's one case. And then using the patients in the living lab to constantly give feedback, how they're using it. So just want to mention, I mentioned this device that I'm wearing, and I want to tell you that my pulse rate has gone down since I sat down. It's now 63. My respiration rate is 15, but actually my temperature, these lights are quite warm. My skin temperature is 31 degrees, but this device I'm wearing, I don't notice it. And in the future, we will all wear devices like this. Like, as John Shaw, a colleague of mine in Ireland, says, our cars are so better, much better instrumented. So we all wear watches. We could detect in the future, in terms of looking at population health, somebody might detect, you know what, in Belfast, 200 people, their skin temperature's gone up by a couple of degrees. What's going on there? We could determine it's the lights, or there actually could be some sort of outbreak. So, it's all, this new health system is about the patient, but it's also about the patient as an innovator. I'm so encouraged. I advise you, come to hear Roisin Malloy's story tomorrow. It's absolutely phenomenal. One person saw a problem that wasn't being addressed by the big companies, and she's developed an innovation that is absolutely spectacular and changes the patient experience. It completely eliminates risk around contact-driven hospital-acquired infection. So digital is so powerful now. One person, one patient can change the world.
Lars, please.
maybe I disagree a little with you, as I don't think we have evidence for continuous monitoring can provide us with any benefits. Luckily, huge companies are looking into this. I have an Apple Watch. No, I do not get any promotion for it, but I worn it since 2015. It means that Apple have all my health data for the last 9 years. And right now in the US, I know that you can go to clinics where you can approve they can access your data. They try to come with some recommendations, but still we do not know very much. But the question was actually, what do we do? And I also heard it as with the older 85 plus. What we know from research, both internationally, but also what we have done ourselves, is that age is not a limit. Younger people, some of them also have low levels of digital health literacy or technology readiness. Older people may have, but when you introduce technology to them where it's meaningful for them, it's only people with moderate cognitive impairment or really severe impairment for other reasons, being in care homes, where it will not be possible to onboard them. We have, when I say we, I had together with a colleague, Klaus Pannerat, we published in the European ERS, European Respiratory Society's monography here in December, 4 tables, and I will be happy to share them as they are open and can be shared. Unfortunately, maybe not the paper, but please contact me, then I can share these 4 tables. And it's actually about when you as a clinician meet a person, how do you meet them? Do you take the screen, if you have some data to share, do you present them together, do you discuss the data, assess you whether they have any difficulties like vision, hearing, or for other reasons, have problems, low level of health literacy. So you have a conversation around your data, and that way you can involve patients and you will realize where are the problems. And then if you introduce a new technology, we also have some recommendations for an onboarding process. We have some recommendations if you want to introduce new technologies in an organization. And I believe, with working with this for 10 years in different settings, that we are able to onboard most, and it's not age-related who we get on board. It's how we do it, and it is that we create the meaning. And it's very simple. If you have an Android, look to your Google Fit. If you have an Apple phone, look into your health kit. How often do you get into it? How many of the parameters do you follow? It's probably not, unless you're a quantified self person, then it's not many of you that are doing it. And I have 176 apps on my iPhone. I'm only using on average 10 of them. So it is really about making the sense, making the meaning, support people, have the conversations around the data and how it helps you. It is just a tool like many other things. We should not make digital tools something special or particular. It should just be embedded in our practice. And very shortly, we have a small study where we ask older people up to 90 years, only a small group, but the greatest barriers were if they have not had any kind of contact to digital technology in their work life prior, if they have lost self-efficacy in they are able to do it, and one of the reasons for losing self-efficacy was that their kids around 60 years old said they were not able to do it. So please don't tell your parents or grandparents they are not able. Support them as they can. Most of them can. And very many things of impairments can be mitigated, as both Android and iOS systems have a lot of accessibility tools. And that's a misunderstanding by many developers. Of course, you should make the UX design and user interface nice and needy for people, but the real accessibility things are handled by the operating systems. If you're aware about that, and if you program in a way where you actually get the API, where you get all the features of the accessibility things in the two systems, then it is possible to make real nice and needy apps, application or programs. So don't use a lot of effort, but go into what is already in the systems.
Thank you, Lars. Please, Matthew.
Just really quickly to kind of build on this, I think thinking about that population health approach and making a comment that I made earlier, we have to start actively targeting the people who don't use these things and start to develop them within those subsets of the population. I think that's why it is so important that we as systems adopt that population health approach and then use that more proactive outreach approach to identify segments of the population that otherwise wouldn't be brought into these design thinking labs and given these opportunities. So.
Could I make a really quick, I really support what you were saying about older people. Aisling Gannon is here, and her mum, showed a video of her mum last week when I was teaching the masters, and students thought this is probably the best thing they've ever seen. Aisling's mum used a Fitbit and a live core with her GP to diagnose supraventricular tachycardia. She had been to multiple cardiologists, done multiple tests, and they hadn't been able to figure out the problem. But an old person, Aisling's mum's, Doreen, says she hates the term geriatric, but using the Fitbit and the live core and working with her GP, she figured out what the problem was. She had an ablation, and she's doing an amazing. So I totally support, older people actually are pretty good at adopting this technology. Sorry.
Thank you so much. We have time only for one more. Thank you again for the questions. They are really great. There's a lot of interest on how these technologies for health might be both for some of the audience members, they can be an opportunity for citizens, for people living with conditions, but it's also, there are also questions about the threats that are involved in this implementation. One concrete question was asking about if bringing the hospital home could be a stressful situation for the people taking care of others who are really being sick. And I would like to add up to this list one personal one. I was having lunch a time ago with a friend of mine who's been a member of European Parliament, and I was speaking to him about integrated care approach and technology being used for bringing people back home. And he was saying to me, no, you shouldn't do that, because you know who's gonna do that? That's gonna be women. So we have been making an effort to bring equality forward, and if you bring the hospital back home, that will be increasing the burden mostly for women. So what do you think about these opportunities and challenges of bringing technologies home for care? We bring both for men and women, the system and society as a whole. Difficult one, huh? You asked for it.
Carers are probably the most unsupported. They are the hidden workforce of the healthcare workforce. So we need to do an awful lot more. But we had the privilege of having Professor Dan Lasserson, who's the head of Hospital at Home at Oxford University Hospitals in Maynooth, for a distinguished lecture on Friday. He goes out on a very powerful motorbike to actually visit patients, and what you could see, so older people, frail people who don't want to go to hospital can be treated in the home and diagnosed using, for example, like a butterfly POCUS device. But what we witnessed, and there was a BBC Panorama program of this, was clinicians coming to people's homes, with empathy, with excellence, and with experience. And in a randomized control trial, the results of hospital home far exceed actually sending an older person into A&E, and God knows what happened. So what they found in a significant randomized an RCT, on average, an older person that was in hospital at home saved the health system, the NHS, over £2,000, which is a lot. But the percentage of patients that then had to be transferred to longer-term care or didn't come home was, significantly less. So people want to be at home, and if you can provide the right supports, and you have nurses or care assistants calling or one-touch video calls, actually the burden, I don't think it can be a much better experience for everybody. But it is very important to involve the carers and their shared decision-making. So I think you can get, we all want the quadruple aim. People might be familiar. We want better care, we want lower costs or higher value, better patient and clinician experience, and better quality of life. And for an older person at home, if they can stay at home, Dan Lasserson talked about the onset of delirium that happens very quickly if an older person is in A&E or a hospital bed, and not to talk about muscle, deteriorating. So I think it's a far better solution, and the RCTs are showing this is a better solution for everybody, but it should be. The carer has to be involved, and it's about enabling and giving them a better quality of life.
I'm just going to keep jumping in because I really find this interesting, and there are digital solutions to solve this problem. I'm glad you mentioned the quadruple aim, though. So I'm a health systems guy, and I'm a linear thinker. So if you tell me I'm responsible for a population, I want to know who they are. If you tell me we should be accountable for the quadruple aim, we should be measuring it, and we don't do that. Right? So I think this is where we talk a lot about person-centered care. You want to talk about an opportunity. Some people would rather be at home. Some aren't comfortable in that space. We need to find ways to connect with people routinely, regularly throughout their journey to say, we'd like to send you home. How do you feel about that? You're home. How are you feeling? How are things going? And if we can empower people to check in, then I think that's where we can be more personalized in supporting the people who aren't comfortable trying, the hospital home type of approach. Make sure they get extra support. Some people are going to run with that. Some people aren't. Right? So again, I think it's something that we need to start building, that regular routine data collection, but then something has to happen. So when I click on my app to say, I'm not doing well here, I'm struggling, then there needs to be a system response to say, well, then how can we help you? Right? So it's super complex, but I think that those are things that we can solve.
Thank you so much. Any other response? Okay, I'm aware of time. Thank you so much for being here. I will take the last suggestion by Matthew. Empowerment of people using the technology must be at the basis, and really understanding their needs over time should be focusing on the development, implementation, and iterative testing and evaluation of technology implementation for health. This was an amazing panel. Thank you, all of you. Thank you very much.
distant lands and chant, there's always a powerful population. Someone from somewhere else will be asked as well. Culture, we've worked out, cultures are different in the different states. pronounce it differently. Coleraine. Anyway, so that's the only thing I've seen. I've got, like many Australians, I've got Scots and Scottish. That'd be great. What's the I don't have a card, and if I get out my phone, I'll plug it in. I give you the quickest one to give you is my private email, because I can say it and you'll be able to find a child.
Hello, everyone. Can we ask if Harriet Hiscock from Murdoch Children's Research Institute is in the audience, please? She's sharing the session. Thank you so much. Yay! We blame lunch. I know, it's lunch. I can if I... Yep, sorry. Oh, we were told.
That's what we call a rude awakening. Lovely to talk.
So that means if we...
This is just very high. Do these go lower?
It's only, yeah, because we've got one.
That's a bit better. No, you want us to sit in the audience.
Sit in the audience? Do you want to? Yeah, sit in the audience. All right. Yes. No, that's good. Okay. Welcome to the poster session, and please take a seat. This is going to move pretty rapidly from what I see, so if you're presenting, maybe sit in the front, don't go too far away. And we have 10 posters, so 5 sessions each, so I'd like to welcome Miriam up to the podium to present, and I will sit here and just give you a little warning when it's getting to 4 minutes, so come up and welcome.
Okay, thank you everyone. My name is Miriam Fernandez. I'm working at the Polivista Research Institute from the University of Valencia, Spain. And I'm going to present the next poster, Empowering Change, the impact of motivational interviewing on reducing frailty among older adults. So as we know, that the high prevalence of frailty in older adults and its association with a high risk of adverse health outcomes has become a priority for health authorities. However, traditionally, frailty has been assessed and addressed from a unidimensional approach based on the phenotypical model that refers only to the physical condition. Today, the most recent studies demonstrate the need to address frailty as a multidimensional approach, taking into account not only the physical condition, but also the social aspects, psychological aspects, nutritional aspects, and why not, the pharmacological treatment. So in other words, in order to promote effective interventions, we need to take into account the interactions between all these dimensions. So following this approach, an evaluation questionnaire was developed within the framework of the European Value Care project to measure the frailty of the older adults. And subsequently, A comprehensive and personalized care plan was developed and implemented for each participant, using the motivational interviewing for its ability, its capacity to motivate and promote behavioral change. As we can see in figure 1, in light of the result of the evaluation questionnaire, of the baseline evaluation questionnaire, the value care plan was developed in a process of co-creation in the primary care centers. Concretely, the professional, concretely social worker, and the participants met in order to establish the psychosocial intervention in light of the result of the evaluation questionnaire, and in order to establish also the goals to achieve by the participant. Taking into account also not only the results of the evaluation questionnaire, but also the interests and preferences of the patient. In this case, motivational interviewing was the technique used, evoking a collaborative conversational style based on empathic listening and respect for the autonomy to reinforce the patient's self-motivation and commitment to change. But why use motivational interviewing and no other techniques? Because in the Value Care project, we wanted to achieve in the long term and in short term the next goals. In the short term, we wanted to detect the psychosocial needs and interests of the person, to know the stage of change in which the person is, and to facilitate through motivation that the person is positioned towards the desire for change by helping to explore and resolve ambivalences about the unhealthy behavior or habit, and to establish and modify together with the participants the objectives to be achieved. And in the long term, we wanted to increase their social networks and participation in society, to decrease the feeling of loneliness, and also to improve psychosocial fragility. So now, related to the results, during the year-long value care intervention, more than 50 participants, including the psychosocial prescription area, participated together with the social worker in at least 4 motivational sessions. During the motivational sessions, the professional patient interventions allow to monitor and follow the progress of the psychosocial goals set, and to modify them according to the participants' progress, always reinforcing the intrinsic motivation and commitment to change towards healthier lifestyles. More specifically, we observe an increase in social contact with family and friends, establishment of new social networks among other project participants and the community, and a decrease in feeling of loneliness and psychosocial fragility. To conclude, this study focused on improving the care, well-being, and quality of life of older people with frailty. This study provides a broader and more socially sensitive view of frailty in clinical practice, assessing and addresses, as I mentioned before, the multidimensional condition of frailty from a holistic, collaborative, and personalized perspective, where motivational interviewing was the technique to optimize interventions, reinforcing patient motivation for behavioral change toward healthier lifestyles. And that's all from my side. If you have any comment, you can send me an email. Thank you.
Thank you, Marion, and that's fabulous for keeping to time. I'll just call up Jalen now, Jalen Layton. And fortunately, the way this session runs, there isn't time for questions, but please come up to the presenters afterwards if you have any specific questions. Thank you.
Okay, hello everyone. My name is Jalen Layton. I'm coming from you today from Canada. I work at St. John's Rehab Research Program, which is affiliated with Sunnybrook Hospital in Toronto. So today I'm going to be presenting this work on behalf of my co-authors that are not here today. And the title of it is Introducing the Long COVID Education and Awareness Hub, a public-facing resource. So our research has learned that people living with long COVID, like other chronic and episodic illnesses and impairments, are also being affected by their psychosocial health and well-being, which includes things like managing their daily activities, participating in occupational duties and social roles, engaging in meaningful leisure pursuits. As well, intersectional social factors such as sex, age, gender, race, ethnicity, socioeconomic status, and geographical location are important considerations when thinking about access to timely long COVID rehab and care in Canada. And so our research study was really interested in better understanding the lived experiences of people living with long COVID and their caregivers and healthcare providers working in the context of long COVID, and really getting an understanding of what we can be doing to support public-facing education and resources. So this project was funded by the Canadian Institute for Health Research, CIHR, and it started in 2021, where we pulled together a group of interdisciplinary researchers, scholars, and healthcare practitioners on our team. In phase 1 of this project, of this mixed method data project, we collected survey responses from over 2,000 people across Canada that are living with long COVID. We also conducted interviews with 52 people living with long COVID, 15 caregivers, and 34 healthcare providers. And then in phase 2 of this project, we facilitated 8 co-design workshops with long COVID stakeholders to co-design really what I'm showcasing today, but that's what has become the long COVID education and awareness hub. So it's a hub that supports education and awareness-based resources that are public facing and meant to help support folks and caregivers who are navigating the continuum of care while living with long COVID. And so the hub, there's 4 different pillars broken down into the hub that were brought out in the co-design workshops, which includes education, advocacy and public health messaging, so health and social care reform and care integration, and peer support. So this hub will be live, a live website. It's at www.livingwithlongcovid.ca. We're hoping to launch it in July of this year. And then for each of these pillars, we've identified with stakeholders some knowledge translation KT outcomes that we can do as part of this hub. So one of them being a documentary series that we just finished filming last week, and we are going to showcase on the hub. As well, we have just been funded for another project that will look at patient navigation models for long COVID in Canada as well. My information is on the screen, so if you do have any questions or you are interested in this project, please feel free to email me at any time. Thank you.
Jalen, that's a massive project and really needed across the world, I think. Next up, Sebastian Lindeblum.
Hi everyone, my name is Sebastian Lindblom. I'm a postdoctoral researcher from Karolinska Institutet in Sweden. I will present to you today, we can call it a research proposal. It's a project that hasn't begun yet. It's about sense making and within the stroke care trajectory. Just a little bit of background to begin with. We know that with the abrupt onset of stroke, it inevitably leads to a sudden change in life for both persons surviving the stroke, but also for the family. And it includes not only the process of rehabilitation and recovery, but also a process of making sense and adapting to a new reality. The recovery and sense-making process often includes the need for involvement of a range of service providers, but also need for intersectoral coordination and collaboration. Unfortunately, as probably in many other places, Sweden faces challenges and struggling with fragmentation and poor coordination of care and rehabilitation, which fails us to provide adequate quality rehabilitation and care, but also, maybe most important, services that are based on the needs of people and their families. At the same time, Sweden is transforming due to a governmental reform, trying to implement the new reform, Good Quality and Local Healthcare, which aims to implement the underpinning values of, let's say, person-centered integrated care, in a sense. However, we have problems taking this policy into practice, and at the moment, the regions in Sweden are responsible for implementing the reform, and there's a gap between policy and practice. And this project focuses on the Stockholm region and the case of the stroke care trajectory there, and contains the hyperacute, the acute, the subacute, and the community reintegration phase, which contains several different care providers, both from the public but also private sector. And the overall aim of the project is to develop a learning network for all of the stakeholders within the stroke care trajectory. That means stroke survivors, their families, healthcare professionals, managers, civil servants, and policymakers. And to achieve this, the overall aim, we have 5 objectives that we're trying to proceed to. That's understanding the current stroke care trajectory and how it's experienced by the stakeholders, and how they make sense of the current role, situation, and context. And further, to explore the needs, of the stakeholders, and also identify facilitators and barriers to developing this continuous learning network. And as I mentioned, we will use sense-making theory and participatory action research, including co-design as well, to develop this interactive learning network to promote person-centered integrated care. And in short, sense-making is the process by which people give meaning to their individual and collective experiences. But it's also a process of rationalizing what people are doing and why they are doing things. And this can be done both as an individual process, but also as a collective one. And to the contributions that we're hoping to get to, we hope to provide learning on how sense-making and participatory action research can be used to promote continuous learning, but also collaboration and knowledge exchange between these stakeholders. And further, contribute with knowledge on how the current networks and how the current stroke care trajectory can transform into a learning one. And the continuous network will hopefully also connect stroke survivors and the involved stakeholders to promote further learning and knowledge sharing, but also implement best practices and new innovation, and hopefully in long term improve patient experiences and outcomes. Thank you.
Thank you, Sebastian. You'll have to come back in a couple of years and report on your progress. Next up, Claire Ramsey. And Sabrina. You can introduce yourselves.
Hello everyone, my name is Sabrina Lynn and this is my colleague Claire Ramsey, and we work for the Northern Health and Social Care Trust here in Northern Ireland. And our poster presentation today is really to give you an overview of the Connect North service, which is an integrated social prescribing service delivered across 2 sectors in the Northern Trust area, and those sectors are health and social care and the voluntary community sector. But before we get into the presentation, I'd just like to acknowledge our colleague Mandy Wilson, who's here today representing IJIC. And it's IJIC who deliver Connect North in partnership with us as one service for the whole of the Northern Trust area. So Connect North is an integrated social prescribing service for adults living in the Northern Trust, and it recognises that health and well-being is about more than just our physical health, and it's affected by various social factors such as our finances, our housing situation, or feelings of being lonely or isolated. So Connect North aims to connect people with the right help and support to address their social needs, but within their own local community, and that's what's called social prescribing. So I'm just going to give you a wee bit of background to the development of Connect North. In around 2018, it was recognised that within the Northern Trust area, there was really quite a number of navigation, link worker, connector, social prescribing type services that were available, and they were all doing fantastic work, but it was really becoming increasingly difficult for service users and for referrers to be able to navigate these, and that was really due to differences in criteria, or perhaps it was geography. So depending on where you lived, your age, your health condition, you may or may not have been lucky enough to be able to access these services. And then alongside those, we were having some new social prescribing services emerging for both mental health and cancer-specific conditions. So at that time then, there was a decision taken at director level within the Trust to try and integrate those services into one service, and that was to try and create clear pathways, increase accessibility, and to free up some capacity within each of those services. So following on from that, we embarked on a 2-year period of engagement with our service users and a whole range of providers, stakeholders, referral agents, and that was really, that took place between 2019 to 21, and we had a break there with COVID, but that was really to determine what the core elements of the integrated service should look like and really what mattered to them. And what we found was the outcomes from that engagement was really similar across all of the stakeholders. The service needed to be holistic, it needed to have a single point of access, it needed to be personalised and provide an effective first point of contact, and really importantly, it needed to prevent our service users from being passed from pillar to post and continually having to repeat their story, and that's something that service users say all the time. So another key element of the service was to have a shared directory of services, a single directory of services that was available to everybody, and that included the general public, so that they could access information on services at that really local neighbourhood community level. And the co-production and co-design element with our service users has been very central to the development and the implementation of Connect North. They've been involved in every aspect, what I've already outlined, but also the name, the branding, deciding on what needs assessment tools that would be used, and then they also represent on our steering group. We actually have a service user who acts as our co-chair. So Claire's now going to introduce you to the operational side of the service.
Hi, so our engagement highlighted a very clear and overarching need for a unified directory of services for the Northern Trust area. Population Plus is our accessible online directory. It's available to anybody with access to an internet-enabled device, and it can be accessed via a web link or a QR code as shown on the poster. We built this and it now creates more than 800 services, activities and supports available for clients living in the Northern Trust area. This now means it's no longer necessary to refer clients to a third-party person like Connect North in order to provide that very basic and localised signposting information to address an already known and highlighted social or wellbeing need. By developing Population Plus, it enabled us to create a stepped model of care. That's also shown on the poster. This means that we can support more people with no extra resources to ourselves. At step 1, clients can access information regarding services and supports for themselves or on behalf of a loved one. They told us they needed to know what was available and to have easy access for it, and we've delivered on that. At step 2, where clients are maybe engaging with others, either within their community or within the wider health and social care family, they can be offered the information from Population Plus without either the need to directly access Population Plus for themselves or without the need for an onward referral and the passing of their information to another party. For clients where step 1 and 2 have been ineffective or inappropriate for whatever reason, the client can be referred to the Connect North service to have the one-to-one support of a link worker. The link worker will then undertake a holistic assessment of their wellbeing needs using a validated assessment tool, and that was one that was selected by our service users. That then forms the basis of a conversation to co-create a personalised wellbeing support plan which outlines the agreed actions for both the client and the link worker. The link worker then supports that client to connect with those services and activities identified to benefit them and offers follow-up as required by that individual in order to meet those health and wellbeing needs. So to conclude, the integration of navigation, signpost and link worker services in the Northern Trust area highlighted a number of historic and now avoidable gaps and inefficiencies both in the care journey and the system overall. The clear and consistent needs identified throughout the engagement process have become very strong anchoring principles for us, for our service, and we remain true to these as they continue to be regularly affirmed in day-to-day practice. So those needs, coupled with the lived experience, our ever-growing learned experience, the robust data collection and analysis of that data, means that our person-centred Connect North team are committed to a dynamic service improvement which is responsive to meeting the needs of our people. Thank you very much for your time, and our details are on there. Thank you.
Thank you, Claire and Sabrina. That's fantastic, really innovative work. Edward Sipler, please come up.
So I'm going to have slides instead of just the poster, because the poster has small print. You know, my name's Ed Seipler. I work in the Southeastern Health and Social Care Trust and Health Development. Delighted to have an opportunity to talk about this, because when you talk about well-being, the well-being of our population, but also the well-being of our staff, what we know, in Northern Ireland here, 19% of people have a mental health problem, but only 30% get any professional help. Now, what are the barriers? Now, stigma's in there, but it's not the main one. The main two barriers, perception and need. And that's a real Northern Ireland thing. I don't know if it's like that in your part of the world. Yeah, I'm okay. I'm all right. I don't need that. But also the availability and this visibility of services. So they're the two main barriers. And the need for early intervention is embedded in our mental health side. How do we intervene earlier with those barriers? So what we did, the session we had before in this room was about collaboration and partnership. Now, along Northern Ireland's a small place, so along with ourselves in health development in our trust, the Western Trust, that's only about 90 miles away, and ASSERT, one of our voluntary community partners. We took a series of written material that we had, 4 interventions. I'll tell you what they are. And these interventions have all been developed with service user involvement, heavy service user involvement, and they've been used extensively on a one-to-one board, written information. But then how do we get people help earlier? Well, let's create an online version of these interventions. So we created 3. One for parents. We took Dan Siegel's work in terms of working with children and improving emotional regulation, self-compassion, because the evidence around self-compassion, when you practice it, and the amount you practice it is linked to the benefits you get. So if it's online, people don't have to, they can read it, but they can watch it and hear it if reading's not their main style, and a low-intensity CBT-based intervention. Now, what we've been doing then from that is we've been training workers from September to now. We've had 12 sessions, 400 workers across the region. Now, that's why I said, you know, we talk about collaboration and partnership. Northern Ireland has 6 trusts. We have opened this training up to all 6 trusts. We don't care where they come from. And can I use a really nice word people love to hear? It's free. So that training's out there. We've got 4 more coming up. But when we did this training, we want to encourage our workforce to use these interventions. What did the training do? Almost 100% of those people, we did an impact survey. The 400 people, we got a 40% return rate. Not bad. That's acceptable. 100% of those people said, we got something we can use for ourselves with our service users. And 99.9% of people said, I've got something I could use for myself. One person said no because they said we would be better getting a written copy of this work rather than digital. That's okay. But the views, we're watching every month, the views on the clips on the online work are going up. The qualitative data, we were blown away by what workers were saying they were getting from this. This work changes lives, we're using it, it's helpful. But one team leader said, it has changed the way we work with people. You have given us tools now that can make a difference. So where next? Well, an added benefit, we weren't expecting this. 29% of people who gave us feedback were from the education sector, working with young people in schools, our communities, and the feedback they gave us, we're starting to use this material in schools. So what we're going to do now, because all the material is for adults, we have a working party formed. How can we adapt some of this material for young people? And I'm excited about that outcome. And another outcome that came, and I wasn't expecting this. Yes, this training is there for people to use it with their service users, but also apply it for themselves. From this work, one of our commissioners, our SPPG, asked me to do 3 support sessions using this material, and that's why I won't be here tomorrow. I have a session with the approved social workers across the region on using one of the interventions. So, where to next? We're talking to our commissioners. How do we support it? Share with people. We're launching our 4th intervention on using the polyvagal theory. But the only way to go forward is working together. We do have a flyer. If you want to take this away, give me a shout. I'll be sitting down there. And if you want to take away the flyer with the link, you're more than welcome. Thank you very much. Thanks for the time.
No, thank you, Edward. And we're running a statewide mental health in primary schools project in Victoria and Australia. I think my colleagues will be very interested in chatting to you. Sandra Bartolomeu, now how do I pronounce your last? Perez, welcome, come up.
I'm sorry to put you through that. That was quite hard. It's Sandra Bartolomeu Pitch, that's in Portuguese. Okay, so I'm a nurse and I'm a prototype researcher. And I'm here to talk to you about patient-public involvement. That is not the area of my research, but it's something I'm very passionate about. I study integrated care for people with neurodegenerative diseases, and I'm trying to develop a model that improves their coordinated care. Now, I'm doing it with them because who am I to say what would good care look like? So I've become quite involved with bringing service users with me on this journey. And I thought it was important to come here and speak to you about this, although this is not my area of expertise, Because my connection with other professionals, you know, in different countries, is that actually a lot of our colleagues do this as a ticking box exercise, because the funder demands it or expects it, and if you don't do a bit of patient-public involvement before you submit your application, you surely won't get funded. So you sort of rush, gather a couple of people, and you expect them to nod their heads and agree with your ideas. That is not involving patients in the decision-making or co-designing with them. So again, I'm not an expert, but here are some of our ideas in terms of what can be done. And I say our because I do feel that through my research journey, it's been crucial that my institution does believe that it's important to involve patients and the carers in decision-making. And you see the name Sally Dace there, and she's my patient-public involvement lead. Sally is a very expert contributor as a person that has lived experience with a neurodegenerative condition, and I'm very thankful to have her insights. Now, I know I only have like a few minutes, and I can't take you through the whole journey, but basically what I want to tell you is that you should involve people from the conception of the idea, develop the idea with them, until you actually implement the idea, not as a ticking box exercise. I would like to focus your attention on actually this part here where it says improved participants' experience with PPI ideas, what to expect from our interview. Wow, what does that mean? So a lot of colleagues can use it, or hopefully frequently use it, for example, to develop people-facing, participant-facing materials like a patient information sheet or a consent. And if you don't do that, you should, because you want to make sure that people understand what they're signing up to. But these, I've put it there because I really hadn't considered when I was developing the interview guide with my group with lived experience. One of them said, well, I think you should send them some of the questions in advance of the interview, which my researcher head was like, ooh, I don't think my supervisors are gonna like that much, because it's almost like they'll have time to prepare. And then I was thinking, well, I am working with people that potentially have cognitive impairment or people that are completely burdened by their carers' responsibilities. Why should I not give them the time to think about these matters? I'm not trying to catch them. So I thought, why not? So I ran the idea through my team, and they were like, ooh, I don't think that's a good idea. I was like, well, we did ask them, and this is what they're asking. Why would, let's have a go. So actually, this simple change, I've sent them a guide, an email just to say, this is what to expect from our interview. I want to have an informal chat with you, and these are the sorts of questions I'm going to ask you. And they were so welcoming. In the end of the interview, I always asked, do you have any ideas about how I can improve the experience for future participants? And I said, no, this was excellent. I really felt comfortable. I had some ideas of what I wanted to say. They could really, add their thought and their time and contribution into the project. And this was such a simple thing. Yeah. And the other thing I wanted to say is about dissemination. And again, we tend to involve them in the beginning and not in the end. So I was invited to present at BBC Radio about the project. And I invited one of my contributors to come and speak with me about how is it to live with a condition. I was there from the researcher perspective, but I have not lived with Huntington's disease, which is the disease I study. So the fact that she was there and she could speak about how it impacts her life while I was explaining why the research was important with her seal of approval made such a big difference on the response of the public. So I just wanted to challenge you in really thinking on how you can capitalize on this relationship with your public of interest. That's it. Thank you so much.
Thank you, Sandra, and a really powerful anecdote that's going to stay in my head. Philippa Homan, please come and join.
Hi, did you know that 30% of patients who had a heart attack experience a new heart attack within 30 days? And do you know why? I will tell you a story. One morning, John, a young computer engineer, felt a stomach ache which he associated with a hard night out with his friends. At night, with his family, he felt a chest pain and he faints. At the hospital, John couldn't believe that he had a heart attack. After all, he was only 40 years old. During the 3 days at the hospital, John thought about his lifestyles. Food choices and tobacco haunted him. 1 month after discharge, he began to feeling better. With the daily pressure, he began to smoke again and miss the important medication. Do you know what happens next? The chest pain returns and he went to hospital again. My name is Filipe Ome. I'm a nurse, a community nurse at the Cardiac Intensive Care Unit in Coimbra, Portugal. And John's story is usual at my daily work. So, cardiac integrated care, it's a participatory research which aims to promote better coordination between cardiology and primary health care to avoid hospital readmissions. A research group with cardiology and primary health care nurses, cardiologists, general practitioners, pharmacists, and people who have experienced a heart attack intend to analyze and improve the user's journey through the healthcare system. With the results of the literature review, the focus group with all the involved healthcare professionals and patients interviews, this group will co-create IMIC integrated care pathway. Once validated, hospital and selected primary health care teams will be trained with the support of a manual created by the team that you can freely download in Portuguese. With this project, John's story would be different. Returning to the day of discharge, together with health professionals, John set goals to manage his cardiovascular risks. Through the Health National app, he is trained to make health records. On the day of discharge, an alert is given to primary health care about John's health status. A month later, John had an appointment with his family nurse to confirm that he continues to take his 6th medication and there are no side effects. She also congratulated him for the 3 days non-smoking. John feels motivated to manage his cardiovascular risks and maintains regular online consultation with his family health team. Thank you.
Thank you, Philip. It'll be really exciting to see where that goes, and I wonder if mental health and support for mental health might play a part in your model as well. Claire, Fordyce, please come and join us.
Hello. My presentation follows on quite nicely from Sandra's presentation around PPI. So this is a project we did. I work in Belfast Trust. I work in a PPI team. And we were looking at collaborating to make accessible information for seniors across Belfast. This really came about part of the age-friendly strategy in 18 to 21. Really a piece of work that was actually co-created, co-produced with lots and lots of partners across Belfast. So the council, transport, older people's groups, health, and lots of others, all co-collaborated to make this strategy be. And we have another one in place now, but part of the commitment that Belfast Trust made at this strategy was to make sure that we were providing accessible information for seniors across Belfast. Belfast Trust is huge. We provide a lot of services in hospitals and in community, and a lot of regional services. But it was kind of felt that older people don't really know what a service does or how to get it. How do they get a referral? What does that look like? And very often I speak to people and they don't actually know the name of the service they actually need. They know they need a walking stick, they know they need some equipment, but they don't know how they get that. So it was to try and unpick that information, make awareness better and make accessibility better for people. So we worked together. It was during COVID. We worked together collaboratively with partners across Belfast Trust, across Belfast. We worked with older people's groups. We worked with the community and voluntary sector. We worked with charities, and we worked with trust staff. And what we created was a booklet, which I have a couple here. There's only 2 left, and I'll tell you why in a minute, but there's only 2 left. I do have one here. So this was a really co-produced piece of work. So we sent out lots of questionnaires. We did interviews with people over the phone. I did online focus groups. And we worked together. We had a bit of a steering group with our older people's groups who really steered the questions we should put onto questionnaires. They really influenced what information should be in the booklet, what it should look like, who should it be given to. Sandra talked about dissemination. They also worked as talked to how do we give this booklet out? Where will it be? What will it look like? So they did all of that work with us. And really, we couldn't have done it. It would not have looked the way it looks without collaborating and co-producing. So because it was in COVID, I sort of worked behind the scenes making the booklet be something, and then it was sent back to the team, to the steering group, to the older people across Belfast, and they were able to review it, come back with feedback, influence what was in it. Eventually we produced 18,000 copies that have gone all across Belfast. We used the older people's groups that we now have strong links with. They were able to give the booklets out, especially across when COVID was in place and it was more difficult to get to people. They were able to access groups across the city to give out the booklet. And it's been really, really well received. We're now in the process of reviewing the booklet. Because we're not in COVID, it means I can go out and meet people. So I've met with lots and lots of different groups across Belfast to make sure that we're delivering and reviewing a booklet that now makes sense for the next few years. We have an online version of this booklet, and we'll have another online version of this. We're also looking at accessibility online to make sure that this is not given in a format that's more difficult if you use an electronic reader. So it's just more accessible, and we're looking at language, ability to have this in different languages as well, because we're a very multicultural city, so it's just important that we have this in different languages for people too. So, 1 minute. So I suppose that really is me. I have a couple of these, if anybody's interested, just to have a flick through, you can do. We only have about 2 left because we've had 18,000 copies away out across the city, and we're looking to produce another 20,000. So it's just gone to the design team with a lot of work from the groups I've worked with. When we get the design back, it will go back to those groups. We will sit in a room, they will analyse it, they will red pen it, and they will bring it back to me, and they will influence how it looks and how we produce that going forward. So that's me. Thank you.
Thank you, Claire. Some really practical support. Shelley Doucet, if I got it right or wrong. Welcome, Shelley.
So full disclosure, I did not know I was doing an oral. I did not get the notification. So is it 4 minutes, 5 minutes? 5 minutes. Okay, perfect. Okay, so I was just jotting some notes down. I'm glad that I was one of the last presenters, so I had some time to gather my thoughts. Okay, so my name's Shelley Doucet, and I'm from Canada, where I'm a professor in nursing, and I'm also a research chair. So today what I'll be talking about is the work I do with the Centre for Research in Integrated Care. So I'm the director of the centre. We developed the centre back in 2018, and it's based out of the University of New Brunswick. New Brunswick is a province on the east coast of Canada. So essentially the main goal of our centre is to develop, implement, and evaluate integrated service delivery models. So the way we do our work is we do a lot of needs assessments at a provincial level, but also at a national level, identify where there's gaps or barriers in terms of accessing care, and then we implement evidence-based models of care within our province and oftentimes across other provinces as well. So I'll give a couple of examples of that in a moment. The work we do is across the lifespan, so we've done work with children and youth with complex care needs, all the way involving seniors with dementia. We use a multi-method patient-oriented research approach. So in Canada, we call it patient-oriented research, whereby we engage patients as partners throughout the entire research process. So they help us in terms of identifying priorities, identifying research questions, all the way through to knowledge translation. And we collaborate with a number of other stakeholders as well. So we have decision makers, clinicians, community partners involved in all of our research projects. And we also have a large team. So the center I direct, I have over 30 staff, plus we have nearly 30 graduate students as well who are doing research through our center. So we have several projects on the go. I'm just going to highlight a couple of them. One of them is that we're the New Brunswick node of the Canadian Primary Care Research Network. So this is a network that's been in operation since around 2015 or so, 2016, and it's funded through our federal government. It's nearly $20 million to run this national network that's all focused on primary care. So within this network, some of the work we do, just an example of a project is we have one right now called the OECD Paris Survey. So essentially, every province in Canada is doing research looking at how primary care is being implemented in terms of patient-reported outcomes and patient-reported experience measures, so that we can learn about how practices are working within our province, but also learn from across the country as well. And there's 20 countries involved internationally as well. So we're learning about how care is provided, like in terms of how we can improve care within Canada, but also informing internationally. And then one of the main initiatives, we do a lot of research around case management and patient navigation. So the research we do around case management is within this model of care, we have case managers who are registered nurses or social workers, work with the clients within the practices who are oftentimes the highest users within the practice, often going to emergency departments, to really develop an individualized, integrated service plan to help the patient around self-managing their condition, and also helping them to utilize healthcare services more effectively, but also so that they're more directed towards their needs. So we've been doing that since around 2015 across Canada. We also do a lot of research around patient navigation as well. So I know that was talked earlier. How many? Two? One? Okay. Earlier, I think in the UK, I know we've heard about link workers. It's very similar. So essentially, we have patient navigators who help individuals connect them with services and supports, health and social services, to really match their unmet needs to available resources. So we host a national conference called the Canadian Healthcare Navigation Conference. If anybody's interested in learning about that, it is a virtual conference, so folks internationally can join in on that. We've been implementing a dementia navigation program within primary care for the last couple of years, just as an example of a navigation program. So yeah, we also do several scoping reviews using JBI framework. So we use to look at the literature to see what research is shown to be effective. And we host a number of events, as I just mentioned one example. So I'll just close by saying that we are very much, we love engaging with other folks. If anybody's interested in any of the things I've talked about, please do connect with me. I think my contact's at the very bottom, and I'll be stick around. Thank you.
Very impressive off the cuff and very impressive suite of research that your centre is undertaking. Alison Holmes, come up and join us for the last presentation.
Thanks. Good afternoon, everyone. My name is Alison Holmes. I am a clinical specialist physiotherapist working in neurogerontology, and I'm also doing a PhD at the University of Limerick. We've heard in multiple presentations over the last couple of days about Ireland's ageing population and all of the issues that brings to our health and social care systems. But we work with a team for developing services for older adults that aims to promote integration of services. Older adults often fall victim to a healthcare model that focuses on treating single conditions in isolation, and it doesn't address the complexity and optimizing functional capacity. And we are sometimes quick to accept decline as a natural consequence of aging, as opposed to optimizing outcomes based on the person's individual needs and goals. We can also be guilty of focusing on GP, hospital and medical-based care systems, but what about all the adjuncts in between that support an older adult to age well and stay at home, or wherever they prefer to live? The Carlow Kilkenny ICPOC Community Specialist Team was established in 2021 in an attempt to provide an integrated approach to health and social care provision in line with Sláinte Care's right service, right place, right time mantra. The service covers 2 counties in the Republic of Ireland, and though they're put in under the same service, there's huge variation across the 2 counties in terms of their socioeconomic demographic in general from rural to urban, and lots of variations in their needs and their healthcare access. Even though it's a small area relative to Ireland, there's still a huge variation in terms of service accessibility across the 2 counties also, and with workforce issues, so access to things like home supports can become a bit of a postcode lottery. So we wanted to see what older people really wanted from their healthcare service, as opposed to assuming that we knew what they wanted. And to try and capture some of the variations in demographics, we decided we were going to hold 8 World Cafe style focus groups across both counties. So we held them in multiple locations, rural, urban, all community-based settings, to really try and make people very comfortable, very safe spaces, and to engage in really worthwhile discussions. So What were our results? 41 older persons with a mean age of 75, although that participants' age ranged from, I think it was 65 to 97 in older adults, which was great, and 23 health and social care providers, including third-party voluntary organisations, participated in the groups. 2 main themes were identified. And similar to what a lot of other presenters have mentioned today, these focus largely around access and communication. Access to things like in-person contact, access to transport, access to services within their locality, access to funding to provide services within the locality, and access to general supports to support them living at home in a healthy, safe way. The other big one that came through really strongly was the recognition of the person as a person and not as a condition by medical staff. So I think sometimes we can be really guilty of thinking we're doing a great job because we don't hear complaints. But in this population, sometimes they're just too polite to tell us we're doing a bad job. And sometimes we are doing a good job. But they usually tell us that, so we have to bear that in mind. So it was just really good to get out to the community and talk to people. So outcomes included lots of really positive actions within the service. So it included further engagement with stakeholders, feedback sessions, development of interagency collaborations, and also access to funding opportunities that we maybe weren't aware of previously. It's also informed a rapid improvement event which took place, on which my colleagues from the Carlow Kilkenny ICPOP team are presenting on tomorrow. So in conclusion, the poster probably should have been named optimising the continuous loop of care rather than an end-to-end pathway, because I don't think that's something that's ever going to describe care for older adults. But the findings provided valuable insight into what both service users and providers want from their health services to make them accessible to older adults, to make it an environment in which staff enjoy their jobs, and thereby informing future service innovation and planning. Thank you very much.
Thank you, Claire. And I just wanted to thank all the speakers for their fabulous, rich talks today and to keeping to time. So thank you. And that concludes the session.
nicht diese Töne, sondern lasst uns angenehmere anstimmen und
My name is Irene Sherry and I am the Head of Health and Wellbeing for Ashton Community Trust in North Belfast. And Ashton Community Trust was set up in 1991 by local people to create employment and services at that time for the residents of the Greater New Lodge, but that has grown to cover North Belfast, the whole of Belfast, and indeed regionally since. There's about 160 employees delivering quality services till about 5.7 million annually across 6 departments working to address the outworking of systemic poverty through health and wellbeing, childcare and family support, training, employment, youth, arts and culture, and through social inclusion programmes. In terms of the health and wellbeing services, I founded Bridge of Hope. It was set up in 2001 following a gun attack at our local centre here in the New Lodge area of North Belfast during what would be known globally as the Holy Cross. And at that time there was a lot of re-traumatisation of individuals who had been impacted by the conflict, and that exacerbated the need to get local place-based services to support individuals who had been impacted by the conflict. So within Bridge of Hope, we would have health and wellbeing caseworkers who would work initially to support victims and survivors to come in to do an individual needs assessment with them to see if we can support them internally through a range of counselling, talking therapies, life coaching, complementary therapies, personal and professional development courses and resilience-based programmes. We are also a VTCT Vocational Training Charitable Trust training centre, training people in body massage, aromatherapy and reflexology, giving victims and survivors the opportunity for development into employment for future development of themselves as well. We also would deliver a number of residential programs to support victims and survivors, and personal development resilience programs as well, regionally every year. We would have 15 staff, and we would have then 40 sessional practitioners between counsellors, life coaches, complementary therapists and trainers. So it is a great team, and we find now that, for example, over the last year, nearly 5,600 people were supported through the suite of services. And with that, nearly 18,000 engagements with them when they would have been attending for their services. So, I mean, I always look on it as that organisationally, it's a real honour for us that people put their trust and faith in us to help them on what can be a difficult journey in their life at that time. And I think that that's the importance of place-based community services being delivered in a local level, because we're there to wrap around in what we do. So if someone, for example, would come in through Bridge of Hope services, we would identify what their current needs are, whether they need support through a counsellor, through life coaching, through complementary therapies, or a combination of all of them, to support of our caseworkers, or if it's some training that they need. But we would also look outside the box and look at that holistic wraparound that Ashton can provide in terms of our childcare and family support. So we would have individuals, for example, who may find it difficult to come into services because they don't have anybody to mind their child. So we would work alongside our childcare to see if they can help and support us to enable somebody to come in and access that critical service for them at that time. We also would have a social supermarket, and we would have a community fridge. So victims and survivors, those impacted by poor mental health and those living with suicide in their families and suicide ideation, we can support them to access the community fridge or the social supermarket. So if someone, for example, is living in North Belfast and has several children, but is finding it different in terms of an increased cost of living crisis that we're currently in, and they perhaps are in debt and are struggling to manage and budget their money, we can refer them in through the social supermarket. They will get the support in there for debt money management. They'll also get support in terms of how to manage meals that they could provide for their family, and they will come in on a 12-week programme. So there's 20 families every quarter would come in through the social supermarket. There's also an environmental project of the community fridge that is open 3 times a week, 3 days a week, which was an appointment base as well, where people can come in for 6 weeks, and they could get food which is also environmental and saving it going to the landfill. And that is a great opportunity because there's great partnership with local shops, in terms of supporting that. And I think it's a great asset because it also enables people that when they are coming in, that there's no stigma attached with anything, which is really, really important for them. And they come in, they maybe get a cup of tea or coffee or a bit of toast, and get the opportunity, to feel safe, to feel comfortable, to feel valued, and also to see how they can be supported, whether it's through training and employment, maybe the children, through our youth, through our art services, or indeed through our social inclusion. So it's that idea that wherever anybody comes into the organisation, there's no wrong door, and we're there genuinely looking to help and support people. And I mean, for example, if I was looking over the last 23 years from Bridge of Hope, 38,000 people have been supported through our services. And, I hope that that people feel that whenever they come in, and I would know because we get so many cards of acknowledgement from people in terms of how our community-based services have helped save their lives in many times. And I think, you know, we always have to remember that we're here to serve the people, and that's fundamental in everything that we do. One example would be Healthy North Belfast. I have been the lead executive of Healthy North Belfast from 2018, where we launched an appreciative inquiry to try and address the poor health outcomes in North Belfast. And the reason for that was that historically we were seeing that, particularly in the areas of mental health and suicide prevention, that statistics were just increasing. And we kind of recognised that we needed to look at something different. And the idea of an appreciative inquiry was that you're not looking at the problems, you're looking at the assets, particularly the people community and the community infrastructure that you have and the current services that you have, to see how that can be utilised better for, you know, to develop better outcomes for people. But it's working at a community cross-departmental government level, and in 2021 the executive and ministers, many of them, joined us on a roundtable discussion and agreed to come on board with the oversight group that we had wanted to develop. And so now that the executive's back and up and running, it would be our aim and intention that we would reopen them conversations, because we have an action plan which we believe was the best opportunity to address the poor health outcomes in North Belfast. So if I look back over the appreciative inquiry, there was 1,014 individual conversations with local residents within the parliamentary constituency. They had been interviewed by 18 volunteers from 13 community-based organisations. We also held 50 events across the 25 wards within the parliamentary constituency, and we held a number of focus groups as well. And what we did at each stage of the appreciative inquiry process was that we kept going back out to the people. We kept holding public engagements and conversations to ensure that they were comfortable in terms of the developments of the action plans that we were developing to put in for implementation. So we got great endorsement, and we had a soft launch in 2021. Obviously with COVID, things have been hindered, and with the executive now up and running, we believe that from an integrative care perspective, that Healthy North Belfast, looking to the future, is a great opportunity for government to work along with us and all the statutory agencies for the betterment of the people of North Belfast.
Okay, good afternoon everybody. Thanks for joining us for this afternoon's plenary session. My name is Robin Miller. I'm the Professor of Collaborative Learning at the University of Birmingham, and I'm also one of the Editors-in-Chief of the International Journal of Integrated Care. And it's been a great pleasure to connect up with people who've got such a passion, interest and commitment to integrated care over the last couple of days. I was delighted to be asked to co-chair this afternoon's session, because in many ways I think general practice is the best of integrated care, but also in some ways the worst of integrated care. And what do I mean about that? Well, first of all, general practice contains a selection of very skilled professionals who are largely committed to making life better for patients, families and communities. And where they're configured right, they can bring together the different professional perspectives into an integrated care team that can respond to the many challenges and difficulties people face in their life. It's the best of integrated care because it offers the potential for coordinating care across somebody's whole life course as they face many different challenges, as they are affected by different conditions. And it can not only coordinate care in the community, but can also act as that important bridge between community and specialist services based in the acute and hospital sector. And finally, it's the best of integrated care because where general practice is rooted in its neighbourhood, it goes beyond the boundaries of healthcare, and it looks to community resources, to what people are doing for themselves in the local area, and tries to connect people up through social prescribing, community navigation and other services. But it's also, I think, in many ways demonstrates the worst, the challenges of integrated care. And it doesn't take long when you look at integrated care in any part of the world before these challenges come to the fore. The first is, how are general practice, and in particular general practitioners, funded, incentivised? Does the funding enable them to be coordinated care? Does it allow them to collaborate with others, or does it require them to focus on a fixed range of medically orientated tasks? Is there true interprofessional working within general practice, or actually is it dominated by one professional voice which crowds out different perspectives and different framing of somebody's issues, and how could they be supported? And finally, the many issues that we face in health and social care in terms of retention and recruitment and the capacity pressures that people face in their day-to-day practice is affecting primary care and general practice too. And that can lead to people not feeling they've got the time, the energy, the capacity to be that coordinated and integrated focus that they can be. So, for all those reasons, general practice is the best of and the worst of integrated care. And we're going to have a fantastic session this afternoon. We've got leading speakers from New Zealand, from Canada, and from Europe, who all not only understand the context and the opportunities of general practice within integrated care, but have actually made it happen in their own work. And I know we're all going to be very inspired by what we hear from them. But we're going to begin with a voice from a local older person in Northern Ireland, Billy, and my co-chair, Sarah McLaughlin, from Mid and East Antrim Age-Well Partnership, is going to introduce herself and introduce Billy. Sarah, would you like to come to the microphone?
Bit of a change in the microphone levels there for me and Rob. Good afternoon, everyone. Thank you so much for having me here today. I'm delighted to be co-chairing this panel. My name is Sarah McLaughlin. I'm the Executive Director at Mid and East Antrim Age-Well Partnership, which is a small older persons charity in a small part of Northern Ireland. I was also the Strategic Improvement Coach for the Impact UK Centre in one of the first demonstrator sites last year. So, having previewed some of the presentations you will hear today, I feel very comfortable alongside these panellists who have noted very similar experiences and points in their delivery of integrated care in the community, and in particular the role of general practice, a key partner that we at Mid and East Antrim Age-Well Partnership have been working with since 2017. So a little bit about the project that I lead on before I talk to one of our amazing service users and a member of our lived experience group, Billy Johnson, who has joined us here today. As Adam Lent from New Local said earlier today, people are experts in their own lives, so Billy really knows what he's talking about. Impact Age-Well is a community development approach to integrated care for older people, and it was created through our Older Persons Charity back in 2017 with funding from the Dunhill Medical Trust. We work with people over the age of 60 who live with one long-term health condition, and they work with our officers through home visits over the course of 6 months, where they work together on the older person's health and well-being through a holistic approach. Referrals into our project can come from the GP themselves or their team, from social workers, or anyone can self-refer into the project. But the GP and their team are involved in the screening of the referrals and also in the case discussion through bi-monthly locality hubs. We work with the whole GP team, not just the GP themselves, from the practice manager through to the admin team as well. The GP federations in Northern Ireland were also key partners in the coalition that helped to set up Impact Age-Well back in 2017. And this was a unique model of care based in the community for older people. Our partners included the local council, the local health trust, and our community pharmacy partners. We started out in 2017 with 6 GP partners on a pilot basis. And now we work in 2024 with all 22 GP partners across our area. We address the person's social circumstances as well as their medical circumstances and anything that affects their health and well-being. Therefore, the older person is perhaps less likely to present to the GP in recurrent visits or to A&E, freeing up capacity in the health service for others, and also enabling the older person to be better connected to more appropriate services which are often based within their community. We're striving to build connections for older people through community assets, whilst joining the dots between health professionals themselves, who quite often have never sat down around a table together. They do this in the bi-monthly locality hubs, sharing information around the service user and then learning from each other's expertise. In the post-COVID world, GPs have been a really key partner. In a time of perhaps inadequate and uneven access to GPs, we have been able to be agile and enable our GP partners to provide our support to them, but also to give an essential bridge to older people in their time of need between the GP surgery themselves and their patients out in the community. So now I'm going to talk to Billy and get his real life experience of what support has been like through Impact Ageville. Just checking that we're on, okay, that's great. Billy, could we start by you just introducing yourself to the audience?
I'm Billy, I'm 87, I live alone, I have no family, and I had just lost a daughter to a brain hemorrhage and was involved in a local GP at the time. And that's how my introduction to Ageville came about.
And tell us in your own words just a little bit about the support that Nicola was able to provide to you over the course of the 6 months and how that has made a difference to your health and well-being.
Well, GP surgery phoned Ageville. Nicola arranged an appointment, came down to see me. This was in the middle of COVID, I should say. First meeting we had, we sat in the garage and talked with our masks on. But she had said that she tested herself for COVID every morning before she came to work. So we eventually let her into the house. I was very much self-isolating at the time, had very few visitors. And we got off to a good start, we got on well. At that first meeting, Nicola told me a lot about Ageville, how they could help me possibly, and bought me a lot of leaflets. We arranged for her first of the 6 appointments, and I must admit that at that stage I was more interested in what practical things Ageville could do for me. And I did have 4, 5 things done. I had a key box fitted to the outside the garage for my house keys. I made use of the handyman service. I had a visit from a chap from Abilitynet regarding some things in the computer. I had a visit from a chap from the local council on safety in the home. There's a couple of others, but I just can't remember them in the minute.
And did you know those types of things existed in your community before the GP referred you into Impact Ageville?
Not from a charitable organisation, no, I didn't. Really, I knew very little about Ageville. I had heard the name, nothing else.
And tell us a little bit about the role of the GP in that referral. Do you think that that made a difference to you engaging with Impact Ageville?
First of all, I was quite impressed with the GP surgery because at a time when they have little time for anything else, they obviously had known my background. They told me that I fulfilled the 6 criteria to join Ageville, and they made the actual contact for me with Ageville. So that made me feel quite confident in the practice, and I gave Ageville, whom I knew very little about, a certain degree of authenticity since the referral was through the GP practice. And that's really how it came about.
And tell me, just in closing, how important was it for you to be able to come here today and give your point of view on how this has supported you and the difference it's made?
Nicola came, as said, we had a good relationship. We talked generally about my health, about my overall well-being, and gradually, as the number of appointments rolled on, I began to realise that whilst I had the practical support already, I was getting a degree of mental, emotional support by her visits. As I said, she was one of the few people allowed into the house. Her visits were very welcome, and I felt that she was providing a degree of support which at the time I probably really needed. I didn't possibly appreciate it so much, but with hindsight, I did definitely appreciate what Nicola did at the time.
And so now you are one of our founding members of our lived experience group at Agewell, and the future is going to be very busy for you, no doubt.
I look forward to it. I certainly endorse Agewell. I think it's a very good organisation. I would very much like to see some of the innovative approaches they've made to older people extend far outside our small local area. Would even hope at some stage to see some of those things incorporated into statutory care for older people. And really, that's about it.
I don't think we've any more to add. You have been very eloquent as always, made my job very easy.
Well, as really, you have been the strong point, and you and Jenny in Agewell, and all I can say is, well done, Sarah.
Fantastic. What a powerful endorsement of integrated care within a general practice context. Right, I'm going to ask our other three speakers to come up, Amarjit, Richard and Jan, if you could. And we're going to start with the rest of our speakers with Amarjit Maxwell, who's the Chief Executive Officer of Think Aurora, who's based in New Zealand. Amarjit, over to you.
Well, that is a bit tall, isn't it? But hopefully that works. That was a very rich conversation to listen to, so very grateful to be here to hear that. Kia ora koutou. A greeting of hello to everyone here in Te Reo Māori, the Indigenous language of Aotearoa, New Zealand. As this is the country that I represent, I am proud of the small country that really is a small nation but punches well above its weight. And as Robin said, I am the Chief Executive of Think Aurora, a primary health organisation in New Zealand. Now I will click. So this is a picture of Castle Point, a place that I hold very dear to me, and it's the place where my husband and teenage children are at right now. So I have a serious case of FOMO, fear of missing out, because they're having a holiday. But I promise you, I will lean in and be very present here today, because this is an important event. And they told me this morning and said, "We miss you, Mum, but we're very proud of you." So I hold that dear to me. So I originally hail from the northeast of England, so you may actually detect that Geordie accent in my voice, and so it is a bit of a giveaway. I'm an avid Newcastle United fan, and so I look forward to some of those games, which I understand there are 2 this week, so I'll be trying to hunt that out. In terms of what I'm covering, I'll basically be providing that some of the insights from Aotearoa New Zealand on the role of general practice in terms of integrated care, the general practice as a wellbeing partner. So my aim is to keep you all tuned in, and then obviously we'll follow on with the co-presenters and look at the aspirations of general practice as a wellbeing partner. So this is what I'll cover, some of the common themes as well in terms of global, but just very high-level snippets in the time. Taking a collective action approach and bringing a case study. That's where the real richness is, and will be in the case study from the Indigenous leaders of Aotearoa New Zealand. And then just a few reflections there. So the aspiration of general practice as a wellbeing partner with general practice being considered the cornerstone of health. And the aspiration, I believe, is ultimately that well-being partner. And what does it really mean, I guess? What is the problem, or what are the problems we are trying to solve? Is it better access to care, improved health outcomes overall in terms of equity? We know that there are dire issues across the world, globally, within healthcare, not only the medical side, but the social aspects as well. And there's plenty of evidence that will be shared as part of this conference. And I guess the theme of this conference around taking the leap and making integrated care a reality, that's the magic for me, because it's taken these learnings from these sessions and other hubs and actually making it a reality. So in the New Zealand context, we have an Indigenous whānau ora model, whānau meaning family, and there are a number of themes here. Now, I've included the Indigenous language here. It is an important part of the cultural aspects within Aotearoa New Zealand that we are very proud of and hold dear. I'm sure, as I say, some of these themes will resonate in terms of that overall pathway to support and health equity, including that self-management, family cohesion, living healthy lifestyles, participating in Te Ao Māori culture, and that really understanding of how that embraces a holistic approach. And then right through to being stewards of the living and natural environments and being a healthy and or just a participant in society creates that community cohesion, and then obviously economic and security wealth. So the academics have suggested that addressing the wicked problems of health inequity requires a whole of government approach and constructing and managing collaboration of many interested parties. The primary health organisation that I lead within Aotearoa New Zealand is one of 31, and you can read there the actual role that we hold, and it is a population health approach. It is bringing the community together to actually support holistic care, and that is what excites me in terms of my role. It isn't siloed. It is working with local government. It is working with social providers. It is working with lived experience. It is bringing the magic of the people and the relationships together. What underpins our system in Aotearoa New Zealand is our a treaty, Te Tiriti o Waitangi, and that has a real focus on equity for Māori in terms of Indigenous people, and the focus on that allows us to move forward in a way that if we get it right for our Indigenous populations, we'll get it right for everyone. So there is a lot of literature, as I say, on integrated care, and some of the common themes in the piece of research that I did on ChatGPT came up with this list, and you'll all be familiar and it'll all make sense to you, but there are health and wellbeing hubs across the globe. It isn't new. It is just really how do we get some of the reality into our everyday work. Some of you may have attended my workshop yesterday on connecting communities for wellbeing, where I shared the integration theme of weaving as a strategy of Think Hauora, and this provides a platform for connected care with key pillars setting out the strategic aims. The aspirations of general practice to focus on health and well-being continues to be a journey. There are so many factors that prevent progress, whether it be workforce and funding, shortages, or increasing complex conditions. Given the need within our communities, we must continue to forge ahead and make integration a reality, not just an aspiration. How we've been talking about it for years, and I think that's why I'm loving, as I say, the theme of this conference. The focus of the strategic aims of Think Hauora includes building health, fostering well-being together for everyone, with multiple partners working to support whānau, which means family. It is these relationships that will move us forward. So ultimately, this is about networks of mutual benefit formed by interconnected, interdependent, synergistic relationships. There's a lot of big words in there. And Collaborative Aotearoa, which was an organisation that I led until recently, coming into this role, they advocate for a collective action or a collective impact approach that supports complex multi-organisation projects to support what sometimes are called the wicked problems. Apply this to general practice as a wellbeing partner, and I believe we can start to shift the needle in terms of positive change for our communities. It will be a mindset shift, and some preconditions will be needed. Being ready for the change is important, and this is an ongoing movement. So bringing it down to reality that I'm talking about in terms of what is happening in our communities within Aotearoa New Zealand, the real pockets of excellence. So best care whakapai hauora is demonstrating innovation in practice, in general practice. And it is actually happening. It is an Indigenous iwi. So Whakapai Hauora is an Indigenous provider based in Palmerston North, offering a wide range of health and social and disability support services tailored to the needs of community. It is a service that looks after over 2,500 patients, with over 85% of those classified as high needs. Now that is a small population base, but it does mean they can take a real local approach and very much an equitable approach. The national and international changes towards high-performing primary care over recent years has included a focus on patient-centred and seamless care across primary, secondary and community-based services. Best Care continues to transform into a fully integrated service that ensures all services are delivered to meet the varying needs of the community. The Te Ara Whanaora model, which you can see linked back to the beginning slide, that concept is used throughout Indigenous organisations within Aotearoa, or versions of it in terms of holistic. So I won't obviously read those out again, but they are an exemplar, and the service was born out of necessity for those with the greatest needs, taking a social determinants of health lens. So this model of integration recognises holistic Māori view of health and links between health, culture, economics, social standing, and historical events, including historical trauma. And it is one based on equity. These pictures depict a family-centred approach which includes cross-sector providers, general practices with extended care teams, so not just the GP, not just the nurse, but health coaches, health improvement practitioners, dietitians, to name a few. But mental health and addiction services, counselling, access to food, a kaumatua or elder support is highly valued within the service. And quite uniquely, they have a radio station to build connection with the services that they offer. And it is about actually creating that connection with the community, with those that actually are needing care, access to care. And whilst this integrated approach sits apart from many others, it still faces the challenges of workforce funding and dealing with the complex nature of social determinants of health. We can be proud of the achievements given the current climate, and we need to encourage others to embrace this approach as the norm. So Best Care Whakapai Hauora continues to seek the input from its community and values lived experience. Through the patient voice, their recent qualitative study captured some of the barriers to achieving better health and well-being outcomes. And ultimately, recommendations were sought from the lived experience, from those connecting with their service, and they actually go some way to furthering their fully integrated approach. So I personally will watch their journey with interest and continue to support from the perspective of a primary health organisation. And it is something to be proud of and seeing it in action. And in particular, I do need to acknowledge Rangatane o Manawatu as the iwi, the tribal group, leading the work of Best Care Whakapai Hauora, with the ongoing support from Te Tihi o Ruahine, which is an alliance of 9 hapu iwi and Māori voluntary organisations and service providers who come together to inspire a collective approach. Now, it's worth emphasising that this is an alliance, and we've had conversations about alliances here at the conference. And alliances do work, based on trust and connectedness, and that is actually the key. I want to move on to, hopefully I'm doing okay for time.
4 minutes.
Okay, I'm getting there, I'm almost wrapping up. So I want to move on with the voice of general practice in terms of, in particular, the voice of a general practitioner to begin with. And this is a long quote, but I really felt that to cut it down wasn't doing justice to the voice of the general practitioner. And Dr. Andrew Miller is certainly forging the way of general practice as a well-being partner. He personally created what was called a well-being model based on a Te Ao Māori, an Indigenous model of care, Te Whare Tapa Whā, and he is absolutely on this journey. So I'll let you absorb that rather than read it out. And Dr. Kirsty Lennon, who actually happens to be my family GP, but she certainly is a supporter of integrated care and is very future focused. And again, taken forward that vision and aspiration of how to become a well-being partner, working with all of the social services, voluntary organisations and lived experiences as we've talked about. And Jane Aylan, a Director of Quality and Culture, a primary health nurse. Now, she is a nurse in the district that I work, and they are deeply embedded in their community. They run community days. They work with Kaumātua, the elderly within the community, and they're part of a collective impact initiative. So we are very lucky to have the forward thinking and seeing it in action. And Dr. Andrew Williams, he is also in the district that I work in. He is a primary care leader across New Zealand, and again, forging the way of really listening to the voice of the patient and empowering them in terms of self-management, and that's really been his passion. So highlights in terms of supporting this shift. General practice is more than ready, and is ready for being a well-being partner, despite the many challenges. We need to learn from our Indigenous communities across the world as we move towards holistic care. I do believe with the movement in terms of Indigenous leadership in various countries, the answers of that holistic care is going to pave the way for us. So we need to continue to support this shift, and the PHOs, or the primary health organisations, as the meso-level organisation, we hold an important role to support at the local level. And to finish, I will share with you a proverb from New Zealand and the richness of the wisdom of words. I hara taku toa, I te toa takitahi, engari he toa takatini. My strength is not that of an individual, but that of a collective. And I think there's no truer word said than being at an integrated care conference, and it is this collective that will move us forward, and it is about taking the leap to reality. So thank you for listening.
Thank you, Imogen. What a fantastic example of a community-orientated wellbeing approach in general practice. And I should have said, we're going to have questions at the end of the speakers, and you can either ask questions directly or you can put them in the app, and then Sarah and I will give them to the speakers individually or collectively. So next, we're going to go to Canada. And we've got Richard Lewenchuk, who's the Senior Medical Director for Integrated Care in Alberta Health Services. So, Richard, delighted you could join us today, and we'll hand over to you.
Thank you very much, Robin. I guess I made it to the podium without tripping or knocking over a water bottle, so I think I'm doing pretty good so far. At this point in the conference, I'm not sure what I'm going to tell you that you haven't already heard, so I hope to reinforce some concepts and perhaps demonstrate that maybe what we hear isn't just ephemeral ideas, but are things that apply in real life. The title that was proposed to me, as you can see, is Enhancing Care in the Community Initiative in Alberta, the province in Canada where I come from, making the case for change and making it happen. And I think that's actually probably a pretty good title. So I'm just going to deconstruct that a little bit from the perspective of general practice. Now, I've read a number of books on change management, and what I've garnered from them is two principles, is that in order to effect change management, either you need to make the current state so untenable that people want to move forward, the so-called burning platform, or you want to make the future so attractive that people want to move forward towards that. Just proves a human can still do better than generative AI in summarizing books. So what is then the case for change in the title? What are we making a case for change from? Well, I think this is pretty applicable almost anywhere in the world. What is the state of primary care or general practice these days? Well, it's typically too many patients and not enough time to see them all. In our province, our country, and in other places, general practitioners function on fee-for-service, so they can only bill a fixed amount to the government, and yet their costs are escalating disproportionately, so there's financial pressures, increasingly complex patients, increasingly complex treatments which they have to keep up on, and they're certainly reminded about all of this by their patients through Dr. Google. Increasing bureaucracy, paperwork, forms, obligations for continuing education, and just the ability to try and keep up with knowledge. People whose chronic conditions are not being controlled. Chronic disease rates have not, control rates have not changed in 20 years globally. Increasing burden of mental health in primary care, and then therefore having to default to reactive care instead of proactive care, which is not a very satisfactory way in which to function. And so there's two highly applicable cliches which we cite. And then the first one is that, well, it's not hard to make the case for change from this. You know, we can't keep doing the same thing and expecting different results, a saying often incorrectly attributed to Albert Einstein. And the other thing that we hear over and over again is that the current system is not sustainable. And if you do check with Dr. Google, you'll find out that there would be 550,000 hits on that phrase. So how we approached this was really by making it happen and not in a top-down manner. So in other words, our thinking is that we were not going to set up a very onerous governance structure with steering committees and working groups and rules and regulations and policies and a whole bunch of subgroups with all sorts of acronyms. If you're thinking I'm referring to the NHS, I'm not. You might be, but I'm not. And so this is how we started, and I think this is applicable in any facet of integrated care. And so we started with creating a shared vision. What did we see as the future? What was the optimum future state? So approaching primary care, particularly the physicians, we said, we came at it from the what's in it for me. If I'm a family doctor, a GP, why would I want to change? What's in it for me? Well, so we would say, well, think of what really spoils your day, or what sort of patient, when you see them on your roster for the day, really makes your heart drop. And so some of them would be that person with nothing really wrong with them, but they keep coming back and insisting that you must be missing something. Or the patient with a chronic condition that just never comes under control, despite their promises that they're going to follow their diet or exercise or lose weight. Or the person who you know has some sort of a social issue, but you don't know what to do about it. You don't know where to refer them, so you sort of ignore it, and they are too embarrassed to bring it up. We offer, we can help you with this. So doctors like data, so we often use some of our local data exemplified here. So we looked at the number 2 chronic condition in the world, diabetes, and we said, can we predict whose diabetes will be controlled? Because that's one of the challenges of primary care. 80% of primary care is managing chronic conditions. And we said, you know, we looked at all of the factors that lead to diabetes control, and using medical administrative data, we just cannot predict whose diabetes will or won't be controlled. On the other hand, if we add in social data, immediately everything becomes clear. And you can see that here in the work that we did, that depending on your income, or your income was the best determinant of your diabetes control. The lower the income, the greater the social need, the poorer the diabetes control. So we leveraged this data really to say, it's not you, it's them. In other words, the problems that your patients are experiencing and the challenges, the social challenges that they're having, that's what's getting in the way of medical care. So, can we help you in this? And so this slide maybe been better titled, Do You Know? But this helps us also leverage further knowledge to say, by the way, did you also know and understand or realize that 80% of modifiable health has nothing to do with the care you provide, but is related to social factors? Or that 40% of primary care encounters have a mental health component? Or 1 out of 6 visits to a GP are related to loneliness? Or the biggest care gap is in people who can't, won't, or don't see a family doctor, not because of their negligence, but because they're more concerned with, am I going to have food on the table tonight, or am I going to be evicted tomorrow? So they don't have time for silly numbers on a blood test or on a machine. Or a common reason for not being able to control a chronic condition, as I already showed you, is because of social issues. That maybe working with a well-assembled team might mitigate some of this issue, and that indeed the world will not come to an end if our funding model changes from fee for service to some other form of perhaps capitated funding. And then finally, health is, as is said in Costa Rica, is really a form of wellness which is created by community, and you are part of the community. So as was highlighted, and this was already mentioned in this meeting, the Fuller report, that it talks about teams and teams of teams, and we offer this to general practice. Have you thought about what is possible through team-based care? And when general practice is thinking of this, they're typically thinking of the team in my clinic. So that's where we start from. So we say, what do doctors do well? What could the doctor do as part of the team? Well, doctors are good diagnosticians. They can manage complex patients. They can liaise with the formal health system in terms of the ER or the acute care hospital. In our country, we have nurse practitioners who are very good at chronic disease management or who can carry out care in niche areas such as women's health or children's health. We have chronic disease nurses and dietitians who can work with patients experiencing chronic diseases, social workers or linkers, or we call them community health navigators, who can help identify and address social needs. Mental health counselors could be in the practice. Specialists could come and visit, and a whole host of others such as physiotherapists or kinesiologists. But then we pull the ace out of our sleeve and we say, but there is another whole army out there which can help you. And that's represented here. Who else is part of your team? Well, starting front and center at the top, family caregivers. In our system, it was said yesterday, 70% of care is provided by family caregivers. In ours, we measured it 66%, so pretty close. Those people are on your team. So a little bit of care and attention to them, understanding their role, can help you a lot as well. About 20-some% of care is in the form of self-care. So anything that we can do to facilitate self-care will be helpful to you. Then, of course, there is the formal healthcare system, the backup from specialty clinics and emergency departments and hospitals. In our system, we have provincial government ministries that provide social services or children's services. They're on your side too. Municipalities provide a lot of care and social care to individuals. They're part of the team as well. The third sector, the volunteers, not-for-profit, and charitable organizations provide a lot of that care. Even businesses and the community at large, that's all your team. So just applying it in one setting, we took this team-based approach, incorporating social determinants of health, and we married it to asset-based community development, the assets that exist or could exist in community. And the child they had was this Reducing the Impact of Financial Strain program, which we started to beta test. And this was the classic NHS type of social prescribing, asking people about, do you ever have difficulty making ends meet at the end of the month, and other screening questions for social need, and then if positive, handing over to the linker or the community health navigator, but at the same time, helping the community understand the services that they might be able to also contribute and provide. So for example, the number one need in primary care is mental health supports. And so people can't afford $200 an hour for a clinical psychologist and psychiatrist. They're busy working with psychosis and schizophrenia, but what people needed was just help with anxiety or stress. And so what did the communities do? They set up coffee clubs for new mothers or single parents or people who are unemployed, and they would share with each other. I believe the technical term for that is peer support, all created by the community at no cost. That is part of your team. So really, if we get to this point, and when we got to this point, if we look back, what has now happened is that integration has occurred at the primary care level. So integration with the social sector, so with the volunteer sector, the government, the parts of the government that provide social services, municipalities and the community at large, integration with mental health services, integration with other paramedical services such as optometry, audiology, physiotherapy. We would say, remember, they're there too to help you. Integration with specialty services too. So all of those relationships then create a really, really large team in order to provide that care in the community. So what did we learn? Well, we learned first of all, and we've heard this before, primary care is about relationships. It's not about transactions. So if you're new to this meeting, you'll hear us talking about stories, anecdotes, experiences. That's the language of relationships. If we're talking about transactions, then we use statistics. So you won't see a lot of graphs with P equals whatever in this meeting. The other thing we learned is absolutely complex adaptive system theory applies, as do principles of a learning health system. Now, I've read all of John Holland's books, the guru of complex adaptive system theory, and I've read all about learning health systems. So in case you haven't, I'm going to summarize those books for you as well. So this all boils down to, don't worry, relax, you're never going to get it right, so just do the best you can, continually measure and adapt. That's a big relief to many of us. Oops. I am not quite done yet. Anyway, I was going to say, what were the last two slides were, what were the results? Well, the results were, there's a nice little slide that said oh, here we go, thanks. This is the results, is that really when primary care makes this transformation, and I really mean the word transformation as we talked about yesterday morning, they become the zealots, the doctors, the other members of the primary care team and our primary care networks and the community itself. And as I heard one GP say in one session yesterday, we ain't ever going back to the old way. And we don't have any trouble with spread and scale. In fact, our challenge is to hang on for a second. We need to get in behind you to provide you with the supports and infrastructure. So really, just to conclude, when we have a common vision, when we have common knowledge, common understanding, incredible things can happen. And as we like to say, in order to gain power, you have to give up power. Thank you very much.
Thank you very much, Richard. Not only a fantastic example of how general practice can go beyond social prescribing to take an asset-based approach to community development, but also some very helpful summaries of some of the key academic texts. So thank you for that. And our fourth speaker is Jan de Massinier, who is a family physician, but a leading academic and change agent in primary care and primary care's community orientation. And I've had the pleasure of knowing Jan over a number of years through his work with the European Forum for Primary Care, amongst others. And he always brings a commitment and energy and enthusiasm and reality to his talks. So it's going to be a great conclusion to our session today. Jan, over to you.
Thank you very much, Robin, for this nice introduction and for the privilege to share some ideas with this wonderful audience. I was given a not so easy title, Social Cohesion and Primary Care, How a Social Movement for Change is Improving the Lives of People in Flanders and Belgium. I think that needs 10 PhD researchers to show the evidence, but nevertheless, thanks Fiona for the challenge. I will try to make it a little bit happen. Okay, that's not interesting. My story starts in 1968. I was a young student at those days, and I was impressed by what was happening in Berkeley and Paris with the May '68 social movement. The elderly people in the room know what I'm talking about. The youngsters don't have to be disappointed. If they don't know it, it doesn't matter. And some of the ideas that were very dominant in that kind of change, societal change, were the attention to the person and looking at different dimensions, not only the biological, but also the psychological, the social, and later on the ecological came back. So this integrated approach. Second important element, democratization of the higher education. I had the opportunity to study to the university and to become a doctor. My parents only had the opportunity to study until the age of 14 years. So all of a sudden, thanks to the bursaries and to the political decisions, we had access to opportunities that would never have been there for the previous generations. Other important point, you don't have to interact in an hierarchical way with other disciplines. Was also very important for us. And especially when it comes to healthcare providers that is needed, but also when you interact with a patient, that should be a horizontal interaction. So this concept of equity, people are of value because they are human beings. And equity also as a characteristic, it was demonstrated by the previous speakers how important social determinants of health are. And finally, the movement for civil rights, so also the patients wanted to have a say in the healthcare system. And that was all very inspiring and very challenging, and some of these things have been moving forward, but others have still a lot of things to do. And the way we wanted to do that as young students, and we are quite a lot of us, some of them are in the room, Dr. Ide Ridder was also one of those students that said, we have to make another kind of doctor. And moreover, we will not do this, what we want to do, only as doctors. We will need an interprofessional team. And so the societal movement and the way we filled in our professional definition, our professional career, they came together. And we started with community health centers. I will not tell you the long story about that, developments in the US, interesting developments in South Africa, but Canada was important, and I know that many Canadians are in the room. I have to say thanks to them, because the Clinique Communautaire Pointe Saint-Charles in Montreal in 1968, there was an interesting experiment by medical and nursing and sociology students of McGill University. They started a community health center. And there was a Belgian professor over there studying what they were doing, and he brought the good news to Belgium. So the fact that we had this movement in Belgium was also related to the developments in Canada. And that's why this international exchange is so important. So we started 2 years before us. Ide Ridder started already with a community health center, and then we started in 1978 with a community health center. But we had to define what it was and to make it happen. There were 4 projects like that in the same period. And we just started like family doctors in a poor neighborhood. That was, of course, a choice on purpose. And then we integrated nurses, social workers, and we started to make a not-for-profit organization that we called a community health center. And then, of course, in 1984 already we had an interprofessional team. And from the very beginning we saw that it was needed to have an other payment system. And interestingly, after 9 months that we were working, all of a sudden came the declaration of Alma Ata, saying that we should do what we were doing, building community health centers. Because if you read the Alma Ata declaration, it's all about cooperation, it's looking at the community, it's looking at social determinants. So the question, what was first, the community health center or Alma Ata? I have to disappoint WHO, it were the community health centers. Nevertheless, we have been working together and we have been exchanging a lot. Let's make a jump. I will do that in this presentation by time and while to 2024. The team today is family physicians, nurses, dietitians, health promoters, dentists, oral hygienists, social workers, occupational therapists, and primary care psychologists. We take care of 6,400 patients coming from 95 different countries. So every consultation is a journey around the world. In order to do that, we were convinced that we had to change the financing system. The previous speaker spoke about that. And so we tried to build a capitation system without co-payment for the patient. And That was one of our first action points. Already in 1982, we negotiated with the National Institute for Health and Disability Insurance, and we said, we want to have a capitation system. And it finally materialized in the 1990s. Of course, we had to wait for the computers because those systems were too complex to run in a handwritten context. And nowadays, more than 500,000 Belgian citizens are cared for by providers that work in a capitated system, which is integrated needs-adjusted capitation. And the aspirations we had by creating this way of payment was that we would like to increase accessibility, no co-payment, better continuity and comprehensiveness, looking from different dimensions, a more horizontal relationship between provider and patient and between different healthcare providers, working together in teams with nurses, physiotherapists, doctors that were integrated in an integrated way paid. So one capitated sum for the 3 disciplines. So then you have to work together. Opportunities for better compliance for the patient, because we can follow them better. A focus on prevention, be it because it pays off in a capitated system. Competency sharing and subsidiarity, of course. And working on quality improvement. And there are indicators and evidence is there that antibiotic prescription is better in practices that are paid in a capitated system. The use of lab testing is more rational. And of course, the integrated care is better. I jump back to 2023, this publication last year by Catherine Danieux from the University of Antwerp that demonstrated that the chronic care model in Belgium was better implemented when you look at the assessment of chronic illness care, the IJIC scale, in practices in a capitation than it was in practices working with different disciplines in the fee-for-service system, and of course monodisciplinary practices in the fee-for-service at the least good scores when it comes to integrated care. So at least there is a kind of correlation and relationship between payment systems and the way we organize our integrated care. And of course, that's important to have this evidence. I will take you now in a walk down memory lane with a focus on social cohesion and integrated care, and I will start at the nano level, because we still are convinced that this is where it happens. When a patient has to have trust in a team of healthcare providers, it happens at the nano level. In the interaction with patients nowadays, patients are more active, they are more challenging for us as care providers, they are better informed, I read in Google, they want a high quality of service, and they are more and more multicultural. And so we have to work in order to make accessibility a realistic project, but without barriers, administrative barriers, financial barriers, cultural barriers for the patient. And of course, contributing to equity is a major task, taking into account the importance of social determinants of health in the situation of people's lives. And of course, we all know what are the characteristics of these primary care patient encounters. It's always with the letter C. It's about commitment, connectedness, social cohesion. It's about clinical competence, cultural competence, looking at context, at comprehensiveness, complexity, coordination, continuity, and the big challenge between compassion and computer. Always difficult. And immediately started activities. Already in the 80s, there was a symposium on primary care, the first in Belgium. 29 innovative experiences were showcased by the King Baudouin Foundation. That was at the federal level. Very interesting, but already it made clear that it would not be so easy to implement all these principles in the Belgian context, because there was an immediate reaction. This meeting took place in the Royal Palace in Brussels, and the conservative doctors reacted in the press, writing, the Royal Palace was taken over by a group of left-wing primary care providers. So it was clear that it would not be an easy journey. But the Minister of Health, the Regional Minister of Health, immediately started an action and a working party on the horizontal cooperation of care professionals in primary care. And they defined that it would be important to have a Belgian structure in Flanders structures to integrate primary care. So from a policy level, it was very interesting. And the report even suggested that we propose to create a specific institutions at the level of the Flemish community, for instance, the Flemish Institute for Primary Care. That was written in 1983. This happened finally on the 14th of January 2019. So you need patience if you want change to see happen. That was the nano level. Let's come now to the micro level, where we started, of course, with our integrated care team. That was what we wanted to be. We wanted to work together. Later on, we integrated the goal-oriented approach that we talked to you about last year in Antwerp. Of course, we took the environment and the home into account. Integration of health and social care was very important. Social worker was very important. And care coordination by patient, informal caregivers or professional happened. And the interprofessional discussions, sometimes in presence of the patient, were very important. We learned so much from each other. We learned how the different professions looked at the same situation, and that was for all of us a learning process. Apart from that, of course, the different disciplines had still their own ways of discussing and organizing their work. And very important, we saw the need for an integrated interprofessional health record. And what we did, we took a doctor's health record and we said, let's write all in that record. And we added so the nurses, we added the different care providers, the social workers and so on, all used that same episode-oriented record. That was not easy, but of course that was not enough. And that's why I was very happy that 2 years ago, the minister asked us to look at the fundamental reform of the electronic health record to make it more fit for purpose when it comes to integrated care. And so there's actually a project in Belgium, the Belgian Integrated Health Record. A group of people are working together with administration and the cabinet very hard on this. And at the federal level, we are creating this principle of a kind of platform where we will have the episodes of care and all the providers, all the healthcare providers will write on that same patient-related platform. Also, the patient himself will contribute to the information gathering. So no more exchanging information, but co-creation of information is the aim. At the same time, from the Flemish side, there is a care plan that has been developed. It's named Olivia, to translate all the different activities of the providers in one integrated care plan. And of course, I hope that both now will be integrated and that we finally will arrive to what we really need, such an integrated approach. Going back to the 80s, in 1986 we said it's not enough to work interprofessionally. Let's work intersectorally. Let's see how we can provide healthcare in the different conditions of the communities where we worked in. Because the communities where we worked in were characterized by huge amounts of poverty. So we took the initiative to bring together not only the primary care providers, but social care workers, policemen, staff from the local schools, community representatives, in order to bring coordination of care. And so every 3 months, since 1986, we have been meeting with 40 to 50 people. Information exchange was important, participation and analysis was important, and together we made a community diagnosis, not of a patient, but of the community as such, seeing what were the determinants and then leading this to actions about physical fitness, intra-family violence, housing problems, traffic safety, drug addiction, and so on. So, intersectoral action for health, and of course, we assess that regularly. One example, we are back now in 2022, so I jump in the time, was this initiative that we took with the Community Health Center to bring in our community after COVID, the people together in order to see, when we have problems, when we have lost people, when we are depressed, can there be a consolation spot when we can help each other to better cope with these problems of mourning, which is universal. And we did not want to do that through medicalization, but through normalization of those feelings. And how to do that? Well, there was a public space, and it was the public himself with a local artist that created the structure of these consolation spots with different stops: fire, water, tree, wind, sound, and earth. And here you have the circle of fire, where it looks like a campfire space, but the warmth of bringing people together in meeting each other, giving each other hope and courage was essential. And what we see now, there are organized activities, but more and more people are sitting themselves together to talk about the loss they had, about what they encountered in their lives, the depressive episode that they were going through. The water is the beautiful view. It gives a mirror, it gives peace. And you have to look in the mirror. Who are you? Who have you become? Who do you want to be? And so you saw that local in the community, there was connectedness in this project, and it all contributed to social cohesion. And actually, after 2 years, we have to say, it's a very original way of bringing people together and improving their mental health conditions by organizing activities, but also by people interacting with themselves. And this project was one of the projects from the Caring Neighborhoods project that were organized by the Flemish community. 132 projects of this kind have been started up in local communities from the 1st of March 2022, and 40 million euros was paid for these projects, and in all these neighborhoods, something happened in order to make the neighborhood more caring.
2 minutes, Jan?
Yes. Okay. Now, I will not go into detail about the organization at the meso level. You know that we have 60 primary care zones. That's working quite very well, and that's well organized. And we try also to bring population health management in that local environment. If I can just give a quick example, this is what we saw as care providers, what we saw as nurses when we looked at the toddlers, the children, their teeth. That was absolutely dramatic. This was really a problem. We talked to the mothers, and they did not know what to do. They gave sweetness to the children and these kind of things. And we did a survey at the age of 30 months, and we saw that 80.5% of the children had already early childhood caries, 7% in the high socioeconomic groups, 30% in the low groups. Relation with deprivation, nationality, and of course, no consultation. We started a project, I will not go in detail, but we started now a project so that actually in Flanders, in all the regions, children are tested at the age of 30 months, and that we have improved the dental care. We compared the situation of today with 20 years ago. Today, we are at 11% of the children affected by early childhood caries. It was 18% in 2004, but we have still a long time to go. The Flemish Institute for Primary Care is doing wonderful work in supporting the different primary care zones that each cater for 100,000 people. So that's really a structure that works well. We embrace the quintuple aim, that you are all familiar with that. And the Flemish Institute for Primary Care is trying to help the different primary care zones to cope with the challenges. And of course, this is work in progress. They are very young, and they have still a lot of things to do and to learn. Let me then come, and finally, there's also an interfederal plan for integrated care that will be the driving force for transition towards a better coordinated, integrated care. What can I learn from this interview? And I come to my conclusion now. Well, a central concept in this overview is social cohesion and connectedness. And I'm more and more convinced that social cohesion is a structural determinant of health. Social connection, it's so important because it brings connection to others via the existence of relationships. It creates a sense of connection that results from actual and perceived support or inclusion in society, and a sense of connection to others that's based on positive and negative qualities. So it's really important that we see how primary care can contribute to social cohesion on the one hand, but social cohesion is also a prerequisite for solidarity in society so that people can help each other, informal caregivers. There is evidence that social connection and cohesion is a causal determinant of health. So when it's there, it improves health. And actually, OECD even developed an indicator, social connections, so that it can be measured, and in the future it will be available as data for analysis, and I think it will be an important point. But social cohesion has also a connection with the policy. What you see here is on the x-axis, the horizontal one, the voters for the Sweden Democrats in Sweden. That is an anti-establishment radical right party. The higher the voter share for SD, the lower was the COVID uptake that you see in the y-axis in a municipality. And I'm convinced that there is a role of distrust that explains this. Distrust in government, distrust in institutions, and probably lack of social cohesion and social disconnection. So I think that more and more we will see that there is a linkage between strong primary care leading to better social cohesion and also leading to more democratic developments in society. and I think that we need that. Did we make a difference? I think we have to be modest. But some things happened. The strong focus on generalism helped us a lot. Attention for underserved groups and proximity is very important. Implementation of community-oriented primary care, look at the dental project. Innovative models of interprofessional and intersectoral approaches. Innovative payment systems, very important. And integration of primary care, social care, and public health. The focus on social cohesion and connectedness becomes more and more important, and advocacy and policy development are important. So, by doing so, we follow the WHO's call for leaving no one behind. And I can announce you that next month, this interesting book will be published by WHO, Implementing the Primary Healthcare Approach, a primer, which focuses a lot also on integrated care. It's already available on the web. Finally, connecting with international people is important. So, now comes my last slide. But the problems are, and I think we are all aware of that, neoliberalism in the previous century and the actual evolution towards stronger extreme right-wing parties does hinder social developments. My concern is, will the new European Parliament have a majority that support human rights? There are a lot of interesting organizations like this one that contribute. My final conclusions are, if you want change, be patient in order to observe progress. And I want to quote also our Federal Minister of Health, Frank van den Broeke, resilient health policy is based on science and solidarity. And I think that's very important. Thank you. If you want to read more, that's my book. Thank you.
What a wonderful conclusion to our four fantastic speakers. And I would recommend Jan's book. It really is an incredible oversight, I think, of the power of primary care. So we've got about 15 minutes for questions. And Sarah, I think you're going to chair the question and answer sessions. We have got a few questions on the app we're going to ask. And Olivia and Justin stand ready with the microphones. So they're going to dash up if anyone's got a question. So Sarah, over to you.
So we're going to do a wee bit of audience participation, get you all involved in the questions and answers today, and not make it easy for you. So but the first question that really seems to have gathered some attention is around carers from Richard Mead. If Richard Mead could stand up and identify himself, and then we can get a mic to you. Right up at the back. So I think that's a question that has come up in previous sessions as well around the idea of carers and how integrated care supports them. So over to you, Richard.
Thank you. Yeah, I'm Richard Mead. I actually work for a charity that supports unpaid carers. And unpaid carers play such a huge and important role in supporting people, particularly in the community and especially in home settings. But they often don't get identified. They don't get the support that they need as carers to be able to provide the care that they're giving to the person they're caring for. And one of the people that they're always or often in contact with is the primary care setting, is the GP, is the district nurse, it is people in those settings. So my question really is what more can be done in those primary care settings by GPs, district nurses, etc., to identify unpaid carers and to help them get the support that they need to continue to care?
Can I ask Richard to take that question first?
Thanks very much for that question. If you look to your right, the lady in the red jacket can tell you everything that you need to know about that. Sharon Anderson, she's presented twice at this conference and is a very strong advocate. We work very closely with her with the organization in Alberta, of Caregivers Alberta. So we hear that over and over. So one of the things that we've had to struggle with is, first of all, just identifying the family caregivers so that they are known to the system and known in primary care. We ask about emergency contacts, but we don't ask about who is the family caregiver. And then there are some very simple things that we hear about. So just the acknowledgement of their existence and of the role that is played by them. Just the simple question of how are you doing? Is there anything that we can do to help you? And this is the agreement we have in our provinces. If that response is positive, then we can hand them over to Caregivers Alberta. That's something simple. We hear another prime need is for day programs for the ones that they're often looking after or caring for, such that it provides the family caregiver with some respite. It provides something for the person who's receiving care to look forward to. Often the family caregiver may even choose to accompany the person to the day program to be with them. There's a whole long list of things I know that can be done. We're trying to systematize it, to create awareness at the primary care level and at the system level, because we're never going to hear or have enough personal care workers globally. So we really do need to honor and support the family caregivers.
That's fantastic. I think from our perspective, in a local organisation, when we went out to speak to our service users and their caregivers and asked what they really needed, what came back very loudly was practical help. And it was being able to give them practical help so that they could spend quality time with their loved one, as opposed to, being the main caregiver and being in that role. But definitely get caregivers to identify themselves and actually see the role that they're in can be very challenging at times. Another question then that came through was to yourself, Amarit, around your approach at Think Aurora and how that could translate to very diverse inner city populations.
Is this working? Yes. I think the example I gave was actually an inner city population, very much very small, not one of the major cities in Aotearoa, New Zealand, but certainly an inner city population code often defined as 4412 because of the high needs that exist. I do think the whānau ora approach, or that approach to integrated care, translates across all localities or all place-based planning, and that is really what we're working towards in terms of making it the norm. And is that answering it enough for you? Certainly, I guess it transcends communities, and it is really about each community has different needs, and using the data to then actually work through what those needs are, and also the patient and the lived experience voice, and getting that qualitative data and going, what are the services that need to be wrapped around? And that's what Whakapai Hauora have done in terms of looking at the needs and saying, well, what is the makeup of services? They have a Ministry of Social Development caseworker funded by central government, but they're actually integrated into their workforce and on-site. Child, Youth and Family, Oranga Tamariki, are also on-site. So those were some examples I gave earlier, but not the two I've just added as well. So there will be variances across different communities based on the need. And it is about that listening, which we heard earlier today. And I think listening to understand is absolutely where we should be.
Okay, and then we're going to go to Renzo de Gabriel, who has asked a question around the teams. If Renzo can put his hand up, identify. Yeah. So it's around the team of teams and challenges, which I was very interested in.
Yeah, so basically we passed through right now also in Malta the setting up of these integrated teams, and we face a lot of challenges. And I wish a bit to know how the challenges you met, how they were addressed, and move forward. We heard about trust, about collaboration, but the practical thing on how a couple of two practical examples.
Okay.
Thank you.
If we can go to Jan's first for that, and then Richard maybe.
I think it's very important that we, from the very beginning of the training, the undergraduate training, that we start to think in terms of team. Medical students, I know them very well. After 3 years, they think that they are real doctors, and it is very difficult for them to learn and to change their mindset. So it's all over after 3 years. So in Ghent University, we made a reform of the training program, and also in other Flemish universities, the programs have attention for interprofessional cooperation. And that's from year one. So that they already see and look together and talk together. And there are huge opportunities. If you have a clerkship in a nursing home, all the disciplines are there. Why not putting the students there, and so that they can learn from each other? So we have a systematic program developed from year 1 to year 6 in undergraduate track for the doctor, but also together with the nurses, social workers, also occupational therapists and so on. Because once you have established disciplines, there is a process of identification with that discipline, and reinforced by the law that sometimes defines that the nurse has to do this, and that cannot be done by an assistant nurse. And so everybody starts then fighting for this own domain. And if you reinforce that by a fee-for-service system, then it's completely over and out. So that means you have to start early, and then you have to see and to make sure that all the drivers go in the correct direction. The correct direction being focused on the patient, working together, looking at complementarity, openness of information, and horizontal relationships. And I think that that is the challenge. And also when you see then these teams in practice functioning, you see the problems that are due to the training. And that makes it so difficult because you have to repair a lot of things that originally are there. I see in the first year, there's no problem. Students in medicine, students in all kinds of disciplines, they talk equally to each other because they don't know a lot already. But once they have established their profession and professional identity, it's more difficult. So start early would be my advice.
And Richard, could you talk a little bit to the inclusion of the wider community organisations in your team of teams and how difficult or how challenging that may have been?
We, I absolutely agree with Jan's points, but also, so as I said, globally we have this challenge. As I said, the first challenge, too many patients, not enough time. Our average panel size in our province of Alberta is about 1,600 patients per family doctor, complexity dependent. But I've been to places where the panel size has been 9,000 or 10,000, and not in a bad way, and that's because of the team. And so the team may incorporate, as I said, the nurse practitioner who looks after women's health, the mental health counselor who relieves the burden of mental health counseling and does a better job than the doctor might be able or have time to do. If we strip off 1/6 of the people who are there by identifying their loneliness, quickly the doctor is doing doctor things that only a doctor can do, and the team works very cohesively. In those practices, they're extremely happy because everybody knows their role, they work together, and then when you realize you have those external resources that you can call upon the community, for example, and they will also help manage some of the social issues. I forgot to mention earlier on in response, also the principle of asset-based community development, of the community helping to look after its members. It's not those people that are there, the criminals, they're the elderly, they're the mentally ill. No, they are part of us, and so it's our job to look after them as well. So that is part of the team as well, and can really contribute to relieving the strain in classic primary care.
Okay. That's fantastic. I think that wraps up the session for this afternoon. I'd just like to thank all of our panellists, in particular Billy Johnson, for joining us today. Please feel free to connect with any of us after the session, and I think it's now coffee break. Thank you.
nicht diese Töne, sondern lasst uns angenehmere anstimmen. Und freudenvollere.
donde quieras. Ahí, sí.
This is a mixed language presentation.
Can I invite the panelists to... Okay, welcome everybody to this session, this sub-plenary, and title is Learning from the Hard Reality of Trying to Create Integrated Care, Reflections from Research and Implementation. And let me explain how we came up with this session. So we had 2 workshops submitted to the conference, and then one was more on research and evidence of what was going on in the United Kingdom. And then there was this other one which was more experiential, was looking at the experience of people trying integrated care for a while, and then how they were, so the thinking was, if I had known 10, 15 years ago when I started, it's not that I wouldn't have tried, but I would have done things differently, no? Or I wish I had learned where I started. And then the scientific committee challenged us to do this combined workshop, and they said, we're going to put you in the auditorium, and this is going to be live stream. I would say fantastic, but the challenge was how to actually, if you remember, the title of this first plenary, From Evidence to Policy and From Policy to Practice. So this sub-plenary actually is trying to do that jump from evidence to policy, from policy to practice. And if you remember the sub-plenary, there are 2 words missing, politics and then back to evidence. So we are going to do something which we hope you find interesting. Let me explain that how it is going to be structured. 3 parts. Part A, we are going to start with the research. So the Nuffield Trust, our colleagues from the Nuffield Trust are going to present the research on the UK. Then we are going to move to part B, experiential, and we've got representatives from Catalonia, the Basque Country, and Wales. And then part C is you. Part C is the audience. We are going to engage through Menti, which we'll explain later, and we are going to be voting and discussing, and then we are going to have this conversation with a panel and with you about, now we are starting the journey. Probably some of you have just started your journey on integrated care. Some of you have been going on this for a while, and that's what we are going to discuss. I've explained this, and now this is my request, that people there, if you want to move back, if you don't want to move, that's fine, so we can be closer, and then when it comes to voting, it's going to be more fun. And then also, we are going to have microphones. So that's the idea. People up there, if you guys want to move up here, it will be much appreciated. If you want to stay where you are, fine. But it's just that it's easier then to engage in the conversation. And I'm going to stop here and give the word to my colleagues from the Nuffield Trust. And then we are going to start this part A on the research and the evidence. What does the evidence tell us about the integrated care and the challenges and the opportunities of integrated care? So you introduce yourself, and please, the floor is yours.
Thank you, Arturo. So, Kemi and I are joining you today from the Nuffield Trust, which is a charitable think tank in London which studies health and social care across the UK. And what we're presenting comes from research that we did about 3 or 4 years ago, trying to learn some lessons from the progress of integrated care across the UK. And we reflected that over a period of 20 years, since around the turn of the millennium, when health had been devolved to Scotland, Wales, and Northern Ireland, and particularly since 2013, each of the countries had come to have major national policy drives to create better integrated care across health and social care. So we aimed to compare across their initiatives, to look at the levers that they used, and as far as we could, to look at the success that they'd had, and what we could learn from that, particularly now, as each of those countries moves into a new period of further initiatives to try to achieve integrated care. So I'm going to begin by giving a quick overview of how health and social care are structured in each of the UK's countries, and what this means for both the position going into integrated care as a policy aim, and some of the structural changes created as a result of that. So we see, first of all, a comparison of the 4 countries in their spending on health and social care. And important points to note here are that spending per person on health is currently reasonably similar in each country, but somewhat higher in Northern Ireland and Wales than in England and Scotland. And that possibly reflects political choices and funding patterns, but also that Northern Ireland and Wales, for different reasons, have particularly high healthcare needs. You can see that the spending on healthcare as a share of total spending on public services is quite similar between the different countries. The same is not true for social care. Spending on social care is very different between the countries. Northern Ireland spends far more than the other countries. England spends less. And spending on social care as a share of total spending varies as well. Now that tells you that while the UK generally shares a model funding healthcare, paid for by taxation, largely free at the point of use, although England charges for prescription, the offer for long-term care and support is very different in these countries. Each country does have a model where there is a means test. You don't get publicly funded social care unless your assets, your pension, often housing, fall below a certain level. But these vary between them. Wales has a more generous threshold. People start receiving funding sooner. Scotland also a somewhat higher one. And for each of these, you'll have to be eligible in terms of your needs for care to be allowed to receive state-funded support. So in general, a much less comprehensive system. But the countries differ not only in the thresholds, but in the additional support they offer. England doesn't offer any additional support, but the other countries have added guarantees of free or accessible care for people. A cap on non-residential care in Wales, and that's free in Northern Ireland. And Scotland offers free personal care and free nursing care. So while that doesn't cover all social care, it's a meaningfully more generous system. Well, let's go through the countries just very quickly. Don't worry, I don't expect you to remember all of these very complicated diagrams. England in particular likes to have a nice complicated organisation chart. But it's worth noting that you'll see here the separation of health and social care going up. Healthcare on the left side as you see it, funded by taxes through NHS England. Social care to your right, funded through the Department for Housing and Communities. Social care is held by local authorities who are also responsible for housing and transport. The NHS is a national system. You can see that England has integrated care systems, which councils sit on, but they're fundamentally primarily overseeing the health sector. And England has separate providers who compete with one another called NHS trusts, who actually deliver secondary care across mental and physical health. If we look at Wales, we see a simpler structure. There's the same divide between social care held primarily by local authorities, but health is both delivered and planned for by health boards, which cover different areas of the country, and services such as ambulances. And both are accountable more closely to the Welsh Government at the centre. You'll see the regional partnership boards connect the social care holding and healthcare holding services, but they don't themselves directly receive the budget for care. Scotland has a similar makeup with territorial NHS boards, social care held by local authorities. It has integration authorities which connect the local authorities and the NHS boards, and they do hold budgets and direct the procurement of services from the other two, although a strong proportion of the responsibility for planning, funding and running services still rests on the two sides separated off. And lastly, Northern Ireland. Northern Ireland is different to the other countries in that it's had structurally integrated health and social care since the 1970s. Both are held by health and social care trusts, which cover 5 different areas of the region. Around those, there have been a sequence of initiatives to try to provide more integrated care, even within a context where the same provider holds health and social care. You can see here a partially reformed system, and I know you've heard a bit this week about further changes being made, with integrated care partnerships assisting in that process. So to summarise, before I pass to Camille to talk in more depth about why and how the reforms that created some of those integration bodies came about, key similarities and differences. All the countries have a nationally funded health service which is largely free at the point of use, paid for by national taxation, which is largely at a UK level. All the countries have a much less comprehensive publicly funded social care offer. Northern Ireland is unique in that health and social care are structurally united, but everywhere else, social care is run by local authorities and health is run from central government. And England is unique in that it has autonomous providers, an attempt to have a competitive market inside its state-run healthcare system, with purchasers who are separate from the bodies delivering care. And I think the last important context to bear in mind is that all countries are currently experiencing very serious problems with waiting times and financial control, particularly following COVID-19. So I'm now going to hand over to Camille Ung, who is a fellow at the Nuffield Trust specialising in social care, to describe how we understood the large number of reform initiatives to create better integrated care across these countries.
Thanks, Mark. And sorry, we're doing a bit of a hokey-cokey between ourselves and the podium. The clicker. Thank you very much. Yes, so part of the work that we did was looking across the policy initiatives that were developed across the UK, policymakers in the last 20 years, so since devolution, to really learn from this natural experiment of the 4 UK countries having similar but slightly different approaches, slightly different health and care systems. So the main of our study goes up to goes up to 2021, but there have been some changes and tweaks since then. We've discussed some of them across the conference. So we've talked a little bit about the changes going on across Northern Ireland, and we'll hear more from Wales shortly. But I think what's really key here is that there were almost 70 major initiatives developed across the UK in the last 20 years, which really highlights how much of a big and consistent focused integration has been across the UK. A lot of these initiatives have overlapped, so we won't be talking to all of them today, such as the vanguards and pioneers in England that were about 10 years ago. But I think it makes it very difficult to outline some of or discern some of the impact that each of these overlapping, consistent initiatives has had over the last 20 years. And although the 4 countries have implemented integration policies that are different at different times and to different extents, they've really shared some broadly shared ambitions and broadly shared aims. So we've broken these down into kind of 3 main buckets, and again, we've heard a lot of this across the last 2 days of the conference. So firstly, improved experience, so for patients, for people drawing on care, as well as improved quality. Efficiency across the system, so a better use of resources, reduced dependency on the acute sector, cost savings, those sorts of things. And then finally, the big one around population outcomes, such as prevention, reduced inequalities, and improved population health. And I think it's fair to say there's been some really big buy-in for some of these big integrated care reforms. We heard yesterday from Rafa Bengoa about the Northern Ireland approach and how much of that buy-in has really been supported across the health and care sector. And that's really set a tone for really strengthening the integrated approach across the UK. It's also worth noting for context, I think, that there's been general population health improvements across the UK in the last 20 years, really irrespective of integration policy. And so it's kind of been hard to tell how much of those improvements have been linked to wider population health measures rather than integration of itself. So what we found in our policy analysis of the kind of 4 UK countries is that all of the countries have drawn on 4 main national levers to drive integration across their 20 years of initiatives. So structural reorganisation is probably the most common one, so where policy makers have sought to bring together different partners under joint governance structures, and increasingly in the UK these have had a statutory status and a greater share of responsibility. Integrated finances have also been a main feature, so for instance by pooling or by aligning budgets. So for instance in England under the Better Care Fund we've had some quite major integrated finance arrangements. And then we've also had things like transformational funding, so not consistently but to invest upfront into measures to support the integration process, so multidisciplinary teams, integrated commissioning, those sorts of things. And then finally through performance management, so setting measures or targets for the system to move towards and assess any improvements. So before I hand over back to Mark again, just a quick summary slide of how this plays out currently across the 4 UK countries. So all of the 4 countries have some form of joint governance arrangement, although they do cover different sizes of populations. So, of course, in England, integrated systems cover up to 1 to 2 million people, so it's much larger than some of the other structures. And of course, as Mark mentioned, we have health and social care trusts in Northern Ireland that are fully integrated. And the other countries operate on a more of a membership basis, and there's varying degrees of statutory membership as part of that. Likewise, across the 4 countries, there are varying degrees of financial integration, with greater efforts to bring finances together and move resources out of hospital and into the community. And some have been mostly focused around certain issues, such as discharge from hospital, so the Better Care Fund in England, while others have had a broader remit around community care, such as in Scotland. Performance management has been much more limited in England compared to the other countries who relied on more national performance frameworks or programmes for government which have really set that tone. So I'll hand over back to Mark now, who will take you through some of the performance measures that we've looked at, that we were able to compare across the 4 countries of the UK to see whether we could see any impact of these integrated care initiatives.
Thanks, Cami. So yes, in order to look at whether these integrated care initiatives had achieved their aims, we went through a process of starting from the 70 initiatives that Cami mentioned, based on the full-up typology from 2005. We analysed them for themes and objectives, used that to make a long list of measures which were accurate measures of whether that they'd achieved those goals. And then, of course, had to winnow it down quite a lot to only those which could be compared across the UK countries. And the UK countries tend to use different data sources and methodologies. So we ended up with a relatively small number of measures, but fortunately it does cover many of the key dimensions through which integrated care would be expected to make a positive difference to people's health. In total, we looked across 10 measures. I'm not going to go through them all, but they were mortality, treatable mortality, emergency admissions, length of stay and delayed transfers from people leaving hospital, satisfaction with social care, access to employment for people with long-term health conditions, and inequalities in healthy life expectancy, reflecting the desire for greater equity in many of these policies. So I'm going to look at 5 here, which we've updated recently to the sort of post-COVID era. But our conclusions very much are based across that wider list. So if we start with emergency admissions, this was a really important one for many of the different initiatives in the different countries, an important part of Scotland's core suite of integration indicators, explicit goal for the different models of both provider and funding integration that we saw in England around 2015. We see little discernible trend during the period of and succeeding that sort of first wave of national integration indicators across England, Scotland and Wales shown here. So England shows essentially no trend in age standardised emergency admissions per 100,000. Scotland and Wales see, if anything, a gradual increase rather than decline. And then at the end of the period, we see the effect of COVID-19 with a sharp decrease in emergency admissions. We believe that's primarily driven by patient behaviour and capacity constraints, as you'll see a bit later in some of the other indicators, swamping any obvious effect of, that we might expect to be associated with national policy. Hospital length of stay emerges a consistent theme as well, and of course indicates to some extent whether a system can find safe, reliable capacity in the community and in social care to discharge people from hospital. Again, we broadly see little change over the sort of 7 years before the pandemic. There's a slight improvement in Wales, Scotland and England, but that's reversed when COVID-19 hits quite meaningfully. And this, I should say, actually reverses to some extent or slows an earlier trend. Before 2013, length of stay had fallen quite fast in all of the countries. So to some extent, this was a period of stagnating progress, interrupted then, sadly, by COVID-19. We saw much more meaningfully positive signs in the trend of people with a long-term condition who were able to find employment. All the countries saw an improvement up to 2019-20, quite similar across them, although you'll note the lower rates in Northern Ireland, reflecting a range of population health issues. We then see that, of course, reversed during COVID, but there is a recovery. So this is a relatively positive trend. It's important, of course, to associate this with changes in the labour market as well as within health, social care, public health. The middle of the decade was a period of high employment and low unemployment across the UK, a period of flat wages but a very tight labour market. And of course that changed as COVID-19 hit and caused economic disruption. If we look now at treatable mortality, we again see that the period from around 2012 or 2013 in fact represented something of a pause in progress. And of course there are many other factors going on here. You saw a period of lower spending by some public services, and some of the rapid improvements that in particular Northern Ireland had made as it recovered from conflict might have been expected to stop at some stage. But you certainly don't see a reduction in mortality that should have been amenable to treatment in healthcare. And again, as with length of stay, we do see that this was a period when a previous trend of things getting better appeared to level off. The last indicator that I'd like to share, because I think it sums up something quite important about maybe some of what underpins the patterns that we saw during this period, is the balance of spend. So there was often an explicit hope that social care and health integration would lead to a gradual rebalancing of spend away from healthcare, or at least hospital care, and into social care, which, as we've seen, is a service where particularly some UK countries spent really quite low amounts on. In general, that's not what we see, though. In England, social care spending as a proportion of services spending has actually fallen, and in fact it fell in real terms for much of this period. It actually went down per person, while health spending rose strongly. And we see the same pattern, less pronounced, but the same pattern in Wales. In Scotland, we see a similar growth in social care and in healthcare, implying no rebalancing, but more or less a continuation. Northern Ireland is the one exception. It does see social care rising more rapidly than health. There is maybe a bit of a caveat around that data, because it is a system where those two are structurally integrated, so there's more of a scope for possibly definitional changes. But it does seem that there should have been a redistribution from health to social care. So across these indicators overall, what we see are trends driven by a wide number of things, certainly population, economy, changes in public health, but certainly no dramatic pattern of improvement or change on the indicators we looked at. And the same broadly goes for the other indicators we looked at in our wider study. So I'm now going to hand back to Camille, who will discuss some of the lessons that we took from this exercise.
Thanks, Mark. So before I hand back to Arturo and to move us on to part B, I just wanted to summarise kind of 5 broad lessons from our work that we will be really interested to hear from in terms of the panel's own experience and their expertise of doing this in their own countries. So from the perspective of the UK, I think a lot of the integration policy has been set by national level policymakers with some very top-down levers to support integration. So things like pooled budgets or structural reorganisations such as that of the ICS recently in England, transformational funding, etc. And I think while these can help deliver some improvements to joined up services at a local level, the theory of change perhaps of how these levers on their own will lead to the improvements that integration is intended to achieve at a local level, such as improving population outcomes, creating efficiencies, that theory of change isn't exactly clear. So I think there's been an assumption that structural changes will naturally overcome existing barriers, but as we've heard a lot about the importance of culture and relationships, it's really important to make sure that those are kind of taken into the equation to overcome some of these existing kind of cultural barriers. I think one of the big challenges in England, Wales and Scotland perhaps is the different accountabilities between the NHS and social care, with local authorities being accountable to their local electorate, and having to balance their budget every year. So the context in which these different integrating partners are very different, and the structures on their own haven't perhaps been sufficient to address this. And so there's lots of on-the-ground things to discover and overcome that I think national levers can enable, but maybe not sufficient to overcome. Acute hospital trusts have really dominated still, and it's been difficult to shift funding flows, especially in the context of high demand. And this has really potentially limited some of the benefits of integration initiatives, although there has been some success around things like discharge pathways. And I think it's interesting that countries such as Scotland have been considering changing their integrated structures to reintegrate around community health and social care and remove acute from the equation. But the delays kind of really highlight how difficult it is to make some of these difficult trade-offs and decisions. And as we've seen from the indicators that Mark outlined, it's very difficult to see any immediate big change or impact directly linked to those initiatives, at least in the measures that we've been looking at. And I think it's been very difficult for us as researchers to measure integrated care. So things like footprints have changed, the outcomes might not have the right data and might be difficult to quantify. The data might not exist. You can't exclude other confounders. And in many cases, there's also this interesting phenomenon that integration might lead to some improvement. So for instance, identifying unmet need, but that might then not lead to cost efficiencies because you're picking up people who otherwise wouldn't have been picked up by the system. So it's really hard to see really what the impact of what's going on. And so our kind of takeaway was that it was really important to have realistic objectives around what integration can achieve. And the evidence base to date, I think, suggests that integration at a national level can have a greater potential for, impact on patient and person experience. But cost efficiencies, I think, needs to still be demonstrated, at least to be able to look at it from a national level. So we need to be careful not to measure the wrong thing. But yeah, some interesting challenges, I think, that will be good to hear from about the panel. Thank you.
Thank you very much. Very interesting. We've got questions coming in from Q&A. Thanks very much. And we've got 2 minutes before we move to part B. And actually, I was thinking, I don't know, the last slide, if we can put it back. No, we're changing, no worries. Because if you retain that slide, guys, that's something that I might want to come back to that. To you, because those things that we had there is probably what we are going to reflect now. But is there any burning question that we've got in the, from the audience right now? Neus, if you, just in case we've got anybody, please, there's somebody there, so we can take a couple of questions before we move to part B. So yes, thank you. There was this lady here as well. No, that's fine, no worries.
Good afternoon. I'm Mike Emery from Wales. I suppose it's just a reflection. I was sort of interested in the study around. So, did anything come out about that power imbalance then when we look at integration between acutes and community side of things? Do we think that we're likely to be more successful if we take acute and secondary care out of the whole policy space? I've worked in both the English and Welsh systems, and it's fascinating to me, despite bringing together integration into one structure, we still end up focusing very hard on that acute centre. Just an observation, part question.
Yeah, that's a very interesting observation. I think thinking back to this period, it is interesting to reflect one of the reasons that acute care did tend to be part of all of these, and that was really that there was a hope that integrated care on this model could deliver savings to acute care, and they could be cycled out into community care and into social care, and so that you would sort of almost redistribute funding with the consent, if you like, of the acute sector, with direct benefits coming to it. And I think that's proven to be quite challenging. And many of the metrics that we looked at, which reflected the emphasis that we got from those policy documents, were particularly ones in exactly that area of, is it actually cutting your number of emergency admissions? Is it reducing your bed days? And so, yeah, perhaps the logic for including acute care on the grounds that it's where the money is weaker if it isn't being freed up in that way. At the same time, obviously, reality does remain that it is where the money is. And so leaving it out, in a sense, just passes on the quite difficult task of who decides where to prioritize resources.
Very good. I think I saw a hand here, this lady. Thank you.
Thank you for that. I know you have a limited amount of time, of course, for the presentation. I'm assuming you did measure satisfaction with social care. It was one of your few indicators from an individual perspective, from a more micro sense. Do you want to tell us a bit about that? About the levels of satisfaction? If you can.
Yes, so we have, in fact, we can point you to our report afterwards, which has that the graph that looks at satisfaction. I think it was quite hard to measure because across the 4 countries, the ways in which satisfaction are measured are different. One of the things that we also publish as the Nuffield Trust is our British Social Attitude Survey, so that doesn't include Northern Ireland, but it does look at satisfaction with social care over the last 40 years or so, is it? And it's been really quite stark how much social care has decreased in terms of satisfaction in recent years, and I think it's become much more of a political topic. Mark, I don't know if you want to add anything to that.
Fantastic. So, do you have any other questions?
I do. Yeah, oh, there you go. I do. I'm going to be really ambitious. I'm sorry. In terms of are we measuring the right thing or not? And I know it's really complex. I know the UK has done a lot of work on defining person-centered coordinated care through the National Voices Coalition. I'm not sure if that's the right term. Is that something you've considered, that maybe it could be a good measure, sort of like asking people to use that definition to rank or something?
Yeah, it very much was, and we looked for various patient experience measures. But unfortunately, as you say, while a lot of work has been done on that, it's relatively recent. And of course, we had a criteria of comparability across the countries, which really gets, even the social care question we used, the wording was slightly different, but it was okay. But to compare in that way, you'd need quite consistent wording for what people were being asked in any sort of survey-based data. So it was a challenging one to measure. I think we certainly did find, when we looked at the literature for this project, some evidence that it might have been a good thing to measure, because there is a strong body of evidence that integrated care initiatives, at least on an operational level, can certainly improve that. But it wasn't necessarily as overwhelmingly prominent as you might think in policy literature at the time, and unfortunately we weren't really able to find a strong comparable metric for it.
Thank you. I know you have burning questions, but let me move to part B. But if you send these, your question through Q&A, I promise I'm going to take this, and the proof of that is that I want to read one question that has come through the Q&A, which says, I represent the municipality of Athens, welcome, which is about to start an IC project, integrated care project, with national funding. What is your advice regarding the key points we should focus on for designing and implementation? And this is exactly what we are going to do in part B. So I'm going to invite Joan Carles Contel from Catalonia. They've been in this journey towards integrated care. So they are going to reflect, and while he's going to speak, so just remember that last slide, because it's there. So the evidence is telling us what is missing, what's not missing. And then the question is, these guys who have been on this journey for a while, if they, what do you need if you need something? If you look back, like 10 years ago, 5 years ago, right?
Thank you. Well, Fray, Arturo, I think we have 10 minutes to explain about the history of our long journey. I think we are in the journey, we are in the middle, because we expect to have more time to achieve this kind of things. No? I think I want to explain the main features. We have structured our presentation in 3 parts. No? The first part, it is about how we started in this kind of journey. But first of all, I would like to explain about which is the situation in Catalonia. It's the main features about the situation in Catalonia. You could see here, we have 1 million inhabitants. We have own competences. In health and social care, we have the possibility to organize, we have some kind of devolution with competence to organize the services in Catalonia, separate functions as in England, between the commissioning, purchasing from provision. The access to social care is means tested, and we have variable types of co-payment by the users. And we don't have, or it's not complete, aligned boundaries, the coterminus, of boundaries between health and social care services. In most of the cases, it's very similar, but it's not exactly the same. That is the situation we have in our country. But I want to start. When we have started with this journey, I think it was very important, the situation we had and we have in Catalonia. We have a very intensive process of aging in Catalonia. You could see in the middle of the century, we will have about 1/3 of the population over 65 and over 12% of the population over 80. Another important thing is when we have started 12 years ago, we tried to start with some kind of unique disease management, but we have changed very quickly into a new case management or care management orientation, especially for people with multimorbidity and people with complex needs. I think most of the cases you have people with heart failure, COPD. We have noticed most of these kind of people, they have different kind of chronic conditions, and we feel very comfortable with this kind of multimorbidity and complex care. Another important thing is we have introduced, within complex care, some kind of identification of the people with advanced chronic disease to introduce some kind of palliative care orientation. I think some kind of first transition of palliative care for this kind of population. I think it's very interesting because we have the possibility to seek and to register in the clinical record this condition of complex needs and the condition of advanced chronic disease. I think it was very important. Another important thing, it's not an advantage, it's on the contrary. We have 5 elections in 12 years. I think the time we dedicate to explain our narrative to the new politicians, I think it's very exhausting. And we have a new election in 2 weeks. I think it's very exhausting process to explain a lot of times the same. But on the contrary, we have a team of professionals, a stable team of professionals working at the Department of Health. We are called the assemblers. We are trying. It doesn't matter the politicians. I think it's very important to have an agenda of chronic and integrated care and to maintain this kind of agenda. Another important thing is if you have well-developed primary health care, I think it's very important because primary health care, especially for identifying and caring for people with multi-chronic conditions, I think it's a very important approach. And I think it's very important if you have a solid primary health care, you have a good advantage to work with this kind of populations. Another thing is we have noticed the importance to identify not only the clinical complexity, but also the social complexity. We have started little by little, but now at this moment we have some kind of operational way to identify this kind of social complexity. I think it's very interesting because when you are identifying people with health, both health and social care needs and complexity, I think it's very important to identify and to make proactive management with this kind of population. Another important thing is to involve on board the clinical and the professional leadership, and especially the clinical and professional leadership within primary health care. I think we are trying, the professionals working in primary health care, make good orientation to this kind of care management for this kind of populations, and we have introduced per every one case manager working in primary health care together with the primary health team for maybe 20,000 or maybe 30,000 inhabitants. Another thing is about the care pathways, especially for complex people. We have some kind of agreements at local level, at county level, with the hospital, intermediate care, and primary health care, to make some kind of agreements what to do in case of crisis, what to do in case of transitional care, and we have local agreements about these kind of things. Another important thing, it is about the IT developments. From the very beginning, we have tried to identify these kind of people in the clinical record, because in Catalonia, we have a unique clinical record in primary health care. It's possible to identify and register the people who has complex needs, and I think it's possible to put. And you could see on the left some kind of customized viewer of the situation of the person with complex needs. You have all the utilization of services, hospital, emergency care, different kind of things, and the multidimensional assessment, the different kind of domains related to functional, cognitive, nutritional, and social assessment of this kind of people. When you have a complex people and you think this person is a complex people, I think it's possible to put this kind of viewer and all the professionals, including the people working in the emergency care, in the hospitals, could see this kind of picture. The same with the kind of algorithms. As we have a unique primary care record, I think it's possible to have all the information of primary care, and we are adding integrated information from hospital, intermediate care, and we have the possibility to have all the information aggregate, and we have some kind of homemade algorithm named GMEA. It's some kind of multi-morbidity grouper, and we have the possibility to make a national stratification of all the population of Catalonia and offer this information in the clinical record for every general practitioner and community news. The same with some kind of a strategy relating to make a consensus on the multidimensional joint assessment. And another important thing we have developed some months ago about to have some kind of frailty rapid assessment, related to make a rapid assessment, maybe in 8 minutes, related to the situation of the people with frailty. I think it's some kind of tools. We have developed and validated these kind of tools, and we have introduced these kind of tools within the clinical record to use by the clinicians in primary health care. Another important thing is related to the indicators. As we have all the information aggregated, we have a unique database from primary health care, hospital, intermediate care, mental health, and emergency care. It's possible to have population-based indicators related to utilization of services. For example, it's possible, if we have almost 400 primary health centers, it's possible to calculate the rate of emergency admissions, not only for our Catalonia, but also per every primary health center. And it's possible, this kind of information, to offer this information to the director of the primary health center. I think it's very interesting because we have indicators related to complexity, the people who is in home care, and the people who is in residential care. Different kind of things we are now. Where are we now? Yes, we have the agenda of vertical integration between secondary care and primary health care, but we are reinforcing this kind of integrated care with social care. We have an agenda now to create an agency of integrated care. This kind of agency of integrated care is not a third department. It's an instrument, to have instruments and tools to drive integrated care in terms of financing, in terms of, for example, governance or IT solutions, ICT solutions. And I think it has been approved by the government, and we are waiting for the approval of the Parliament. I think in the next session, in the next term, it will be approved by the government. And practical things. For example, you could see here when we are implementing integrated care in home care or integrated care in residential homes, we have some kind of checklist, and very practical checklist. When you are going to the territories, to the counties, I think you are checking the different key elements related to this kind of integrated care. Or for example, offering, not only having at national level these kind of indicators, but we are delivering and offering these kind of indicators. For example, there are indicators related to residential care. I think it's possible to have these kind of indicators in a population base available for the managers and the commissioning health authorities working at community level, at county level. Okay, 1 minute. Okay. A very interesting thing is the problem we have. We are trying to share information among health providers. I think it's easy. We have a national joint or shared electronic health record with all the information of health, but we have some problems to introduce and incorporate this kind of information from the social care services. We have legal barriers, we have some kind of cybersecurity concerns. And I think it's very difficult, and there are very few countries in Europe with this kind of agenda. I think it's very important to have this agenda for the next month. And the last thing, it is related to work in not only internal clinical leadership, but also to drive and push some kind of system leadership. I think here in UK, I think you have good examples of this kind of training. Okay, that is the last slide. Thank you very much.
Well, we put up the slides for the Basque Country. Can I, can I ask you very quickly, just for our colleague in Athens, seeing all these tools now operating, which is the only one that you think that has been the most important, that you think that has been the real lever that has, all of them are necessary, but which one is the key one? Just choose one. You have 20 seconds, or just one word.
So?
Yeah, choose it. Choose it.
Maybe the most important thing is to involve the clinicians. For me, the most level of satisfaction is to have people and clinical leaders, professional leaders, who are trying to make the same narrative. I think to have this kind of impact in the leaders at county level, working in the same agenda and developing this kind of new narrative.
Fantastic. I think that summarizes that for our colleague in Athens, that's the key thing. Fantastic. Now, we've got somebody from the Basque Country, Orzabala, and they had elections on Sunday. So again, remember, politics is important. So please, Igor, cuando quieras.
11 minutos. Okay. Hi, everyone. Good afternoon. I'm not depending on the politics, but anyway. I'm not a director. I'm just a head of a service. So I try to tell the things from my perspective. First of all, thank you, Arturo, for having me. I should say it's a bit difficult to answer questions you made us to how to evolve in the future and so on. But I'll just give my opinions, my reflections on this. I've been all these days reflecting on that. But the facts are one thing, and the reflection is another thing. So this is the Basque Country, very small population, to more than 2 million people in North Spain. We got a universal healthcare coverage, and we are now 13 integrated care organization, full integrated organization. More than 300 primary care centers and more than 30,000 people working in the system. Just a preview, but particularly we are, just as the previous one mentioned, trying to manage particularly these patients from the upper level of the system, the high complex needs patients. We call them complex patients or multimorbid patients. So these are for us the big laboratory, in order to, whatever we do there, we may translate into the other system. So we got 75,000 people with multimorbid patients in the Basque Health Service. But from them, we just covered 25,000 people into the clinical pathway. You'll see a bit later what it means. So when we talk about integrated care, I have no data on this, but when we talk integrated care, this is our view of what integrated care means for us. What we did was change regulation, and at that time, the Basque Health Service. After a while, we saw some things that didn't work, so we worked more on pushing the primary level. we stratified the whole population in the Basque Country from the high needs for the ordinary people with no health needs. And we try to work on what is care or clinical pathways, because we see that this is the way where integrated care is fully deployed through this consensus between professionals. And if you ask our professional for them what integrated care is or means, probably most of them they will say that integrated care is a unified clinical record, because all those systems, primary and hospital level, they share all information about the patient they share, and as well they can talk to each other, professionals from both systems. And non-face-to-face strategy as well. New roles, particularly in the nursing area. Social and community are now big actors in this particular movie. They were before, and not such as they are now. The other one is citizen empowerment, which is one of the big areas we're trying to evolve and give them strength. And during these days, and particularly this morning, and sometimes we in Basque Country, we sort of create new structures. Like you see, this one, my department is one of them. Try to push and foster wherever integrated care means. And the other one is now Biosistema is Croniune, which is a foundation in order to research on, in this case, in care organizational issues in the Basque Country. So, this is our journey. Very, very quickly. This is the last picture. So, we began in 2009. This is 13 years of story. Well, this is a history, but I tell you my story on this process as well. We began with a tackle of chronicity at the time, 2009. In 2013, we saw that the best way to answer the chronicity challenge at that time was to go through integrated care. And in our setting, we solved the problem, let's say, integrated care, by two sides. One is structural integration, and the other one was clinical integration. In that road, the right side is clinical integration, and the left side is about structural integration. So in 2013, we got a plan about how to integrate our organizations, primary settings and hospital setting, into just one organization, just one board. And in 2015, all our organizations were fully integrated. What you saw in the first slide, 13 ICOs, integrated care organization. In 2018, we came up with a new, let's say, law how to manage this organization. New directorate for this new ICO organization was created. And in 2019, we went with some evaluation, let's say, how our assessment on this project was. And we saw at that time some suns and clouds, lights and darkness. So we discovered that probably in order to go further with integrated care, we should go through some changes, particularly in the primary setting. We need to work quite more in primary setting to foster the primary setting. So we stopped at that time. And in 2021, we decided to create a new, let's say, directorate in the headquarters, in the upper level of the board system in the Basque Health Service, which is the primary care directorate. And in 2024, we're working for a new strategy for this primary care setting. On the other side of the picture, this is more clinical integration, not just the structural integration. And we were with this patient I mentioned before, the 25,000 people with multimodal patients, high complex needs, and so on and so forth. So it's okay, I finished. So we went that clinical pathways with a big consensus from professionals from both health level, and we saw at that time that we got better outcomes than previous years. So we scaled it up to the whole system, but again, in 2019, we went into an evaluation process, talking with professionals and managers, and we saw that things were improving, but not as much as they're supposed to be. So again, we revisited the clinical pathway again with professionals and front professionals and managers, and we made some changes in the process in order to go on. So all the time is revisiting, renewing, changing. This is very important, with a lot of talking with professionals and managers as well. So some reflections in order to, how would you go on further in this process? I would say these 7 reflections, but the last, I think probably to me, is the best one. And some of the speakers in the previous roundtable mentioned it. Keep faith and be patient. This is a very long way. This is not happening from one day to another. But it's important, as Rafael Bengoa mentioned the first day yesterday in the morning, strength strategy at policy levels. This is key in order to transform the system from upper level. But the narrative should be very easy to understand, very easy. Otherwise, it's quite complex to carry on with it. A clear alignment among all actors to focus very well the issue. Double-side leadership from top level, but also from the bottom level, from the professional level. And planify the change management. Planify. This does not happen because of this. It needs to be planified. There is some successes and some setbacks, and that's not bad. It does not happen everywhere. So go on with that. And as well, during these sessions, is one again and again, listening to patients should be part of the process. So it's some part in this movie, and sometimes it's not. In our case, I think we should be working quite hard on that. And the other one is the last one. Keep faith. Thank you. Thank you.
Fantastic. I'm going to invite Shelley now to explain about Wales and the Welsh journey, and just to say, yeah, you need to be a believer, right? Keep faith and be patient. But thank you very much. I think this is very helpful for those of us who might be in the process. So, Shelley, sorry. Yes, you introduce yourself.
Thank you. Good afternoon, everybody. And I'm sure you're all coming towards the end of a long day and really keen to get off to the gala dinner or wherever you're going for your dinner tonight. So hopefully we can give you some really helpful insights just to finish your day off. Oh, that's not my slide. How do I get my slides up? Here we go. So I work in Welsh Government. I was just sitting here reflecting now, thinking, gosh, I joined Welsh Government in 2018, but actually I've been working in the health and social care partnership landscape for over 20 years. So the point about being patient and committed and tenacious about what you have to do, that long-term view definitely chimes with me, because it takes a long time to make the changes that you want to make, and we've still only moved about that far along the system. A little bit about Wales. So we're a small country, and we've got a population of 3.1 million people. We have 22 local authorities that run our social care system, and we have 7 health boards that offer our health system. And actually having that volume of different organisations in a country so small creates variation because everybody wants to do things their own way. One of the narratives we often hear is it's different here, but there is a question about how different can things really be in such a small space. We have a global budget of health and social care of about the 9 billion. That's the figure we kind of think when we look at all the collective resources we've got together. But we do have dedicated resources we put specifically into the integration space. So we have the £146 million of the Regional Integration Fund, and we have over £70 million that goes into capital build around developing integrated hubs. And all of that is managed through our regional partnership boards, which I'll come on to. So I was thinking about how best to present the journey we've been on, and I think it's felt like we're trying to build a jigsaw, but we've actually not had a picture of what's on the box, what is the thing we're trying to build. So we had all these ideas, thoughts, ambitions put in front of us, and then it's been a case of, so how do we now build that? And it's interesting, you know, I think if you had your time again and you started to apply a proper change methodology to something in a clear plan, you might start in a different place. But we started where we started, and this is the journey we've been on. So we started off with legislation. We set the mandate nationally. We had the the Social Services and Wellbeing Act, which set out the ambition around integration for health and social care to work together through regional partnership boards. And at the same time, we had another piece of legislation that came out in a similar space, talking about the well-being of future generations. And those two pieces of legislation really did complement each other, but there was overlap. Both created a set of partnership arrangements. So we had 7 regional partnership boards, and we had 19 public service boards that sat under the Wellbeing Future Generations Act. And we did have some tension in the system about who was looking at what, which partnership was meant to be looking at which bits of the jigsaw. And I think over time we have worked through that, and actually the system started to align itself. So we're starting to see public service boards that are on those local authority footprints starting to amalgamate of their own accord to fit with the footprints of the regional partnership boards. We've got closer relationships. So that was the mandate. We then looked at creating the structures, as I said, through the partnership boards. And then we started to look at, well, what are the systems, what are the services, how do we actually make that integration happen? And that's where we put resources into the system. So we had the Integrated Care Fund at the time, and that has now evolved into the Regional Integration Fund. But we also had a strategy in A Healthier Wales, which is a 10-year plan for developing our health and care system for the future, and there was a heavy focus on integration, and we also launched a capital fund. But in none of that did we articulate and say, and this is what it will look like, this is what you're trying to build, this is what good integration is. So we've worked through those enablers that we've got, and tested from a top-down and a bottom-up approach. So we've had the mandate from government and the structures to help us do it, but the resources at a grassroots level to test, innovate, look at ways to integrate services and bring the two together. We've had review points, and we had a first review in 2019 when we reviewed the legislation. I'm picking up the point about, from the Nuffield Trust about pool budgets. In our original legislation, we said you must pull budgets for commissioning older people's care homes. And we found through various reviews it wasn't happening, that partners weren't moving with that. So in our review in 2019, we tightened that up and pushed that even further and said these must be regional pull budgets, these footprints, you need to do this. And we still found that people weren't doing it properly. A lot of effort went into describing a process that looked like a pooled fund that really wasn't a pooled fund. So our latest review, which we did a white paper in 2021-22 and a programme of change last year with lots of engagement. We started to review some of those mechanisms. For pool budgets, we've actually decided what we needed to do was more clearly position pool budgets within the context of what they were meant to do, what they're meant to achieve. So it's about actually how we design and commission services jointly together, which pool budgets may or may not be a tool to use. So we've offered some greater flexibility now for partnerships within that, in the hope that it will make more sense to them. We also asked the question about, should our regional partnership boards become a corporate legal entity in their own right? So similar to Scotland and England, where their partnership arrangements are that corporate legal identity, they can hold their own resources. We asked the question in Wales, and the response back was, no, don't do that. We think that the current arrangements are strong enough, but we just need to tighten them up to help us deliver what we want. And there's various things we've done in there to really look at the scope, clarify what it is we want regional partnership boards to do. And that's the journey we've been on there, really refining what we've already got. These are some of the messages that we've persistently had along the way, and they're really contradictory in nature at times. So we've got people saying, well, what do you mean by integration? What does good look like? What's the vision? What are you trying to achieve here? Tell us what you want it to look like. Against, well, actually, we know best locally. Don't overprescribe it. Don't tell us what to do. Our community is different and we need to do something. So there's a real tension there about how do you balance that national down mandate and leadership with that flexibility for things to look local. And I think going forward, that's what we've really tried to build into our next phases. A little bit about our structure. So we don't have an integrated health and social care system at the top, and actually our current direction of travel is almost going to reinforce that separation. So we've recently launched an NHS executive to help drive improvement in our health services, and we have a programme of work to develop a national care service for Wales. So at the top, we're not on a trajectory to connect these things together structurally. So that means that the integration, the interface has to happen through our partnerships at that regional level. So we have the 7 regional partnership boards. But underneath that now, we are now bringing primary care into the equation. It was a gap previously. We weren't connecting with them. And we've brought primary care in so that we're connecting with the local cluster arrangements. We have 60 of them in Wales to make sure that our local to regional to national thread runs both ways, and we can get that local place-based delivery within a national context. Our RPBs have the usual people you'd expect around the table, so health, social care, and it's they that have the duty to cooperate on them. The legal duties sit on the health boards and local authorities, not the partnership, because the partnership's not a legal entity in its own right. So that, I think there's pluses and minuses to that, but actually what it does do is it doesn't create the partnership as a separate thing that's responsible for integration. Actually, the health boards and local authorities themselves are responsible for this duty to cooperate and drive integration. And we also do make sure that we've got carers, citizen voices, provider voices around the table, and we've just done a programme of work to really strengthen that, because we found that carers and citizens were telling us we're struggling to get our voices heard. It's really hard in a room full of professionals to actually communicate, so making sure people are properly supported to engage with the system. And we've also done some work to really define what do we mean by integration. So if we're in a system that's not properly integrated at the top, to what extent can we really expect true integration? So we've started to recognise that this is more of a continuum, and actually there is sometimes having things that are aligned or joined up for our communities is good enough. It doesn't necessarily have to be a fully integrated approach. So that's been the other learning that we've had to try and express this more of a pathway. And then from all of that, we've really started to, and answering one of the questions earlier about what really makes the difference, actually having now narrowed our scope, being really clear, we are talking about integration in the community. So it's health and social care, third sector working together in the community. And we've created this blueprint now. So this is the blueprint that we've got, which sets our key system enablers, our models of care we want to develop, and the key population groups for whom we really want to look at active health management and positioning that within a locality place-based approach. I'm going to whiz through now because I've had my warning. So I think this is where we've got to. We've got our jigsaw now. We have got the edges and the corners there. We need to fill the middle, and that's the next drive. So the picture in the box is now going to be this blueprint, and our next programme of work is going to be really about making sure that we are taking the learning from what's best and escalating that up to scale it to a national level. that's not without challenges because people don't want to change what they've already got. And then a big piece of work looking at people and culture and leadership. So on one of my earlier slides, we talked about systems, structures and people. I think the people bit is the bit that we haven't focused in on enough. So really trying to make sure we're getting in to get that culture that is going to help us further drive this change and really embed it in. Okay.
Fantastic. Thank you very much. So it's great, well, it's great, no, but it's, I think, very reassuring to see that Wales, they've been on this journey for 10 years and they've got the pieces and they are building the puzzle. So they're still building the puzzle and things they all said that. So now we need to move quickly as collectively. So we've sent you, it's actually me from my phone. So if you check your Q&A for this session, go to your app. And then if the guys, you can put up that one. Yes, okay. But I think we need the previous slide, the one that we, no, with the link. Yeah, so it's, so you might find me in the Q&A for this session. I've said you can join our interactive voting exercise at menti.com. So you go to menti.com, you open your browser, menti.com, and enter the code 4127648. Shall I repeat? Yeah. Is everybody in menti.com already? Yes? Oh, fantastic. So 41227648. Right? And what this app is going to allow us to do is to vote, and then we continue the conversation from there, because what we've done is that first question, which is how confident are you in these approaches to overcoming barriers to integration? So we'll start with the barriers then. We've selected these from the research. We've heard that how you've overcome those barriers, but you are struggling with those barriers, so you've introduced tools to overcome that. And so I want guys, if you start voting, and yeah.
Yeah, I think it's quite interesting how, so we've added a few as our experts were talking, and particularly I think hearing from Juan Carlos on the importance of data interoperability, which seems to be doing quite well. Well, things are moving quite a lot, actually. I don't know if the panel perhaps have some thoughts on some of the things that really make the most difference, but I think it's also interesting, I think we've had throughout the conference really the theme about the importance of co-producing approaches and bringing in people's perspectives and voice, the voice of carers, the voice of people who draw on care, the voice of patients, and I think that seems to be doing as well as one of those things that is really driving.
I think it's interesting that, as we highlighted in our presentation, the generation of UK, integration initiatives that we looked at put a lot of weight on shared budgets and shared governance structures, and they're maybe not doing so well up there, and that might reflect that perhaps people are developing an interest in steps closer to the front line rather than those more abstract structural things that are meant to bring them about.
That one work? Yeah. I mean, what's really interesting, there's not a lot between them all, is there? There's no sort of huge polarisation. I think that's because they're all really important. And that's the learning I've been on. We've started in one place in Wales, but actually we're having to plug the gaps now of the things we neglected early on. And really you have to pay attention to all of these things if you're trying to develop an integrated system. I think the shared budget's probably, for me, is the lowest, and yet that's one of the places we started. And all the advice that we had from our delivery partners was you started in the wrong place with some of that, particularly the subject matter that we attach those pool budgets to. I think for pool budgets to work, or shared resources to work, they have to be set within a purpose. Why is that going to make a difference? And I think if you're able to do that, then people will come on that journey. but at times it's been really difficult to articulate what is the benefit. We do have really good examples of shared budgets in things like community equipment stores, so where health and social care partners absolutely will invest together to make sure they've got the equipment out there in the community, and they will do that. But then in other places where it's much greater risk, it's harder to persuade them to do that sharing of resources.
Yeah, I mentioned in the presentation that in the Basque Country, the health record, the system information is absolutely key. They work, for them, this is the integration, the clinical record system information. And the other one is the professional leadership as well. We've seen in this long journey is that something that coming from the structural level or sometimes even a policy level, if professionals are not engaged by themselves in all these changes, probably you make a lot of efforts or budgeting on something, but the professionals and the leadership is absolutely important in order to shift a bit the system. But don't forget as well all professionals are important, but as well the first one, let's say co-creation or collaboration with all social agents as well is absolutely important in order to, it's not just health system, not just about working together, hospital and primary level. It's about that, but it's quite more complex than that.
Two things about the most important barriers, about interoperability. I think it's very important to think about this kind of issue. I think it's very important, for example, in the case of Spain, in most of the regions, we have a unique primary healthcare record. I think it's very important because you have a very good basis where you could integrate different kind of layers of information. I think, for example, in Catalonia, we have 80% of the primary healthcare related to a unique system, but we have progress from 80% till 100%. I think it's very important because it's a very good example to have a good basis of information not to exchange and to share between different kind of providers. Another important thing is to exchange information between health and social care. I have mentioned before, in the case of social care, the level of maturity of the records, of the electronic records, I think it's very different. I think in the case of electronic social care records, in most of the cases, people are working or professionals are working with paper. I think you should introduce this kind of electronic social care record and also to standardize and harmonize the social care problems. For example, in the case of the health problems, we are using ICD-10, for example. You have some kind of international codification of health problems. But in the case of the social care problems, we don't have any kind of international codification of social care problems. I think there is a lot of work to make to structurate and harmonize this kind of information and after to make interoperability between the systems.
I would like to add, this is not in the screen, but I would like to mention how important is where the consensus between professionals trying to work with patients and manage patients, particularly in chronic diseases. And it's not on the screen, but I would say that all about care pathways and clinical pathways is as well absolutely key, because it's the place where professionals put all the efforts in order to manage patients and diseases, particularly chronic diseases.
Is there any question? Anybody wants to join? Are you happy with this picture? I think we've stopped now, voting at 35, yeah? Next one, hopefully it's going to be quicker. So, yeah. Take that microphone, fantastic. Because we are going to do a second question, so we can close this one.
A few of you have mentioned that providers and professionals are important in integrated care and change. I'm just wondering how they've been included in the journey, because I'm a provider and I do, but my colleagues don't speak the language of integrated care, of administration, of healthcare planning, right? So how do you explain integration and what you're trying to do in the system to the frontline provider who actually is doing something totally different in the clinical world and is not really, it's not resonating to them what integrated care means.
I think that's a really interesting question. It has been really difficult. One of the more recent analogies I've been using for the work we're doing in partnerships is that actually they need to be viewed as an iceberg. So the small number of people we have around the table are not it. They are just the representatives, and all the organisations and communities they represent have to be brought on this journey with us. And that is one of the next phase we're really looking at. How do we make sure that we do that? We do have provider representatives around the Regional Partnership Board table, so they have seats as well. We've recently just added primary care providers to that because it was a gap, and the Wales Ambulance Service Trust as well has been added. But we also have third sector and private sector representatives and housing social landlords. So they are represented, but they've got their own challenges in connecting that back. I'm hoping now we've got a clearer vision. It's clear what we're hoping to build, what the parameters are in that community space. It's going to be easier for us to communicate that and take them with us. I think one of the advantages we have got in Wales, though, because of our size, compared to perhaps some of the other UK nations, we are closer to the people we serve, the communities and the organisations we work with. So I can remember a meeting not long back. I went with the minister who met with the UK Social Care Providers Forum, to which the English providers were kind of said, we're really envious of our Welsh colleagues because you've got that close relationship. You're regularly in dialogue with your decision makers, your ministers, in a way that they aren't able to do over the border. So there is something about small being beautiful sometimes.
That's a good question and difficult answer, probably. You have to communicate or let them know what is integrated care and what it is for, and how to involve those people in some, let's say, decisions and managing system and so on. In the VAS system, in this integrated care, we got some act or some normative in order to be the professionals have the representation on those decisions in the integrated care organizations. And as well, there's a commission where the population and the council are involved in some decisions in the geographical area. If you are asking me, does it work in some states or not, that's another question. Probably not as well as it should be, but we're trying to make it more dynamic in order to get more answers. And the other one is how do you promote to be the citizen, the neighborhoods involved in all these actions and to know what else it's about. There's another challenge, and probably for next year, maybe we come with an answer.
Let me move to the next question because I can see that people are voting. We've got here 29 and then 77 responses. Oh, right. So we've got a, okay. So this is the second question. You're already voting. Shall we give like 5 seconds so people stop voting, because then it keeps moving and we don't know, yeah? Yeah, shall we stop there? Fantastic. So guys, do you want to react to what you are seeing, which is the results from this voting?
Yeah, and I think it really echoes what some of the panel have been discussing about kind of creating. I think there's some interesting ones about shared, shared perspective, shared purpose, and really driven, I think, by person-centered approaches, by better patient experiences, by better people experiences, and aligned with that as well, efficiency and quality. And I think it really feels to me like from some of the discussion that we've been having today, it's really important to make sure that those are the driving factors, the driving shared ambitions that are happening, and being realistic from a policy level about what we can do at a national level, if anything, to make sure that at a local level, these sort of ambitions, these aims are reflected and shared across all different professions that are involved.
Maybe my reflection related to this kind of answers, I think I feel very comfortable with the idea of triple aim, or quadruple aim or maybe quintuple aim. No? I think we have different kind of versions. I think you have some kind of balance, no? Between efficiency, person-centered care. I think it's very important to introduce some kind of measures. We are talking about the PREMS, no? the patient or person-reported experience outcomes, but we have very few measures related to these kind of things. I think it's very important to introduce this kind of measure related to this kind of dimension. Another, it is about quality of care and maybe equity and maybe the quality of the satisfaction of the professionals working with integrated care. I think that maybe the correct answer is the balance between the different kind of dimensions you should assess in integrated care.
Yeah, of course. Yeah.
There are many manager or people from managerial areas here in the room. Efficiency at the end of the day is how costs are involved in the process. But you know this, not this particular event here in Belfast, but the previous before, we always talking about person-centered care and whatever. But as I see here, it's not the first one. Even that we could add in some other expression, but efficiency is quite in the front line. I would be surprised. Maybe I'm quite romantic, and I thought that it would be more person-centered care anyway.
I totally agree. I have to say personally that I'm very, I'm not going to say disappointed, but to see efficiency so centrally, it has. But that's absolutely fine. That's how we feel integrated care is. Any other reflections, Shirley?
Yeah, just the last one from me. It's really interesting that, when you think about how you connect people to this agenda, integration is hard work, it's a change. People are going to ask themselves, what's in it for me? Why am I going to put time and effort into this? So I think to articulate the change that's needed to take people with you, you have to satisfy that for them. So what will it mean for service users? What's in it for you? What will it mean for operational services and delivery staff? And what will it mean for your organisation? And you've kind of got all of them covered off there, So it's just really interesting that those aims are spread across all of those three domains. So you've got better outcomes for people, which is what the individual wants. Being able to work in a person-centered way, that's what we know our workforce wants to be able to do. And efficiency, that's absolutely what our organisations want, so that they can manage the challenging resources situation that they've got.
We've got 1 minute. Yeah, yeah, actually that's interesting. So more than a question, would anybody close down the session with a reflection? More, not really a question, but a reflection on this. Yeah, okay, happy to. Not always here the panels have to close the sessions. I think it's going to be nice that we've done it collectively, so please, go ahead.
I won't close it, but the reflection is you're disappointed on efficiency. And one slide before, in the execution strategies. In the execution strategies, one thing I think was missing is the integrated business case. So what's the win-win of the different parties involved? And I think this is one of the key challenges we have to figure out in practice. So how does this look like? How does it work? Because it won't change overnight without neglecting efficiency. It's important in practice, and it should be addressed also in the execution strategies. At least that's my perspective.
Fantastic. Thank you very much. We are on a journey. That's what we are learning. Yes, we are at this moment. We see this. We have to juggle with all the elements, and we've got a lot of tools. We've seen these 3 countries, a lot of tools. Next time Nuffield Trust does another study, hopefully we're going to get better results. So thank you very much to everybody for being here until 6 o'clock. And please, if you join me in a round of applause to the whole panelists. Thank you.
Thank you.